chief guest to inaugurate this webinar, Dr. T.S. Surendran, Vice Chairman of Shankar Nethralaya. I'll just share my screen now. And
you can also share everything, Mohan.
No problem, boss.
I'm telling happiness, man.
This we have called it as an SN Alumni E-Connect Panophthalmic webinar. We are the blessed few who have gone through the corridors of this great institute, Shankar Nethralaya, and we owe it to our Guru and all the consultants of Shankar Nethralaya and the Temple of the Eye for making us what we are today. We have the blessings of our Gurus, Chief and Madam today, and we hope to do well in the future also with their blessings. I'm sure in the challenging times, we need their blessings in abundance. The chief guest of today's program is none other than Dr. T.S. Surendran, who does not require any introduction. The man who has served as the president of the Establishment Society of India, received several prestigious awards, including the Colonel Rangachari Award and Best Doctor Award for the year 2011 from Government of Tamil Nadu, Excellence Award from the Establishment Society of India in 2012, and many other awards as well. More importantly, Dr. TSS is the person who is the pillar of the alumni. You would say all the alumni meetings, he is always there. A person who is so humorous. Very rarely we see a combination of a person who has got fantastic patient, interaction, communication, a good surgeon, good clinician, good academician, good researcher, and above all, a fantastic human being. Dr. TSS, as you all know, is the main, the pillar of Shankar Nethralaya, and presently the Vice Chairman and Director of the Pediatric Ophthalmology Department of Shankar Nethralaya. I request Dr. TSS to inaugurate this symposium and also say a few words.
And he also was our immediate past president of our alumni.
Yes, sir. Dr. TSS, sir, all yours. Dr. TSS, sir.
Unmute, sir. Unmute.
Please unmute, sir.
Unmute.
Sai, yeah.
Good evening, my children. Now am I audible?
Yes, sir.
Okay, good evening, my children. Thanks for all the sentiments, Dr. Mohan. I think with the possibility of this Chennai Super Kings, Mohan Rajan, Jay Biswas and Partho, this meeting would not have been possible. Kudos to all the three of you. And you already welcomed and also mentioned about the mentor. And both of them are doing well. I think last week I spoke to Dr. Vasanthi. She was inquiring about some board meeting. And she told that Badrinath is able to talk, especially in the morning hours. That's a good this thing for to share with all of you. And Shankar Nethralaya alumni, as you know, I think started in 1989 at Shrenak Shah House, where Chandran, very few of us were there. And I'm happy to share that I was present in that meeting. I was instrumental in starting this alumni. And I'm not an alumni as such. I'm part of Shankar Nethralaya, but I think part of alumni also. And I think it's very nice to see all of you and expect the academic feast, I would say, and celebrating our Deputy Director, Pediatric Ophthalmology, Dr. Sumita's birthday today. I was the first to wish her in the morning. I'm sure she will recollect. And I'll just end with a joke. Always, I think Morgan also told humorous. Yes. So I'll tell some joke about Thai. I mentioned it once. I was taking the international president of the Lions to the free section of the hospital when I was the medical director with a team of people all wearing tie. And one Munsami from Kanjipuram or someplace, he just told, I think, you fellows are walking here and there with langoti in your neck. Langoti is common. I don't know whether you are aware. Langoti with in the neck and walking here and there. I've been waiting for 3 hours in this wretched sun. And this is the comment he passed, and I threw off the tie that day. I just made arrangements to see that patient, made him comfortable, gave him tea, and then he was looked after. Because more than 100 patients had come that day, and this Lions big team, 20 people came that day. So with that joke, there is no claps, I think. I would,
Yes, sir. I can hear my clap, sir.
because some joke will come. I have a lot of jokes, but I think I'll restrict, and I don't want to enter into the academics part. Wishing you all the very best. Love to everybody. Stay safe. Thank you.
Thank you.
Thank you very much for the words of wisdom, sir. I know you are a great support for our alumni. Whenever we approach you, you are always there with a solution to our problems. And I always, cherish our association with you, sir. And we go on to the introduction of the chairman. And Rajiv, can you just share your slide, or you want me to share?
Yeah, I just shared. Can you see the slide, sir?
Yes, we can see.
And can you hear me too? Yeah.
Yes.
Yes, we can hear you.
So it's my real pleasure to introduce Professor Natarajan. I would say true leader. I don't think any society I know where he has not been a president. So he's been president for every known societies, and we all know him as so energetic. 36 years experience, 60,000 surgeries, and full of energy. And I always say that from Dharavi to US, everywhere we see him, it may be a Dharavi model or the awards which he has received in US. I think his presence itself builds energy all around us. Welcome, Dr. Natarajan.
Thank you.
Yeah,
I request you to just say a few words.
Mohan?
Yeah,
Mohan?
I will introduce Kerobi, and then Natarajan and Kerobi can say a few words.
Sure,
Okay.
sure.
Okay,
Yeah.
okay.
Can you stop sharing? Okay.
You can.
Yeah, I can take it from here.
Yeah.
Yeah, Kerobi is the the darling of the Shankar Netralaya, I would say, because she was doing fellowship along with us, and Kerobi is a top ophthalmologist in Bombay now. She takes care of the Bombay hospital, and I'm not sure whether that's a correct date of birth, 1958, but Kerobi looks much younger than what she is, and always full of energy, full of enthusiasm. And Kerobi is such a lovely person to move with. And she's at present the associate professor of ophthalmology. More importantly, she has become the main person for the ROP work as far as India. I think she's the international ambassador for the ROP as far as India is concerned. And apart from the several positions she has held, Kerobi, I think, is one of the leading lights of Shankar Netralaya alumni. And welcome, Kerobi, as a co-chairperson. Now I request Dr. Natarajan and Dr. Kerobi to say a few words, and then we will move on to the moderators and then to the panelists as well.
Nati,
Sure.
would like to say something first?
Yeah, I'll say something. Thank you, Kerobi. And you taught me how to lead a woman in a dance. So I have to lead now the alumni also. Rajiv, can I share the screen for a minute?
Please, sir.
So thanks to the Saravanan from ADP. I told him yesterday that I wanted some old photographs. I'm glad he assured. Can you see the screen?
Yes.
Yes.
So I don't know. JB will identify. JB is readily saying yes. You can see Dr. Manju Kulkarni, Dr. Badrinath, Dr. Mr. Vaidyanathan, Dr. Bhaskar, everybody, I think. And this is there. The PPT is Dr. Surendran sir. It is there. And Rajiv, you can ask him probably to circulate to all the alumni. And this is again, you can see Dr. Jovanovich and his wife, Dr. T.N. Mursekar. You can see Dr. Gopal with the black beard and the white hair, which helped me as a consultant. We work together. You can see Sujata here next to Surendran, and Kalpana here, Dr. Chandran, Tarun Sharma here. Where is Dr. Mary here? Mithul Bhatt. Mohan, you're here. Somewhere, always you're looking somewhere, man. And next to KVR, and you can see Ramurthy here.
Yeah.
And poor
Can you make it fast because we don't have time,
Okay.
Nati?
Okay,
Yeah,
and this is Madam and Chief, and you can see the garland. We were holding it, and that's again, I think, whichever function, I don't remember. Anyway, this is with the Chief's favorite in the Indo-Israel meet, and that Dr. Surendran there with Mohan. And yeah, I'm just running through. This is just to say I wanted all the slides of alumni. That's all. I'm just
Very nice, very nice.
Last 30 years. So it is there. I think you can probably circulate. Rajiv, you can do that.
I'll do that.
Do that, we'll do that.
Right. Thank you.
Thank you,
Yeah,
thank you, Nati, for the...
Kale, you can start. Thank you very much. And thank you, Mohan, for allowing me to continue as president. Thank you.
You're
Nati.
eternal president for us.
Thank you, Nati. In this whole scenario, everybody's introducing everybody. Only Mohan is left to be introduced. So let me introduce a person who needs no introduction. He's somebody who's so well known to just everyone in the world, I think, not only in ophthalmology. And he is, I think he should be named as Mohan Humor, because he's one of the best entertainers in the whole country, and he has won so many of these OPLs. So after aqueous humor and vitreous humor, it is Mohan Humor which should become popular, and always remain that way. Your positivity is very infectious. Your jokes are too funny, and we just love you.
Thank you so much, Karan. Yeah, and thanks Nati and Kerobi for the nice words. I would like to share the screen again. You
have to share still, Mohan. Yes.
Has come.
Yeah. Nati, we have seen. Kerobi, we have seen. Mohan, we have seen.
No. I have to tell something, sir. Go one slide back. So the Sutradhar of the program, the man of passion, I think already been introduced. But I think there are a lot of things about Dr. Mohan which is unsaid. And besides the humor, he has taken all the four arms of Shankar Nethralaya and replicated it in Chennai itself. The patient care, community care, research, and academics. I think that's something which I just wanted to add that. Thank you.
Thank you, Rajiv, for your nice, always, we really cherish our association with you and your programs at our hospital. Your lectures are really fantastic. And let me compliment and congratulate Dr. Natarajan for the celebrating the 30 years of Aditya Jyot Eye Hospital also. It's been a big achievement as far as the Indian ophthalmology is concerned, the world ophthalmology is concerned. You should all give a big round of applause to Dr. Natarajan Nati for this. Yeah.
Thank you.
And, yeah.
Thank you.
Pleasure of introducing my co-moderator, Dr. Rajiv Raman. It doesn't require any introduction. Rajiv is much more than a clinical ophthalmologist. He is a clinical scientist, is a researcher, senior retinal surgeon at Shankar Nethralaya. He's done several pioneering work, and his pioneering work on teleophthalmology, on the recently on now of late on the artificial intelligence is something phenomenal, incredible achievement Dr. Rajiv has done. Several papers published, and above all, Rajiv is a very, very humble guy. Such an humble fellow I have not seen in my life. And Rajiv Raman is really a great guy, great addition to Shankar Nethralaya. I'm very, very happy to introduce him as a co-moderator today. Over to the program. We'll stop sharing the screen here, and then the panelists. We'll introduce the panelists one by one.
So why not you start with JB?
No, 1 minute. I'm going to start.
No, JB is JB is the backbone for science of Shankar Nethralaya alumni.
We are coming to JB a little minute. Yeah.
No, nothing there.
No, not only that. By the time we share the screen, I just want to tell JB's dream for SN alumni. He always told an alumni of Wilmer made the Wilmer resident manual, which is like a textbook, like a gospel truth for the American residents, something like that. SN alumni he wants. So I think his vision for SN alumni is somebody as a resident when he joins Shankar Nethralaya, and by the time he leaves, he should be a part of the world of ophthalmology. Rajiv is doing a great job in contributing to world science in ophthalmology, and I think Rajiv started the first publication with me, and that is still we are trying to ignite to all our juniors now. and I have several publications with Raju. And thanks for Raju for continuing the All India Ophthalmic Society
My
DR
pleasure.
drive. And so we want that. And same thing, JB. JB
Honored.
is, I think, has a maximum number of peer-reviewed publications in India. And I think maybe Namrata is near, and Dr. Amod Gupta is near, I think. But and maybe Dr. Jagatram. I think these are the 4 names comes to me. How many peer-reviewed publication, Raju, you have?
280, sir.
Okay, so little
Amazing.
more, half of JB. Mahesh is next. Okay, you're ready, Mohan.
Yeah, we're ready. We're ready with the first panelist. I request Rajiv, who has to introduce Mahesh?
Dr. Natarajan. Dr.
Natarajan
Natarajan.
has to introduce Dr. Mahesh Shanmugam.
Okay, so it's a great pleasure to introduce Mahesh, and I think Mahesh is one of the first PhD in ophthalmology, and from Shankar Nethralaya is the first PhD, and currently head of the vitreoretinal services across all Shankar Eye hospitals and ocular oncology services in Shankar Eye Hospital, Bangalore. Interests are medical retina, surgical retina, vitreoretinal surgery, ocular oncology, pediatric retinal surgery, including ROP. And I think his a great contribution out of Shankar Nethralaya is his retina meeting, which is more popular than even our Vitreoretinal Society of India. And I think to him and Avinash Patenge, he has more than 150 peer-reviewed, and all of us have to race with JB, and I think I also have similar. And even though JB and me started, and he has won the prestigious Rangachari Sivareddy Oration of All India, then Swaralata Panshe Best Research Worker, MG Bide Memorial Award, Samar Kumar Bishwas Award, presentations in national and international conference. And more than anything, I think is the most humble contributor as a vitreoretinal surgeon. And I think one of the most prolific vitreoretinal surgeon Shankar Nethralaya has produced, and where Dr. Badrinath is proud. And I remember that time once I think Dr. Badrinath was saying we should have 50 publications a year, and he and S.K. Rao were part of that team. I present you, Mahesh.
Okay. Mahesh, yeah. We have a second panelist, Dr. Girish Rao, to be introduced by Dr. Rajiv.
Yeah, Dr. Girish Rao, we all knew him as a great and a very good clinician. And last couple of years, we have also seen that he has a great management skills. So he's currently the president Medical Research Foundation and a senior consultant in my department, and a lot of things to learn, the humbleness and the skill of taking the team together. So I congratulate Girish and welcome you to this webinar.
Girish Rao is doing a wonderful job, as you rightly said, Rajiv, taking the complete what called responsibility of the Shankar Nethralaya, taking Shankar Nethralaya to a different level altogether. Thank you, Girish, for being here. And we have the next panelist, Dr. Pramod Bende, to be introduced by Dr. Kerobi. Kerobi?
Kerobi.
Dr.
Kerobi?
You are muted, I think, 1 minute.
Can you hear me now?
Yeah,
Yes,
you can hear me.
Yeah.
Please introduce Dr. Pramod.
Dr. Pramod is someone who doesn't require any introduction because he's such a well-known figure nationally and internationally. But from all this, apart from being the director of this retina services at Shankar Nethralaya, he's an excellent clinician, a surgeon, and a great friend to have. And it is this friendship which I cherish over all these years. And he's my partner in ROP, so I like him much more than for anything for that.
Thank you, Kerobi. Thank you, Pramod, for being here. I know he's a fantastic vitreoretinal surgeon, again, a very humble guy. And we have next panelist, Dr. L. Vijaya, to be introduced again by Kerobi.
Dr. Vijaya, she's my soulmate. She was somebody who was there with me. She was like kind of my heartfelt friend right from the day one of my fellowship. And it is her who has associated, even though she was a consultant at that time, I have associated myself as a friend, and she has guided me so many times through so many things. She's a great surgeon. She's a great clinician. She's very well known for all her work. But to me, she's the warmest individual that I have ever come across, warmest and the friendliest.
Absolutely. I think you hit the nail on the head. Vijaya is the most friendly, most very warm, full of warmth and love and affection. Vijaya, thank you very much for being here, Vijaya. And we have the next panelist, Dr. Vinay Nangia from Nagpur, and Dr. Natarajan will introduce Vinay.
Yes.
Nati?
Can you have the screen? The screen
It is
sharing?
there.
Yeah, it is
Yeah.
there.
Okay, 1 second. Where I can't see that.
You have any cataract, Nati?
No, man. I changed the instrument because I have to
Please
give
come.
another talk in a Brazil thing. I don't know where is in the iPad. I'm not able to see. Okay.
You don't need slide to introduce Dr.
Yeah,
Okay.
Vinay Nangia, tell about
Tell.
Vinay Nangia.
Vinay
You know
Nangia
about
was a
Vinay.
fellow, and he was a fellow in vitreoretinal surgery with us in 87. I remember we sent a maximum number of vitreoretinal papers that time. That is 9 papers and 7 were rejected. And that sort of Badrinath was dejected that time for the 88 All India Conference. And he was a consultant in retina. And then later he went to US and went and got fellowship trained in glaucoma. And he's one of the authority on glaucoma in the country and in the world. Plus, he does a lot of epidemiological work in central India.
Yeah.
He's got several publications with Just Jonas, and he's working on diabetic retinopathy and glaucoma in central India. And his publications are valid for not only for Maharashtra, but for the whole country. And I have the great pleasure in introducing Vinay Nangia.
Thank you, Vinay. Thank you, Nati, for this wonderful introduction. Vinay, as you know, is the king of Central India. Yes.
I just want to say that Nati actually trained me in doing retinal surgery, actually.
Fantastic.
Yeah.
Thank you, Vinay, for being here. We have none other than Dr. D. Ramurthy as the next panelist, past president of AAOS. I request Dr. Natarajan to do the honors.
Okay, so I'm happy to introduce Ramu. Ramu was 1 year senior to me in the fellowship. He and Gopal were doing the buckling surgery that time, and I was a consultant with Dr. Badrinath that time, and they both were doing as an alternate. And after that, I think he started first Tirupur, then Coimbatore, and then rest is history now. He's got more than 6 centers, and he has an illustrious wife who's also done partly with Dr. Surendran, Dr. Chitra Ramurthy, and then he is now both the son-in-law, daughter-in-law are ophthalmologists, and he was a great scientific committee chairman following me in 2008. We did a 6 year wonderful scientific program. He revolutionized brought from whatever I did. I'm happy that Shankarnetha Alumni ruled, and even now ruling. Again, next 6 years will be by Partha Bishwas. So as a Shankarnetha, I think we are in the helm of affairs for All India Ophthalmic Society and international. And only thing is Ramurthy, Vinay Nangia, Vijaya. Vijaya also was my fellow, and she was a fellow with me and Dr. And she, I don't know whether Vijaya remembers, she presented the first paper, Anatomy of Vitreous, in the first vitreoretinal workshop, which we did in 87, when me and Gopal were consultants that time. And later she shifted to glaucoma, Ramu shifted to cataract and refractive surgery. Mohan is almost gone to cataract refractive. So I think few of us are sticking to retina, me and Cyrus and Kero Bilari. So with this, I think Ramurthy is a great, I think he's kept up the name of Shankarnetha all over, particularly being the president of All India Ophthalmic Society.
Yeah, thank you, Nati, and thank you, Dr. Ramurthy. I consider him as a colossus as far as the Shankarnetha alumni is concerned, and he is a trendsetter. And we have none other than Sujata here, and I request Kerobi to do the honors for Sujata.
Sujata has been my friend for the last 30 years. Ever since I have joined Shankarnetha, she was doing her diploma at that time, and we were strength for each other because the number of women was very less at that point of time. So I know her since then, and she is now the executive medical director of this Rajan Eye Care Foundation. She is the best half of my friend Mohan, and I think she's held him stable through all these years. Her work is excellent and surgeries are really good. And I got interested in cornea only because of seeing some of her videos, because she showed me all about the big bubble and all, and I was really fascinated by it. So congratulations, Sujata. It's nice to know you.
Thank you, Kerobi, for the nice introduction of Dr. Sujata. Sometimes she's the bitter half for me as well as the better half for me. But she's always the best.
I don't believe you.
Yeah.
He's going to get it when he comes home.
Yeah. Keep the rolling pin ready.
We have none other than Dr. Rajesh Fogla. As you know, Rajesh Fogla is an icon as far as cornea is concerned in this part of the world. I request Dr. Rajiv to introduce Dr. Rajesh Fogla.
I think you had told an excellent thing that nobody can beat him as far as the corneal surgeries are concerned. And even during fellowship time, it was always a buzz that there are few people who are born surgeons, and Dr. Rajesh Fogla is one of them. And I am not sure, many of you may not be knowing that he's equally good in cooking, his cooking skills, and a fitness enthusiast. Dr. Rajesh, welcome to the meeting.
Thank you, Dr. Rajiv. Thank you, Dr. Rajesh. I know you are such a busy guy. You have an eye donation meeting also today, but you had the time because you have got the love and affection for Shankar Nethralaya. And then we have the Chairman Scientific Committee, Dr. Partha Biswas, my very, very good friend, and he's actually taken the Shankar Nethralaya alumni to a different level altogether. Partha Biswas, as you know, is Chairman Scientific Committee now, and he was previously the Chairman Academic and Research Committee of AOS, and he is the Director of the BBI Foundation, Kolkata. Partha Biswas has won several awards, Colonel Rangachari Award, several papers, and it's always a pleasure because he's such a nice human being and a great guy, great friend of mine, and I have the pleasure of welcoming Dr. Partha Biswas here. Partha, welcome. Is he there, Arun? Okay. No problem. We have Rashmin Gandhi, another guy, stalwart in the teaching as well as in ophthalmic education in our country is concerned. And I request Dr. Natarajan to do the honors for Rashmin Gandhi.
Yes, yes. So I'm happy to introduce Rashmin Gandhi with the shining on his head. There's a globe. So he's a FRCS Glasgow, FRCS Edinburgh. Am I audible?
Yes, you're audible.
Okay. Director Foresight Worldwide. He's ICO Fellow, Johns Hopkins University, Consultant Neuro-Ophthalmologist, Center for Sight, Visiting Professor, University of Hyderabad, Vice President, Indian Neuro-Ophthalmological Society, and ex-director of the Shankar Nethralaya Academy, and was in Shankar Nethralaya from 95 to 2013. And here with presenting Rashmin.
Thank you, Nati, and thank you, Rashmin. I think it's a truly multifaceted personality, Rashmin, and he does so much. I don't know how he's got time to do so much of work. And thank you very much, Rashmin, for being here with us.
Thank you, sir. Thank you so much.
Yeah, we have the next panelist, the doyen, as far as oculoplasty is concerned, and wife of Dr. Another top vitreoretinal surgeon, Dr. Mahesh Shanmugam, is also the panelist. Dr. Lakshmi Mahesh, Dr. Kerobi will do the honors for Dr. Lakshmi.
Dr. Lakshmi has she was there right from the time that I remember, because she came in a little late, but we've almost done our tenure together. And she has trained very ably under Dr. Nirmala Subramaniam in medical retina. And she started her full-fledged department of orbit and oculoplasty. And she's the head of the department now. And she was another person who was constantly there and a friend when she was at Shankar Nethralaya. And we remember her very fondly from that point of time now.
Thank you, Kerobi. Thank you, Lakshmi, for being here with us. And your contribution to the oculoplasty, not only oculoplasty, but also the ophthalmic education in this part of the world is really significant and remarkable as well. We have Dr. Bipasha Mukherjee, who's also heading the oculoplasty department in Shankar Nethralaya. Bipasha is also a very, very prolific oculoplastic surgeon. I request Dr. Rajiv Raman to do the honors for Bipasha.
Welcome, Dr. Bipasha. Dr. Bipasha heads the orbit oculoplasty reconstructive services at Shankar Nethralaya. And besides oculoplasty, she also has a passion for traveling, photography, a very good teacher, and their fellows, it's a very close-knit department. And all fellows, they regard her for her skills, for the way she teaches. Welcome, Bipasha.
Thank you, Rajiv.
I have the greatest pleasure of introducing the hero of today's webinar, that is Dr. J.B. Jyotirma Biswas. who is the director of the ophthalmic pathology as well as the uveitis in Shankar Nethralaya, and amazing 456 PubMed indexed publications. I think we should give a standing ovation for JB for this wonderful contribution, wonderful achievement, I would say. 65 chapters, 4 books, 40 awards. And JB, I'll tell you today, ladies and gentlemen, if today there is a scientific program of Shankar Netra alumni, it is because of JB.
Yes.
It is the brainchild of JB, and because of JB only, this idea of the Connect and the webinar all started. And JB has been contributing significantly for all of us. And welcome, JB, and thank you very much for being here. And
Thank you.
And your teaching, your ophthalmic education contribution, the ophthalmic education, very, very significant as well. We have the final panelist, Dr. Kalpana Babu, who is also an authority in uveitis, and I request Dr. Raji Raman to do the honors for that.
Welcome, Dr. Kalpana. And Dr. Kalpana did her fellowship in uveitis and ocular pathology at Shankar Nethralaya. She was the best fellow. And even from the fellowship days, I just spoke to Sudarshan and her colleagues. She was the one who published the most. She had maximum publications among the fellows, and she took this passion of doing both clinical work as well as getting involved in research, even at Prabha Eye Clinic. And welcome, Kalpana, for this meeting.
I think Kalpana Babu is somebody who is very humble, but a very, very competent ophthalmologist. And her contribution to uveitis and also to ophthalmic education is very, very significant and very, very incredible achievements also. Thank you, Kalpana, for being here with us and sharing your expertise and knowledge with all of us. And we go on to the first speaker, and I request Dr. Ramurthy to do the honors for the first speaker, Dr. Samresh, in the cataract section. Dr. Ramurthy?
Yeah, it's indeed a nice opening for the scientific program, in the sense that Samresh is going to be presenting. I know him as a competent ophthalmologist, an excellent surgeon, a great innovator, has won multiple awards. His videos are a sight to see. It's great to have him here. And he's based out of Jaipur. And as you can see over here, whether it's in the national arena or in the international arena, his contribution and recognition has been very significant. Welcome, Samresh, and looking forward to your presentation.
Thanks a lot, sir.
Okay, over to Samresh. I'll stop sharing my screen. Samresh, it's all yours.
Yes. Thanks a lot, sir, for the lovely introduction. It's so glad to see all my teachers, in Shankar Nethralaya and after Shankar Nethralaya in one place. And so I'm going to start my talk with a case that when I started my practice, it sort of perplexed me because I came from a retina-centric training, Shankar Nethralaya. So these are cases that have started coming to us more often over the last few years. A subluxated lens, which is a relatively uncommon situation for a routine cataract surgeon. But a lens that is subluxated to this level is generally a lens that puts up a question in our mind on whether we want to go ahead and do a primary lensectomy, or as a cataract surgeon, what can you do about this lens? So the goal for a cataract surgeon at this point in time is to create a bag fixation if you can, because it has been taught to us so many times that the eye has an anatomy and you want to maintain the natural compartmentalization of the eye as much as possible. So I'm going to discuss how I'm going to handle this case. This is a pediatric cataract, so it's a soft lens. It looks like a classical syndromic cataract with the with the subluxation going temporally. So I'm going to make a small incision over there. I'm going to make an opening with a needle, and I'm using microcapsular excess forceps to create a rhexis. Pearls to give over here is not to create a big rhexis, because you want to open up the rhexis only in the area that's visible. So I go ahead, make a small one, because I know the nucleus is small and that can be tackled. Once the rhexis is complete, I have to somewhere stabilize the lens and bring it centrally so I can remove whatever little bit soft material there is. And my choice for bringing the lens centrally is a Greishaber hook. Any hooks will do. Greishabers I say particularly because they're non-traumatic and they will not rupture the capsule. So now once I hook the lens and bring it onto one side, I'm hydrating it, very gentle hydration. And an important thing is the use of viscoelastic. So I'm using viscoat or a dispersive viscoelastic to form a cleavage plane so that I can then go ahead and remove this cortex and the soft nucleus easily. Nucleus removal, there are a few things to understand that I learned with experience after damaging a few eyes. My irrigation is always inside the capsular bag. And notice how my aspiration flow rate is just 5. So I'm using a very, very controlled fluidic system, just enough to keep the bag inflated and just enough to draw out material very slowly from the eye so as to not cause a collapse of the bag, capsular bag, and not to disturb this whole anterior vitreous face, which I'm now coating with the dispersive viscoelastic and filling the capsular bag with the viscoadaptive viscoelastic, Helon 5 in this case. And that's the rightly said that OVD is an important term because it's a viscosurgical device and it's not just visco. You have to use these devices smartly. Once I do that, I realize that the rhexis is small, so bag implantation may be very difficult. So I go ahead and use microcapsular rhexis scissors to snip it, and I'm going to move ahead with this by using forceps to sort of try and enlarge this capsular rhexis to a size good enough. And it's important to do that because these eyes, whatever you do, is just your stamping is done for life. So it's very important to be very sure of what you're doing in these cases. And so far, we have not disturbed the anterior vitreous face because it's a gross subluxation. I use a double Cionni element ring, and I'm using a Gore-Tex suture. A Gore-Tex is a non-biodegradable suture, and this is an off-label use. But the suture material is very thick. It does not disintegrate. It will stay there for life, so it's a good suture to use. So I go ahead and I'm going to again move through this because these are again technicalities. But you should take as much time as possible and as much control as possible to be able to slide this whole capsular tension ring with the Cionni elements right in the capsular bag, preferably in the first go. Since these sutures are very, very, ropey and thick, it's easier to see them and it's easy to keep them apart. Once the Cionni element has been dialed into place inside the bag, I will dial this element into the area of the maximum subluxation so as to give the maximum support over there. And then I use a railroading technique to sort of pull these sutures out. Again, I'm using a straight forceps. Once I put this Cionni ring, I titrate my sutures because I want to pull the bag onto the nasal side. So I make that suture a little tighter to have to pull the capsular bag. The other suture at this point is just to give support. Initially, I was doing Hoffman pocket. Now I've gone back to the flaps because the suture tends to sort of erode out through my Hoffman pocket, maybe because I make a shallow Hoffman's pocket. And finally, I go ahead with the lens implantation. I don't do a wound-assisted delivery, so I enlarge my incision slightly and I try to place the lens slowly. My choice is to use a hydrophobic lens in all pediatric cataracts because there's more control and less PCO. And notice how a good material IOL will give you enough time and opportunity to place the lens in a desired position, which is inside the capsular bag. This is a Miyake apple view that we did in our clinic just to understand that if you have a lens in the capsular bag, the haptics are always shielded from these ciliary processes. And so the inflammation is far less as compared to a scleral fixation where the haptics would be rubbing over here. If you're doing a glued IOL or if you're doing a sutured scleral fixation, the PMMA haptics will tend to erode out to these areas. So eyes with Cionni ring are far more quieter. So I just end my talk by saying that, there is an opportunity in cataracts like this to not go the past planar way and lensectomy. And I think with a little bit of experience, an in the bag IOL implantation goes a long way in protecting these eyes. Thank you.
Beautiful. Lovely, lovely video, Samresh. As usual, your videos are really out of the world. And I just wanted to ask you before I go to the panelists, Dr. Ramurthy, Dr. Rajesh Fugla, Sujata, and Partha, and Rashmin also. I just wanted to ask you, this is a progressive zonulopathy. This is the case of Marfan syndrome. Am I right?
Yes, sir.
Okay, it's progressive zonulopathy. Do you think it makes sense because there's going to be a progressive zonulopathy because you're fixing one side, the other side is going to progress as well. So what in your opinion, number one? Number two is you've used iris hooks for the capsular bag.
Right, sir.
It's a good idea to use iris hooks because iris hooks rest on the capsular rhexis margin and they can tear the capsular rhexis margin. And once the capsular rhexis margin is torn, the entire battle is lost. So these are the two questions I want to take to the panelists. Dr. Ramurthy, Sujata, Rajesh Fogla, and Partha Biswas, and Rashmin Gandhi. I think these are the 5 panelists who are doing the cataract, and they can probably ask you some. Dr. Ramurthy.
I think superb surgery, Samresh. I mean, truly a fantastic sight to see. As the only couple of things I might have done differently, if at all I was able to do this kind of surgery, is that I would also preferred using capsular hooks instead of iris hooks because I think that supports the phonesis a little better. And the second thing I would have done is, before going ahead even with the capsulorhexis, I would have gone ahead and put some dispersive viscoelastic in the area of where the vitreous phase is uncovered, because that kind of tamponades over there. It's not like what you do, just put dispersive viscoelastic in that area alone. That forms an adequate cushion, and the rest of the steps can proceed in a more controlled environment. I think we cataract surgeons constantly keep discussing these cases, but this is a unique opportunity. We have some eminent vitreoretinal surgeons, and as you can all say, not every one of us can do the kind of surgery Samresh did. Is it even worth the effort? I mean, what about doing a lensectomy nowadays? You know, we are able to go ahead and go do a glued IOL or do a Yamane technique and fix the lens completely. It has often come to my mind that this seems to be much more easier, and I would like our vitreoretinal colleagues to tell us whether it's worth the effort, or they would say that go ahead and just remove the lens and fix the lens onto the sclera.
Rajiv, can you just comment on that? Rajiv.
Yeah, Dr. Ramamurthy, what you're telling is correct. Well, I think the second approach of removing the lens and doing a scleral fixated IOL, doing a proper vitrectomy, and then placing a SF IOL would be a good idea. Dr. Pramod Bende, what you feel? How would we manage this case?
That's a huge subluxation is there, no?
Yes.
Yeah, because it's almost a half lens is moved now. And what Dr. Mohan Rajan said, I agree with him, because this is basically, it's trauma. I would have said, yes, it is a stationary situation, but being a progressive condition is eventually, I think we are going to land up in problem. Yes, the suture will hold to some extent, but this type of progressive condition, I would prefer to remove the lens, capsule, everything, and probably scleral fixation, whatever way, whether it's glue or Yamane or whatever it may be, but I would prefer in this scenario that my choice will be that one, particularly knowing it's a progressive condition.
What we keep discussing is that, you know, this compartmentalization of the anterior and posterior segment and keeping the vitreous phase is extremely important. That avoids posterior segment complications. Is it really true, or if a competent vitreoretinal surgeon does a lensectomy and implants the lens, scleral fixates the lens?
Once this vitreous is removed, sir, I think that should not be issue. But you need to do a good vitrectomy. I won't do half-hearted, just anti-vitrectomy, lensectomy, and do. Then there's a problem.
Yeah.
Do it a complete job. Do complete vitrectomy and this one, because we have incidences. Ultimately, we'll end up removing like a capsular bag, ring, and IOL. Because that later on down the line, 4 year, 5 year, 10 years, an entire thing to complex to be removed and fixed with another thing.
Yeah, but I think what Shamresh has showed, it requires good surgical skills to be able to do the kind of surgery what he has shown. And I think he got away with the iris hooks because it was a soft cataract. You did not have to do too much of manipulation of the lens material within the bag. Otherwise, capsular hooks are ideal, because whenever you try to rotate a nucleus or manipulate the lens more, your manipulation of the hooks are more, you can tear the capsular bag. And it's great that he used a double Cionni ring where he has supported it on both sides. So even if you have progressive zonular loss, those two sutures will definitely hold the bag without preventing it from tilting. And instead of using Prolene, he has used Gore-Tex, which is known to have long-term stability. And as long as you can put a lens within the bag, I think it gives excellent results, because a scleral fixated IOL in a pediatric eyes has its own sort of set of problems, unless and until the vitrectomy is done properly. Otherwise, you can have long-term other problems which can happen. So I think to be able to do this surgery, you need good surgical skills and the right instruments.
Absolutely. I think you're given very nice messages. Sujata and Partha, you'd like to say something? Is Partha there around? Sujata?
I agree with what Rajesh Fogla said, because we have had similar situations, and I've done both. I've done a lensectomy with a glued IOL and also done the same thing. But probably the only different thing I did was doing a Hoffman's pockets, which he already explained he is not doing anymore. Other than that, I think it's a call you take depending upon the age of the patient. In a pediatric patient, I would be a little bit more wary of doing this, because particularly being a progressive condition. But having used double Cionni, I think you've taken the matter into your hands, and the long-term follow-up, of course, is required for these patients. But I've not had the opportunity to operate on these pediatric age group. I've been doing it in a much older age group. So I've done both glued IOL as well as the technique that you have done. So now I would prefer to rather do a lensectomy and go ahead with either a Yamane or a glued IOL than taking so much of risks.
PV sir, you had one publication now on pediatric SFIOL. Do you have some our SN data, what it showed? Because I think a large series of a pediatric SFIOL was recently published.
Pramod. JB.
PV sir.
Yeah.
Pramod.
Actually, our data is, those days we used to have only Prolene suture, and down the line we are seeing few suture snap and subluxation after maybe 10 years, anything between 7 to 8 years till maybe I would say 15 to 16 years. We do not have that much data as far as Gore-Tex is concerned. We started using last 3 years probably, I would say. But yes, they are quite rewarding as far as, because that age having amblyopia is very prevalent, and you have to take care of, particularly uniocular aphakia is much more problematic to handle. But still, what Rajesh was talking about, just coming back to, as far as possible, I would try to avoid doing SFIOL till probably 7 years of age. And but the exceptional situation, youngest age, what I did is a 4 year. I could get away with that because the uniocular aphakia did not have choice. And so patient is holding on, but the risk of yes, suture snapping was there. Gore-Tex is too early for us to tell, because if we talk about it's 100 years and all those things theoretically, and that exactly what was taught us when a Prolene came into market, and we all seeing results now, Prolene snapping. We used to be so comfortable. Gore-Tex will take, we have to wait for a long period of time now.
Yeah, we need to have a long-term follow-up. And Rashmin, you have anything to say?
I just wanted to ask, wonderful surgery summation. It was very nice. I just wanted one question is that when do you decide to operate? When you see this kid, would you just operate in all patients, or do you have some criteria where you said, I'll go ahead and operate?
I think that's a great question, sir. We published this. We studied aberrometry in these eyes which have mild subluxations. So gross subluxation is a no-brainer, because I think the earlier we tackle, like sir brought about, we have to handle the amblyopia. But even mild degrees of subluxation induce a lot of coma aberration, because the lens becomes spherical on one side where the zonules are weak, and it stays in its aspheric shape on the non-weakness side, and that induces a huge amount of blur in these eyes. So my threshold has gone down for these children. So even if I see a 3-4 hour clock of subluxation, and if I can in an age group where they are able to sit on a machine, I do an aberrometry. It clearly shows that there's a lot of aberrations inducing sort of amblyopic nature. So my threshold has gone down. But if I see a clinically visible thing on a moderate dilatation, I will go ahead and operate this.
What about IOL power calculation, these eyes?
So we, again, for children who are slightly older, we target emetropia for 7 years and above. For younger children, we use our pediatric IOL calculation methodology by reducing it according to the age.
I think the message is very clear. Pramod, you want to say something?
No, just I wanted to have, because refractive surprises down the line as they grow, and with having so many sutures and hooks, long term down the line, 5 year, 10 year refraction surprises, how have you landed up any?
So we are lining up with myopia, sir, but it depends again on the age. For very young children, we are targeting a hyperopia, compensating for the axial length growth. But for children above 7 years, we are targeting near emetropia.
Just a comment on indication for surgery. Samresh, you are almost suggesting that you'll go with the amount of aberrations. Of course, quality of vision does matter, but as of these kids are concerned, it's more what kind of vision they are going to have, and the quantity of vision is more important. So in a case like yours, where it was practically bisecting the undilated pupil, you have no choice but to go ahead and operate. But even if 3-4 clock hours is there, but most of the lenses in the pupillary area, the patient is having 6/9, 6/6 vision. You can never emulate nature. I would, you are a fantastic surgeon, but I would still hold my hands till such time as the patient really has a visual complaint before going ahead and interfering. Or there's a paracentral or a paracentral opacity which causes a drop in vision.
I agree, sir. So I'm only indicating in eyes which have a blur, but the lens is not giving you a clear indication on the surgery. That is where an aberrometry will come to help. If the vision is good, there is no reason to touch.
So the vision is good and the astigmatism is not very, very high. I think we can wait. Okay. So these are the patients I think we should wait. I think we have got all the points very nicely covered by the panelists. And we'll take the questions at the end of the questions from the audience at the end of the cataract session. Any other discussion on this particular topic? Because we're running short of time. We'll have to go to the next speaker.
Yeah, we'll go to the next speaker, sir.
Yes, sir. Yes, Rajiv. I request Dr. Sujata.
Yeah, I'm here.
Dr. Nishant.
I'm very, very happy to introduce Dr. Nishant. And I should say that I really know him from the cradle for quite a long time. And his father, Madhivanan, is known to all of us. He's also a former fellow of Shankar Netralaya. And true to his genes, Nishant is an excellent surgeon. He's a fantastic surgeon. He's done his cornea fellowship from Shankar Netralaya. And also, I've seen him do live surgeries, fabulous corneal surgeries as well. And his recent passion is taking up tennis and cycling and guitar. Over to you, Nishant.
Thank you so much.
Stop sharing the screen, Nishant, and it's all yours.
Yes, sir. Thank you so much. A very good evening to esteemed ophthalmologists and my dear friends. So I am going to talk about a small case where there is actually a pre-existing. Is the video seen, sir?
Yes, it is seen.
Yeah, thank you. So this is a case where actually an intravitreal was actually given around 3 months back, and the surgeon by mistake had actually ruptured the posterior capsule. So we had actually done the investigations and found out that yes, there was a pre-existing PCR. So how do we go about these cases? Make sure that the rhexis is little smaller than what we anticipate, because sometimes in case if we want to keep it in the sulcus or any other places, I will not extend the rhexis more than 5 or 5.25. After completing a proper rhexis, the most important part is the hydro. I will always say a gentle hydro on both sides. Make sure you don't do, even if it is a hydro delineation, don't do it from one side alone, just do half on one side and try to go through the other side and complete it so that the nucleus comes separately. Doing the phaco part is going to be much easier as we are going to use it with very low power. Only the vacuum is going to be a little more high, and make sure that the anterior chamber is stable, because this is one stage where if there is too much of fluctuation in the anterior chamber, there is definitely chances of the anterior vitreous face giving way and the vitreous thrust which will be there. So make sure that the whole core of the nucleus is there, and before coming out, just inject visco inside the anterior chamber, form the chamber, and then bring out your probe. My preferred choice of aspiration is the bimanual. You can see that the cortex is little sticky because it is little complicated cataract. It was a young male. And at the place of the pupil, PCR, I will go in the end. I am not changing my hands because that is also definitely going to collapse the anterior chamber. So as much as possible, even if it is a bimanual, I am trying not too heroic, but trying to aspirate the cortex all the 360 degrees. Once that is done, there is slight amount of PC polish, which I also do, because you can see that the PC does come in. Always make sure that you have one eye on the posterior capsule, because they will be very friable, and there are chances of extending the tear as well. So after a proper PC polishing and even the anterior capsule, so that not too much of phimosis happens, I'm again injecting, making sure that I don't extend the posterior capsular margin and not disrupting the anterior vitreous face. So the posterior chamber intraocular lens is placed in the bag and dialed. So I actually am not very confident enough to actually do the the posterior capsulorhexis without the lens. So what I do is I place the lens, because I have not ruptured the vitreous, and then I go posteriorly behind the lens, because now I know that in case even if any vitreous comes, either I can do a vitrectomy or I can go through the plas plana and do a vitrectomy. So the one important step in this is make sure that you do it very slowly, and you should always have it much more under control, because these rhexis tend to slip away and they also tear. So once the posterior capsular rhexis is also complete, I checked that there's actually no vitreous. You can see, and the irrigation aspiration is done for the final time. And you can see how neatly the anterior rexus margin is also present. And this is the complete posterior capsular rexus.
Fantastic.
I thank all my alumni
Very good.
members. Thank you, MR sir, TSS sir, to all my gurus in Shankar Netralaya.
Beautiful. Thank you very much, Nishant. Really a wonderful surgery. You have shown that. But I just want to ask you, and also take the question to the panelists as well. What is the point in doing a posterior capsular rexus after you implant the lens? Because during the implantation of lens, when the PC tear is there, if the posterior capsular rexus is not there, then the PC tear can extend during the implantation of the IOL itself. So there's no point in doing it after the implantation of the lens. You have to do it before. That is my take. I just want to the opinion from the other panelists as well. Dr. Ramurthy, you can start.
I quite agree. I mean, in the sense that the idea of doing a posterior capsular rexus is to make a strong margin which should not extend. So if Nishant has been able to, with his excellent surgical skills, has been able to implant the lens without doing it, without creating a rupture, and the vitreous face is intact, maybe he's taking a bit of a risk by going under the lens, because it's a difficult step to perform, though he did it very well. And everything was very well done, Nishant. The only step I might do differently is that I may not rotate the lens, especially your haptic went right in the area of where the PCR was there. So in these cases, I would just, the leading haptic, I would let it go into the capsular bag right away. And you are angulated in a way that it was going where the posterior capsule is intact. And the trailing haptic, I would just tuck it in using a Sinskey hook through the side port, so that the rotation is not necessary. And otherwise, everything went off well. And just because the others are there, a comment that we always used to send cases to the posterior segment guys with drop nucleus, drop lenses. Now they have started reciprocating and sending some cases to us for creating these cataracts.
I know, but when you see, I think Ramurthy have said these points very nicely. I'll ask Sujata's opinion also, and also Rajesh Foglas and Rashmin Gandhi. If Partha is there, let him also comment, because he has shown several cases of intravitreal, what you call Avastin cases, pre-existing tear of the vitreous. Very important to note this, recognize this preoperatively, and take all the precautions during the surgery. And I also found that you went and in that area you did the hydrodelineation. What I would suggest is, don't go anywhere near that area at all, wherever the PC tear is there. So no sort of hydrodelineation in that area, particularly. You can do it away from that area. I want to ask Sujata's opinion as well as Rajesh Fogla's opinion on this particular case. Beautifully done case, Nishant.
Excellent surgery, Nishant. You're a fantastic surgeon. And the only thing is, I don't think I would have handled this case in such an elegant manner. It was so beautiful. The only point is, I mean, I would consider this case as something like a PPC. How I would treat a PPC, I would go on the same lines. So I would do a hydrodelineation rather than a hydrodissection. And doing a bimanual IA, I think you followed all the steps. And I would definitely agree with Mohan on the fact that, I'd like to do the PCC before implanting the lens. And if it's a very small break, I'll just go ahead and implant even without bothering to do a PCC. I think you really did a fabulous job.
Thank you.
Rajesh, thank you so much.
I agree. Putting a lens in the bag and then trying to do the PCC, the stress from the haptic itself can sometimes stretch your posterior capsular rexus, and you can have extension. And if you did have an extension and one haptic pops into the vitreous, it can complicate matters. So I think ideally it should be done before you slip the lens into the bag. There is a recent publication from Howard Gimbel in JCRS this year, where he has shown that in the presence of a posterior capsular defect, sometimes he prefers putting the lens in the sulcus and then doing an optic capture through the capsular rexus. So that also, in a situation where you have a rent and you are scared to do your posterior capsular rexus, you can think about doing this, where you place your lens and then do an optic capture through the capsular rexus, because you've already done a smaller rexus.
It has to be a multi-piece lens then.
No, he has done it with a single piece only in the paper that he has reported. Although we prefer to use the multi-piece because the optic has square edges, but because he pushes it behind the capsular rhexis, he says that it doesn't have the effect on the iris, the constant rubbing and the uveitis that goes. So that's a nice paper. Again, it's a technique that's described, but yeah, if you have access to a 3-piece, then use a 3-piece lens and you can do a optic capture through the capsular rhexis that you have.
Yeah,
and PC polishing also, I think in the presence of a posterior capsular defect, if the edges are fibrosed, maybe you can get away by trying to do the, but I think that's again one step which may not be advisable, because the posterior capsule, it can get caught in the probe and it may not release it, and then if that situation happens, you can end up enlarging the defect in the posterior capsule that you have.
Thank you, sir.
All the points have been beautifully stressed. Yes, Nishant, tell me.
Challenge between the stress of the capsule or the stress of my heart. So I think
you did a good job. Ultimately,
beautiful surgery, Nishant. Very nice.
Yeah.
Very nicely, well managed.
Rashmin, you have anything to say?
No, nice surgery, Nishant. Well done.
Thank
Very
you, sir.
nice. Is Partha there available online? No, not available. Okay, I think it's a beautiful surgery, Nishant, and the nice take-home messages. The only take-home message I want to give is that try to do a posterior capsular rhexis before you implant the lens, because that makes life easier, and also the implantation lens will be much safer. And we go on to the next speaker. Yes. Are you sharing that, Rajiv? No, 1 minute. Ashok.
Yeah.
Can you just wait for a minute?
Yeah.
We have to introduce you formally. Can you stop sharing?
Yeah, I have. I think it should not be visible now. I'm not sharing now.
Yeah, okay. Thanks a lot. Thanks, Ashok. I request Dr. Rashmin Gandhi to introduce Dr. Ashok Rangarajan.
Thank you, sir. And it's really a pleasure to introduce Dr. Ashok, who has been a mentor and a friend. He was our early cataract days. He was the person who supervised us and was very patient with teaching us the cataract. And apart from the achievements that he has listed, there are sometimes the projects and achievements that you do that cannot be put in the CV, but nonetheless have big impact. And one of the achievements that he had was that while he was a fellow, he was asked to lead the JCOC, the community department. And at that time it was in Pummel. And under his leadership, he shifted the whole department to JCOC on the Pycroft's Garden Road. And in the shifting, there was nothing which was lost, and the whole process was very smooth. So kudos to Ashok, and all yours.
Ashok, all yours, Ashok. You can share your screen.
Is it visible now?
Yes, boss.
Thank you so much, Rashmin, and thank you, Dr. Mohan Rajan. I'm always in awe of your enthusiasm in organizing all this. I just will take a minute to deviate from this topic to mention about this Pummel days and how we developed community ophthalmology. In those 2 years between 97 and 99, when Chief put me and Dr. Sheelaj on there, I used to come back and report to Chief every evening at 8 o'clock. And that was a huge learning experience, not just learning ophthalmology or cataract surgery, but a huge learning experience with the big man himself. And I mean, as we always know, he used to lead by example. When you see the boss working there, you have no other choice but to work hard. So mine is a fairly mundane topic, something we all face every day. So coming to the point about what is a hard cataract, there is no scientific classification given. And it's something which is very relative to the strength which you have as a cataract surgeon. So to each his own definition of what is hard or very hard and what is a difficult clinical scenario where you can do a phaco. Important to know that when we decide to do phaco, we should take into consideration a lot of other factors before one decides to do that. Needless to say, preoperative assessment is very important. Endothelium, pupils, presence of pseudoexfoliation. In today's atmosphere, it's very important that we take a lot of chair time and discuss with the patient the increased risk while doing phaco in such a situation. And personally, I approach all cataracts from the temporal side, and I do temporal clear corneal. I feel temporal approach gives a lot of area, especially in those deep set eyes. If you're not comfortable doing clear corneal, you could do a small tunnel. It's just easy to bail out and convert into a scleral tunnel should you wish to bail out. The other pearl which I want to tell is, irrespective of whether the capsule is visible or not, I would prefer to stain a very hard cataract because it gives the visibility of the rhexis margin edge when we begin to chop. Needless to say, ophthalmic, OVD, viscoelastic is of paramount importance here. I would prefer to use a chondroitin sulfate based viscoelastic because coatability is what is very important here. Endothelium coatability, number one. Number two, it should not get washed off easily. So we can use the OVD as a buffer between the last pieces and the fragile capsule. So here is a video. I hope it plays. Yeah, video. What I want to show here is you can see Cataracta nigra and doing.
Can you play it?
The section, we cannot see the fluid wave go by, so you should press the center of the nucleus to release the fluid on either side and then decompress the anterior chamber also so that the anterior chamber pressure does not build up when hydrodissection is being done. You could also use a viscoelastic and rotate the nucleus to confirm before the beginning the phacoemulsification. Here I'm using a heavy viscoelastic before beginning. Now, again, the question is which machine is preferable to do a hard cataract, peristaltic or Venturi? I use the Venturi in my own place. I use this peristaltic, which is no financial interest here in another hospital where I perform surgeries. I have put up the settings which I normally use. What is important here, which I want to bring about is, do you do a crater or not? I would prefer to do a long and wide crater before I begin the vertical chops. Important thing here is to do a deep and wide crater so that the probe fits into the width of the crater as you begin, and then you introduce the vertical chopper. While doing the chop, I would use a burst mode, high vacuum, as you can see on the right side. Take the cleavage plane all the way down till you can see that open little space. There is a huge joy in seeing that vertical chop happening whenever you do these cataracts. I would prefer to do all consecutive chops before I begin to eat off the pieces. While eating the pieces, I would use pulse mode because it decreases chatter and keeps the piece close to the mouth of the probe. Now the question is, a Kellman step is preferable. Whether it is 30 degree or 45 degree does not matter as long as you can impale the entire piece and you don't leave the port unguarded while you are beginning to emulsify the pieces. So I'll move to the next slide here. Pause this here and I'll move to this one here. Yeah, what I wanted to point here is the next three slides I'm going to show. These were ones when we were supervising the surgeons doing. Would not want the rocking of the nucleus to happen. If there is rocking of the nucleus happen when you're sculpting, that means the power is insufficient and you're just pushing the nucleus. So the power must be increased so that the sculpting happens, and you must use a deep wide trench before beginning the chop. Again here, very important, this video will just barely show that little bit of smoke that comes up, but very important to recognize cataract smoke or cataract milk. As the power is being used, you will see that little escape of cataract milk or cataract smoke, which is an indication that there is a bit of heat buildup happening. And there you go. You could see the little cataract milk. At such a point, I would ideally pause, check the patency of the ports before beginning the surgery again. Persisting at this point, especially with the presence of a heavy viscoelastic, could result in a corneal burn and could completely alter the thing. It's very important that we recognize this. Here is another one. You should watch the surgeon without achieving full impaling. You attempt to chop and continue to pull back the piece. Now the chop has not happened, and somewhere along the line, the port has got, the phaco port is opened up, and you can see that the iris will get caught. But the surgeon continues, there you go. The iris is caught now, but the surgeon continues to persist. The reason this is happening is because there has not been a complete impaling of the nucleus with the probe before beginning the chop. And another two videos here. This is one after the hydro dissection. The surgeon continues to dial, I believe, in an attempt to bring the nucleus to the anterior chamber, and then does the phaco here. I wonder what is the use of doing a phaco when you might do a good phaco in a good mature cataract, but you will ruin the endothelium. In any case, the end result is going to be poor. So I just brought out these three slides or these three video clips to highlight what should not be done. Surge is nowadays a thing of not much importance, I would say, because we have wonderful machines which have microprocessors which can sense the tip and correct the, so there is very little surge which happens, and there is good anterior chamber stability in almost all end machines in today's practice patterns. And one doesn't need to really look for a high-end machine before attempting a hard cataract phaco. This is another, just the last slide, one situation where all of us face, where we begin to emulsify and then suddenly find the piece does not move at all. And this happens because the probe is plugged somewhere. So, and we continue to persist in the emulsifying mode, which means the heat delivery is continuing, but the aspiration is not happening. So that is a very risky situation. So we must stop and review the situation and then proceed. So to summarize, topical or peribulbar, the choice is yours. If you're not too confident, you could do a small scleral tunnel, temporal, and then proceed with phacoemulsification so that you're ready to bail out should you need to. Staining the capsule has its own benefits, has its own benefits. Very important that viscoelastic you use should have chondroitin sulfate. Vertical chop is the best method to choose. Sub-chopping further helps. Pulse mode is good so that there is no chatter. And most important is the last line which I've written here. Whatever your level of expertise, if you feel you should convert to an SICS, not do phaco, or call your senior colleague and ask him or her to perform, because at the end of the day, we are answerable to the person who's under the drapes. Thank you very much for your patience.
Very nice, Ashok. I think simply fantastic pearls as far as hard cataract is concerned. Personally, what I would do is I will use a straight tip. I use a 15-degree. I prefer a Venturi system like Stellaris, but whatever machine you're comfortable, I go bevel down. If I'm using a Kelman tip, I go sideways. With occlusion is better for me. And I always use the vertical chop. I use a sharp chopper, which is devised by me. And the most important thing in hard cataract, in my opinion, is to make sure that your posterior nuclear plate is completely separated. You have to see the posterior capsule through and through and right across the nucleus, and that is then only you should try and attack each of these halves and bring this. Otherwise, you'll have a white cornea the next day. And we have Dr. Ramurthy there, or he's gone?
Yeah, I'm there. I'm just.
Ramurthy, you have any suggestions?
Yeah, I think nice surgeries and very nice tips that has been offered. I think right from capsular rhexis, an adequate size capsular rhexis is very important. I think it was shown that about 5.5 millimeter rhexis needs to be done. And then he was talking about heavy molecular weight viscoelastic. I think it's important that dispersive viscoelastic, because we are also concerned about the corneal endothelium, needs to be used. In these cases, I would go for a soft shell technique where maybe use a dispersive viscoelastic, coat the endothelium, then have a heavy molecular weight viscoelastic in the middle. Otherwise, if it was just one, I would just go with a dispersive. And then, as you rightly pointed out, I think the most important step to achieve is to break the backbone of the nucleus. And once you have done that, then whatever method you employ, then things become easier. Not everyone is capable of chopping these grades of cataract. So just in case you're not comfortable with chopping, it's also a good idea to do a good stop and chop technique where you really go down sculpting and create a nice deep crater. Literally, you can create about 1.5 tip width segment right in the middle, and then even going through the two side ports, split it into two. And subsequently, the steps become much more easier. One aspect I may do a little differently is that I saw that Rangarajan was at places trying to remove the bits of nucleus. I would chop the nucleus completely within the capsular bag, because that itself, the nucleus, presence of nucleus itself, acts as a deterrent for these any kind of capsular bag complications. And once they are chopped into bits, smaller bits, in these cases, I might even go for 8 bits and then remove them one after the other. You also need to remember that these hard cataracts are often associated with weak bags. They tend to weak zonules. There's a tendency for the posterior capsule to trample in. So right through the surgery, you have to employ all care to make sure that these goes off quite well.
I think beautiful points, Ramurthy. I think it's important. If you are not comfortable with the chopping technique, do the stop and chop technique. As Ramurthy rightly said, you need to make sure that you use very good phaco power to make the trench, as Ashok rightly mentioned. Sujata, you have anything to add? And followed by Rajesh Fogla. and Rashmin also.
I think
Sujata?
an excellent surgery, Dr. Ashok. It goes to show what a beautiful teacher you are. I would agree with Dr. Ramurthy, and I mean, I prefer, there are a lot of people who like to take out the pieces as they go chopping. I'm a person who likes to chop within the bag and start removing, particularly in a hard cataract. It gives so much of support to the bag. And making a slightly larger rexus is what I would do when we're dealing with hard cataract. I think you've carried through all the points very well. I don't think there's anything much I can add on this. Thank you.
Because if you slightly have a slightly larger rexus, that gives you more space, especially in this brown black cataracts. Rajesh, you have anything to add? Anything do differently?
No, nothing. I think he has covered beautifully most of the points which are relevant to dealing with a hard cataract. Preoperative specular microscopy is essential. You do it, and I think it's not to lose sight of the incision. Because you focus on the cataract and protecting the PC, and end of it, if you realize that you have created a thermal burn and you have a leaky wound that you need to close, that can make a mess of things. And for people who are not very confident of dealing with very hard cataracts, I think a scleral incision is more forgiving. And at any point of time, if you need to extend, you can easily extend rather than from a corneal incision extending, and managing that sometimes can be a little bit more cumbersome. And always do it much more slowly. And if you are used to doing topical, maybe for a hard cataract, give a nice perivulvar block and do the surgery, because then your patient is also more comfortable and you can also deal with the situation much better.
I think it's a very important point, because sometimes you can have a slightly prolonged surgical time and the patient may not cooperate and things can go a little messy. And Rashmin, you have anything to add, Rashmin? Quickly.
Just one point which Dr. Ramurthy had already said is that I would use liberal HPMC, because we need to make sure that the endothelium also is protected. Dispersive
viscoat.
Yeah, dispersive viscoelastic.
Yeah.
And the other thing is, be prepared to use iris hooks if you are dealing with a hard cataract and somewhere down the lane your surgery, your pupil becomes small and you're not able to. So instead of working with a smaller pupil and trying to deal with a hard cataract, then catching the iris, it would make sense to spend some time and just put the iris hooks or a pupil expansion device to keep the pupil dilated and then complete your surgery.
Absolutely. I think it's a very brilliant point, Rajesh, and then I really appreciate that for you for that. And it's important because the pupil becomes small. You don't have to, you have a complex situation in your hand. So you not only have a hard cataract, but also a small pupil, which can make life very, very difficult for you. And that's, I think, point wherein you have to go and use iris hooks. And any questions from the audience, Rajiv?
I didn't see anything, but I'll check it. You can go through the next talk, sir. I'll ask if it is there.
Next talk is pediatric by Dr. Sumita. And I think we are catching up with some time.
Family.
Yeah. Ashok.
No, we don't have any questions.
Okay. I request Dr. TSS if he's there. Dr. TSS is there? Dr. Surendran. Sir? Rajiv, can you introduce Dr. Sumita?
Yeah. So it's my pleasure to introduce Dr. Sumita Agarkar. She's actually my senior in during my MBBS days, and a pediatric ophthalmologist, a senior consultant, and a great researcher. Many of you may not be knowing that she has published some very important stuff from the pediatric ophthalmology, and a leading ophthalmologist in even the Orbis project. Welcome, Dr. Sumita, and a very, very happy returns of the day. Enjoy your birthday.
Thank you so much.
Many happy returns, Sumita. All yours.
Thank you. So I'm going to present a case. I was first planning to present a case in strabismus, but usually strabismus case induces a mass lubric. So I'm going to stick to a cataract thing here. And this is a 4-year-old.
Not audible, Sumita.
Okay. This is a 5-year-old child who came to me with complaints of poor vision since 3 years. Diagnosed as uveitis with complicated cataract elsewhere. Had first cataract surgery with IOL implantation in 2014. August 2015 underwent membranectomy. And post-membranectomy, there was some refraction done, and that was around +11 according to the reports which was there. And but no glasses were prescribed. Underwent in July 2016 a Sulcoflex lens. Vision has been recorded 3/60. Then underwent another membranectomy in 2017. Then another membranectomy in 2018 using scissors. And this is his ocular examination thing. As you can see, child is very poor vision in the right eye. He's orthophoric, luckily. Other eye seems to be normal. And this is his picture in the right eye, slit lamp examination picture in the right eye, and that is in the left eye. You can see the sulcoflex is completely half in the anterior chamber, and there is a thick membrane between the two lenses. So since there was no view, child had very poor vision, we decided to go ahead with planned sulcoflex removal and probably removal of both lenses. So this is the intraoperative, this is a small video. And as you can see, the second lens is very badly stuck to the iris as well as to the lens which is underneath. And with the use of scissors and viscoelastic and all, finally I was able to bring the sulcoflex in the anterior chamber. Luckily, I was able to take it out fairly easily through not a very large incision. And you can see there is a really thick fibrotic membrane between the two lenses. And I used a vitrector to cut the membrane, which was encasing both the capsules, the lens which was beneath. And at this point, when I stopped and looked at the fundus, fundus looked clear. There was no evidence of inflammation behind. So I decided, and the other lens appeared to be very securely in the bag. So I left it there. And this is at 6 weeks. His vision had improved to 636. Other eye, of course, remained normal, but his refraction was around +10, which we gave. This vision which I am mentioning is with that refraction value. And this is his eye, looking quiet. So my question here to the panelists and those who are eminent ophthalmologists here is, was there any other way I could have dealt with this? Should I have removed both the lenses? And what's the lens forward? Should I do a lens exchange for removing or just give him amblyopia therapy? Because he's densely amblyopic. He wears that +10 glass comfortably, is able to patch, and parents are really happy and do not want to undergo another surgery. So my carry home after this case will be probably two lenses don't correct one wrong biometry. And surgery is just the first step on a very long road for children. So doing it right the first time probably makes all the difference. Thank you.
Beautiful. Seriously amazing, Sumita. Very nice. And the take-home message is, I think Sulcoflex is a very large diameter lens. It's about 13.5 millimeter. It's made by the company called Rayner. And that is not, I think, probably indicated for a residual refractive error in a child. Okay. So that is probably one wrong indication which has been put. What you would have done? Suppose you had a patient with a residual refractive. Can you stop sharing the screen for a minute?
And I thought I would want people to discuss.
Yeah, no problem. Yeah. What exactly you would have done? I would like to ask the panelists also. Rajesh, Sujata.
One thing I missed while doing this, I should have probably done a specular, which I did not do before planning surgery. And I did have a DVR planning for lens exchange for both, but finally the other lens looked fairly secure, and also I did not go ahead and pick out the other lens. But that's one thing which was missing in this patient, if somebody wants to know.
Yeah, because you have removed the Sulcoflex lens, I was wondering whether you could have replaced the primary lens also. Yeah. That was a good, could have been an option. Of course, there was a lot of fibrosis there.
Yeah, it was very, very tightly, and somebody has done a neat posterior capsulotomy behind, and visual axis was clear, retina and all looked fine. So I decided to leave that lens there. But
no, I was asking the question to the panelists as well as to you. What exactly, suppose after a pediatric cataract surgery, you find a refractive surprise of about +10, +11 post-operatively, what exactly you would have done? Rajesh?
In the early stage, I think I would plan for IOL exchange before all these other secondary complications of synechiae, fibrosis, everything has happened. So I think if you feel that there has been an error, I think you should go in as early as possible and exchange the lens, because that is the time you have the window to do that. Pediatric guys don't do very well with sulcus fixated lens. We have seen a lot of these cases that come back. Usually you get a optic capture and you get synechiae of the iris to the posterior capsule. And then to open up the bag also, it's not like in an adult eye where you can open up the bag and try to remove the IOL. If I had to remove the second lens, maybe I would have cut it at the optic haptic junction, just remove the optic and then try to see if I can, depending on the situation, the amount of fibrosis, whether I need to remove the entire capsule and do a proper secondary IOL, or if the posterior capsular axis was intact, I would have placed the lens in the sulcus, and the optic, I would have done a reverse optic capture to try and correct that. And in Sumita's case, like even after removing the sulcoflex, if there is a significant refractive error and the other eye is close to emmetropia, then I think a contact lens wear seems to be the best way to manage to prevent further progression of amblyopia.
Yeah.
Can I say something, Mohan?
Sujata, yes.
Can I say something, Mohan?
Who's that?
Karobi.
Karobi, yeah.
Please.
Karobi, please. You come back.
She did the surgery very nicely, Sumita. And I think her decision to leave that lens was quite right, because there was a whole lot of fibrous tissue, and trying to remove it would have probably resulted in some kind of bleed or some other complication. And since the posterior segment was clear and even the capsule was clear and there was a rhexis over there, I don't think it would have been right to tamper more, because in these kind of surgeries, I think best is the enemy of better. So if you have a better response, you leave it at that and then manage the amblyopia and the refractive errors either with a contact lens and see, the eye is amblyopic. So at the moment, the child is not going to have diplopia. So you can give patching and do the other amblyopia therapies, because that will be more helpful than creating a worse scenario in this patient. So I fully agree with Sumita. I think she's done the right thing.
Excellent, excellent. Sujata, you would have to say.
I just wondered, why can we? I would like to ask Sunita her opinion on removing this lens and putting a phakic IOL, a columnar lens. Will it make a difference, and that will correct the refractive error and also probably be less fibroid, won't induce fibrosis like the previous lens, the sulcoflex lens? Any thoughts on that?
I don't know. I have no experience of a polymer based lens in children. That to such a young child who is just 5 years old. There are instances of phakic IOLs to correct the refractive surprises. Probably a little older, teenage, and it's probably an option in teenagers sometimes who get very large myopic shifts after following cataract surgery in childhood. But
because it's more forgiving than other lenses, if you want, you can.
There are a lot of reports of polymer lens ICL being put in the sulcus.
And it's easily explant. If you want, you can go ahead and explant the lenses. I'd like Rajesh Fogler to comment on this.
I don't think, because in a pediatric eye, the tissue reaction, it's in a very, it behaves in a totally different way compared to an adult eye. And sizing is again an issue. I don't think I would be very comfortable putting a columnar lens, even though the material is more biocompatible. But why play around with the child's eye? And as Karubi said, trying to do more when less is better, it definitely makes sense. And even what she mentioned was to try and remove the entire lens capsular bag complex can definitely result in some posterior segment complication. So even if I had to remove that second lens, I would have removed only the optic. I would have cut the lens at the optic haptic junction, just remove that lens, and then think about whether I could put a proper lens and do a posterior optic capture just by creating a central opening. So that would be my other option. Otherwise, contact lens is the best option.
Contact lens is probably the best option. Yeah, Rashmin, you have anything to say?
I just want to make a point here, because none of people in the panel are probably pediatric ophthalmologists. Actually, it is not required to worry about contact lens too much at this point, because child is very densely amblyopic.
Yeah.
Sometimes failure happens because no glasses are given, because there is such a large refractive error. That child would have done equally well if the doctor had just given that +11 in the first place and not tried to put a second lens to take care of that. I think less is more probably works at that point onwards only. Yeah, your parents are going to pound you about questions about thick glasses and all, but I think visually child would have done equally well, even if he had given the glasses at that time.
Correct. So I think you need to base your decision based on the clinical findings and visual prognosis.
Yeah.
I
And not
completely
be too
agree with
heroic.
you.
Yeah, very nice, Sumita. It is a very good presentation and a very tough case scenario as well, and you managed it so well. And we'll go on to the next set of topics, that is the glaucoma session. Okay, right. I request Dr. Vinay Nangia to introduce Dr. Shweta. Vinay?
Go back, sir.
Sorry.
One slide back. Yeah.
Yeah, it's okay. Vinay, are you there? Vinay Nangia.
I think Dr. LV ma'am can introduce.
Yeah, no,
I'm
yeah,
Vijay can introduce.
Yeah, so very nice to have Dr. Shweta Tripathi. I didn't know too much about her, so I'm going to have to read out your biodata to introduce you to everyone. So you've done a fellowship from Shankar Netralaya, and that's a long-term fellowship. And she's working at Lucknow as a senior consultant in glaucoma. And she was the organizing secretary of the National Conference of the Glaucoma Society of India at Lucknow, and also that she has many publications to her credit in national and international journals. And I'm very happy to meet you on this program, and we look forward to your case presentation.
Thank you so much, sir. Same here.
Shweta, all yours, Shweta.
Yes, sir. So are my slides visible?
Yes, Shweta.
So I would like to thank all my seniors, respected seniors, dear friends and colleagues as well. And I would like to start the presentation with a shloka which sums up all the teaching given to us in SN. That's Guru Brahma, Guru Vishnu, Guru Devo Maheshwarai, Guru Sakshat Param Brahma, Tasmai Shri Guruve Namah. And straight away coming to my presentation for tonight would be talking about the imperishable truth about when we talk about dealing with a case. That's a good history. Let's see how. So this was a case where a 50-year-old female presented to us in September 2016 just for a routine evaluation for this suspect, and nothing significant was seen. So she was advised to review to the clinic after 3 months. Later on, we lost her to follow up, and then she presented to us again in December 2017. That was 15 months after the first presentation. Again, now a simple complaint of occasional heaviness, though the past significant history was there with us now, that she had gone to see one more doctor, and there she had been prescribed the AGMs, which she was on irregular usage. The significant ocular findings here were that the vision was 6/6, but the pressures, though they were inconclusive because of the irregular use of AGM. They were 18 in the right eye, and left eye it was 16. Gonioscopy, it was open angle. The disc damage was documented in the form of 0.7 cupping with the early notch. So these were the corresponding field defects for the patient. Then later on, the patient was restarted with the same beta blockers which she was on before coming to us, along with the lubricating eye drops, and she was kept under regular follow-ups with reassurance at all her visits due to her non-compliance. till she came back again to us in August 2018. And this time it was something significant where she had complaints of redness. And again, she had stopped the AGM on her own. The significant slit lamp examination ocular finding showed that there was a diffuse conjunctival congestion with rest of the anterior segment within normal limits. There was no associated any kind of inflammation seen elsewhere in other part of the eye. Though the pressures were, again, I should say, controlled or 18 millimeters in both eyes, she was treated for conjunctivitis in both eyes along with the topical antibiotics and lubricating. But this is the most important part where we can see a spread over of the patient of her follow-ups when she was there with us for the treatment of that conjunctival congestion along a period of 1 month, where we can see that the conjunctival congestion is behaving in a different pattern, reducing or increasing irrespective of the drugs being used to control the situation, probably starting from the antibiotics to the oral steroids and the topical steroids as well. On the other hand, the IOP was worrying us. So we had to add on to the AGMs and to along with the topical and the oral steroid. Finally, we attained the goal on at the end of the month, 1 month. That was congestion had reduced significantly and the pressures were well under control. These were the investigation reports when she was there with us for the treatment. But we knew that this was not the end of the story. Actually, it is a time for us to replay the whole sequence from 11/9/18 because she presented to us on 28th August. And this was 11/9/18 because we knew that there were certain thought-provoking points in this case which led us to keep on thinking about something else is happening, which was responsible for the conjunctival inflammation along with the increase in the IOP because of the recurrent diffuse conjunctival congestion and the fluctuation of IOP in the absence of any significant positive sign in the form of proptosis, lid edema, and going up to inflammation and ophthalmoplegia. And the uttermost important thing was the patient being distraught, aggravating the non-compliance to her every visit. So what we did was that we decided that, okay, we'll go back in the history part once again, and we'll focus this time, especially on the medical history. And when we did that, we got the result. The patient gave a history of episodes of fever and being treated for UTI. She also revealed that she was having hematuria for 10 days and the urine routine report showed the RBC. Immediately, we understood that there is a secondary underlying cause for the increase in IOP and the inflammation as well. So we took a significant negative history in the form of the involvement of respiratory tract, and immediately the immunologist opinions was sought. And the situation came for which we were keeping our fingers crossed with the lab investigation, the ANCA screening report positive in the form of NTPR3 and a renal biopsy, which stated that she was in a life-threatening condition, that's a granulomatosis with polyangiitis. Immediately by the treating immunologist, she was treated along with the rituximab, cyclophosphamide, and steroids in one or the other form, oral along with the IV infusions. The Birmingham vasculitis score, to all our surprise, immediately within a period of 2 or 3 months, I should say, improved from 15 to 0. That's the vasculitis activity score. And add to a sigh of relief, started coming the pressures down to such an extent that spread over a period of, as we can see from this slide, spread over a period of 2 to 3 months, the pressures came down gradually, which helped us to withdraw the AGMs. And during her last visit, that was in January, she was on a single AGM in both the eyes. The patient fulfilled the criteria as laid by the American College of Rheumatologists, 2 criteria. She had urinary sediments positive and the granulomatous inflammation of the biopsy, which led the immunologist and us to lead to a diagnosis. Now, I would like to conclude the presentation with re-emphasizing on the fact that these kind of life-threatening conditions should never be overlooked, as these are life-threatening as well as permanent visual disability for the patient, can lead to blindness also. Even though the most common involved in structure for the eye would be orbit, but the literature says a single conjunctival inflammation, isolated, I should say, conjunctival inflammation or involvement cannot be overlooked. The learning milestone, the main milestone which we came across through our entire journey of treating this patient was about the perseverance about the systemic history taking, perseverance about the follow-ups, and the most important, the perseverance about coming to a conclusive diagnosis, which was leading to this kind of ocular presentation. And it all helped us to achieve the aim of the holistic care in the form of saving the patient's life and preventing the permanent blinding condition. And thank you all to my teachers. Thank you so much.
And thank you, Shweta.
That was incredible. One minute, Vinay. Let us stop sharing. I request all the others to kindly mute because I could hear some noise from the background. Yeah, over to Vinay and Vijaya for their discussion on this.
Yeah, Vijay, do you want to say something?
Sir.
Okay, Shweta, thank you. That was a great presentation, and it's taught me a lot of things also. And I just want to take you back to a period when you were describing the case when the patient came with conjunctival congestion. Yes. And at that time, I get the sense that the diagnosis had not been made that she's suffering from an immunological condition, but that you had started the patient on steroids. Is that correct?
Yes, sir.
And what was the reason for starting the patient on steroids? Because you thought that there was scleritis or episcleritis or some orbital inflammation or something like that?
Sir, it was a persistent inflammation. So it was not responding to the topical antibiotics. So we thought of giving a shot of the topical steroids.
All right. Because I saw that in your next slide, because you gave the steroids, somehow the patient's intraocular pressure was better controlled on the next visit, actually. So I think that was an indication that steroids had some role to play in. So I also want to just put to you that do you think that the inflammation might have reached up to the trabecular meshwork because it's an immunological condition, and or do you think it was just elevated episcleral pressure because of the conjunctival inflammation and thickening, or it was a combination of both actually?
Sir, I feel because the gonioscopy, the angles were quite open and there was no blood in Schlien canals. So what we assumed was that the pressures went up because of the inflammation causing some kind of Schlemitis or tuberculitis.
Okay, and you would just like to follow up the patient and keep the immunological condition under control. Great, thank you very much. It's terrific.
Yeah, good, very interesting case, Shweta. Congratulations. If you have to give a clinical diagnosis, so what do you say? What is your working diagnosis?
Ma'am, I would say because it was a systemic condition, that's crescentic glomerular nephritis, that's polyangiitis. So
that's fine. I'm looking at the eye.
I would say, ma'am, secondary glaucoma, a broad sense.
Yeah. Yes, because I'm not sure whether the external inflammation has produced the glaucoma, or she was intermittently using steroids that has produced. I'm not sure. So I do appreciate that you want to call it as episcleritis or scleritis, because with episcleritis, glaucoma chances are very, very remote. Yes, with the scleritis, you can have a secondary glaucoma. So that's why it is a little confusing for me to accept. Are we dealing with the two conditions? I'm not sure.
Ma'am, actually the clinical pictures, which were, if you allow me, I can share the screen once again. The clinical picture shows no evidence of episcleritis and scleritis on any of her visit. And during her treatment for this systemic condition, she is continuously on oral steroids and the infusion of IV steroids. So with keeping that in mind, we ruled out the cause of increased pressure to be steroids to some extent, ma'am.
Okay, what is the maximum pressure you got?
29. That was 29.
Okay. JB has a point. JB?
I don't think that the patient had conjunctivitis. The patient had definitely had scleritis. The reason is that one of the commonest association of granulomatous polyangiitis is scleritis, and that doesn't respond to topical steroid. You need to put immunosuppressive like cyclophosphamide or biologic agents, that the rituximab which has been found.
Yeah, that will explain the rise in the intraocular pressure. Because scleritis can produce rise in the intraocular pressure, but episcleritis is unlikely. Yes.
Vijaya, the patient didn't have much pain, no? They had only conjunctival congestion she had. If I'm right, Sweta?
Yes, that's a good point. That's
a red eye, ma'am, which continued for 1 month. Painless red eye.
Painless red eye.
Yes.
It's what? Why? Yeah.
JB, scleritis, can it be painless?
No.
Yes, it sometimes can be painless, but deep scleral veins are congested. But usually most of the times, 80 to 90% it is with the pain, boring, dull pain. But not many times it is not that severe. So the patient might not be really aware of it.
Yeah. So the positive thing is response to the immunosuppressants, and control of the pressure tells you that there is a pathology like what JB has suggested. Maybe I would call it as possible scleritis secondary to the systemic illness that has caused rise in the pressure that got controlled with the control of the systemic condition. So there is a possibility for the relapse for this condition if the systemic condition treatment goes out of control. Needs a good follow-up. Very, very interesting.
Thank you.
Very nice presentation, Sweta. Anything else to add? Vinay, you would like to add anything?
No, I just thought that there were several lessons for us to learn. And the reason that I actually put forward that, possibility whether the trabecular meshwork was involved, because once you have inflammation around the angle, that is, you have either conjunctival inflammation or circumciliary inflammation, or you have episcleral or sterile inflammation, then I think that that it's only possible that, the trabecular meshwork gets inflamed, but that you may not be able to see what's happening on the gonioscopy actually. So that's what I was trying to suggest. But it was a great case, and thank you very much.
Yeah, somebody has, Kalpana Babu has put, did she have a orbital involvement subtle, which could also cause increase in IOP?
Ma'am, CT orbit was done and it was normal.
Yes. Okay. And fine. I think both the lacrimal gland and the orbital involvement, what she wanted to know.
Yes.
There was a question, so that's fine. Okay, so basically, it's the systemic condition producing possible scleritis with a rise in the intraocular pressure. Good. Thank you.
Excellent presentation. I think it's a very rare case wherein she says there is no scleritis or episcleritis, clinically at least, but we have to keep that possibility in mind always.
Yes.
So especially when there is an autoimmune disease underlying.
Yes.
Yeah. So we'll go on to the next case of glaucoma.
Yes.
Rajiv? I'll share the screen now.
Yeah, please share.
I'll share. And then we'll go on to the next speaker. And Dr. Vijaya will introduce Dr. Saiban.
So Sheben Sethi did her glaucoma fellowship at Shankar Nethralaya. So she did that when I was in sabbatical for 2 years. So I didn't have much interaction with her, but what I heard from others was she is very smart, very good with her work. So I'm sure all the credit she has is because of her smartness. At her very young age, you can look at if you look at the slide, you will know that she has achieved so much. I'm sure she has a bright future. So with these few words, I will ask Shehwan to present her case.
Dr. Shaiban?
Yes, sir.
Yes, floor is yours.
Thank you so much, ma'am. It was quite humbling to hear such nice words from you, and you've always been my role model. So without much ado, I'll start with my presentation. So good evening, everyone. So can't handle so much pressure is what I heard myself say very early in my career when I had to deal with this daunting case. It's not a heroic case, but it is interesting in the way that it raises a lot of questions and has many lessons to teach. In the end, it will be fascinating to know what our experienced learned teachers would have done differently to tackle this case. So this is a case of pseudophakic neovascular glaucoma, wherein the patient presented with an IOP of 35 millimeters of mercury. She was already on 3 AGM, steroids and cycloplegics, and gonioscopy showed 270-degree cynical angle closure. First of all, what we did was bring the IOP under control by putting the patient on maximally tolerated medical therapy. 3 sittings of PRP was done thereafter. The NVI started showing regression soon after. But since the patient was extremely intolerant to Dimox, surgery was planned early, about 1 week after the last sitting of PRP. I did a trabeculectomy since the conjunctiva was healthy and mobile. A 1-minute mitomycin C was used, and a routine trabeculectomy was done in a loose apical suture. Just one apical suture was placed, and the conjunctiva was closed after placing an ologen implant. Intravitreal ranibizumab was injected at the end of the surgery. The patient was fine up until the third post-op day when she presented with an IOP of 50 millimeters of mercury, which was refractory to any mannitol or any other treatment. So on careful examination, there was peaking of the iris. So it seemed like it may be the cause of blocking the stoma. So an iris repositioning was done and the pupil became rounder. However, the drop in the IOP was not satisfactory to me. And still unable to achieve good IOP control and seeing a vascularized bleb, I thought of attempting an early bleb needling with apical suture removal in this case. Now, this was pretty much a blind procedure because, mind you, the ologen implant was still sitting there under the conjunctiva. So, although I was not sure of the extent of successful dissection, post-op reduction in IOP from 47 to 26 was encouraging. The very next day, I again did minimal slit lamp bleb needling with direct injection of 5-FU into the bleb since the bleb was vascularized. At the time, a small air bubble escaped into the AC. I sort of felt happy that at least the filtration path is established, and luckily the IOP also dropped down to 8 millimeters of mercury after an hour or so. So I finally took a sigh of relief thinking that things are headed in the right direction. But little did I know that the very next day, the patient will present with a decreased vision. There was florid anterior chamber reaction, multiple DM folds and corneal edema. So what I was looking at was something I had never seen before. The patient actually developed a 5-FU toxicity due to inadvertent entry of 5-FU into the anterior chamber. So no further interventions were undertaken except just the patient was advised home ocular massage. So we all know very well that tackling NVG cases can be quite challenging and outcomes are often unpredictable. So here I'll share some lessons that we can learn from this case that can improve surgical outcomes. The first pearl that I would like to give is always give a 2 to 3 week gap between the last PRP session and glaucoma surgery. This will allow for a full regression of NVI and a quieter eye for better post-op results. The second pearl is that ologen is absolutely a bad choice in such cases. In fact, I've stopped doing ologen altogether when you know that the demand for bleb modulation is high. Secondly, assessing bleb function also becomes more difficult because the bleb already looks very elevated from the implant itself. So ologen precludes visibility, suture removal will be a challenge, and so on and so forth. Pearl number 3 is unless IOP is very high, one must always give a shot of giving an intravitreal anti-VEGF injection a week preoperatively. This will improve the success rate significantly from 62% to 95% as reported in literature. Pearl number 4 is that be very cautious with your delivery of 5-FU injections. Although direct injection of 5-FU into the bleb has shown to give good results with immediate post-op IOP lowering, which is what I based my case on. But this case highlights the fact that we cannot ignore that toxicity can happen. Otherwise, there are very few cases reported in literature of 5-FU endothelial toxicity in particular. However, interestingly, I did come across one case report which says that the corneal changes remained even after 6 months. So the final and the most important debate is the choice of the right surgical modality in such cases. My patient could not afford an AGV, which can be the case commonly in India. TRAB is an equally good option. There still does not exist any clear evidence or consistent basis in literature for choosing one over the other. However, there are certain specific indications where TRAB is relatively contraindicated. So finally, I hope this helped. I'd like to end by expressing my utmost gratitude to being invited to be a part of this illustrious SN alumni meet and for being given the opportunity to speak in front of my revered teachers. I do have a list of questions that will call for interesting discussion if the panelists think that is relevant and if I have a little
10
time.
minutes.
So, the questions I'd like to throw to the panelists would be, what should have been the right surgical modality, TRAB or tube to begin with? Was doing a slit lamp bleb needling with direct injection of 5-FU into the bleb a bad move? And after the 5-FU toxicity develops and the bleb is still vascularized, what should you continue doing? Should you give it inferiorly or just stop any interventions like I did? And what did they think about combining an anti-VEGF at the same time as trabeculectomy if surgery is hurried due to very high IOPs? Also, any experience with putting an anti-VEGF directly into the bleb in neovascular glaucoma? I'll end there. Thank you so much.
Thank you. Thank you so much, Saiban. Simply fantastic. Over to Vijaya and Vinay Nangia for their discussion on this particular case. Before I ask the panelists, did you give intracameral anti-VEGF as well? Saiban.
She gave intravitreal.
I gave intravitreal at the end of the trabeculectomy because I had to hurry up the surgery since the patient's IOP was about 39-40 without Dimox and maximum AGMs.
Okay. No, preoperatively, you didn't give intracameral?
No, sir.
Okay. Vijaya?
Yeah. So basically, I think a very difficult case. I think you tried your best to manage the problem. Congratulations. So patient had NVG in angle closure stage. So NVG with angle closure, almost 270 degrees is closed.
Yeah.
So when 270 degrees is closed, the amount of the vascularization also will be much less in the eye. So routinely what we do is we do the, like what you have done, we do the PRP, that is perfectly correct. Only thing we do differently is we give the anti-VEGF 24 to 48 hours before the trabeculectomy. That kind of reduces the amount of the remaining vessels. Then you can do the trab is not a bad choice. Trab can be done, but I don't see the need for the Ologen when you have already used the mitomycin C. So maybe taking a multiple releasable sutures would have been a better idea. And the fact that the pupil peaked indicates probably PI is not sufficient, because otherwise the people never gets peaked into the trabeculectomy site. This can happen because there is anatomical alteration in the angle because of the contraction of the membrane due to the neovascularization. So there is an alteration. Maybe when you caught the iris, the PI was not good enough. So these are some of the things that you can keep it in mind. Post-operatively, needling, you can definitely do it. But usually we don't give the 5-FU into the bleb. We give the 5-FU away from the bleb when you do the needling, because it's already, there is a patent opening. But fortunately, most of the time, the 5-FU toxicity because of the entry of 5-FU into the antechamber resolves over a period of time. So what happened in your patient? Did she?
It took about a month. I had to
Yes.
steroids and put the patient on cycloplegics. But in a month's time, she was back to normal. Her IOP was also stable.
Yes, it happens. So these are the few of the modification. Whether the tube or the trab, I think trab also works if you take all these precautions. Yes, many people directly go for the tube. If you go for the tube, there is no need to rush in for doing a anti-VEGF 24 hours to 48 hours before, because most of the angiogenic factors gets drained out through the tube, so that the bleeding and other complications are less. Vinay?
Thank you, Saiban, and thank you, Vijay. I think that, there are so many lessons, and as a young ophthalmologist, you've had to deal with so much. So I think I'll just go by whatever points of discussion you had. Normally, we do give anti-VEGF pre-operatively. It would be rare to give it intraoperatively, but that is permissible also. And we used to try to, do anti-VEGF both in the anterior chamber as well as in the posterior chamber, but I think it really doesn't matter. I think either way, it's going to work well. And because it's all coming from the posterior chamber, the first preference is actually to do a intravitreal anti-VEGF, ideally pre-operatively. So there was a time when I would like to do trabeculectomy with mitomycin in all these patients. But we've shifted now that almost all such patients will undergo a glaucoma drainage device because there is a greater certainty of outcome. So you're not struggling with the trab post-operatively so much. And I wouldn't use Ologen because I consider Ologen, as Vijaya pointed out, to be at a very low level in terms of its anti-fibrotic efficacy. And also that, you know, since a long time when we initially started using Ologen, not being able to access the sutures and placing the Ologen on the scleral flap was a big challenge. So we never ever placed it on the scleral flap. We always placed it up and to the left of the scleral flap, so that whatever anti-fibrotic effect was there, we expected it would diffuse to that area, but that we always had an option to do laser suture lysis or remove the sutures, you know. And I don't use 5-FU because we used it long time back, but in Indian eyes, we never felt that it had the kind of effect that it did in white Caucasian eyes, actually, where they do use it quite a bit. And I don't use it superiorly also because of what happened, because that's, as you know, it's a terrifying experience to go through that, actually. And also, I would never do something like this on the slit lamp. I think that, you know, it's much more better, and we're much better in control when we have the patient lying down and we're using a microscope, and then you can much better plan where the tip of the needle is going. But in general, in such a patient with neovascular glaucoma, where you expect a lot of anti-fibrotic reaction, 5-FU is a little bit weak for such a patient, actually. So I think there were lots of lessons for all of us in this patient. And you know, I think this is the way that maybe that we can avoid something like this happening, and there may be a better chance of the patient doing better, actually. Thank you. Thank you for this great case.
Thank you so much, sir. Thank you, ma'am, for your input.
Very nice.
Yeah. Thank you.
Can I make a comment, Mohan?
Yeah. Please, Kerubi.
See, the thing is that it's a case of neovascular glaucoma, which is definitely related to some proliferative process going on behind, either diabetic or whatever. So the thing is that in this case, suppose say you give the anti-VEGF, you have to give the anti-VEGF because that will take care of a lot of blood vessels which are in the angle. But to reduce it, sometimes you can do an ARC, or you can do a transconjunctival diopexy, transscleral, diopexy, to further reduce the pressure. So if your pressure gets reduced without it and it opens up the pupil, then you can treat whatever is remaining at the back part and get an effective control without having to do any kind of surgery.
Harabi, can I intervene here? I think they have done the good PRP.
Yeah, they've done
They
a good
have taken care of the posterior pathology. After that only they have handled the glaucoma.
Vijaya, here I would like to say that there are a lot of cases of diabetic, especially diabetic macular edemas of this, where you find that even in spite of anti-VEGFs and even in spite of full PRP, the stimulus comes from the anterior retina. So the thing is that nowadays, the thing is that if the refractory diabetic macular edemas are not resolving with the anti-VEGF therapies or the laser, you tackle the anterior retina to try to get a solution to your problem.
Anterior cryopexy can be done. That's a good option.
I agree
Or
with
a
Dr.
diopexy
Karabi. I
with,
think this patient was what she has mentioned is a post-CRVO. Post-CRVO, if I remember, like the first slide shows post-CRVO. And
Yeah.
I think ARC definitely I would have added.
Is there any role for cyclodiode or G6 laser?
Yeah, you can do that also in two
I'm asking.
settings.
Yeah, no problem.
No, I think when surgically she was able to do a procedure, I mean, we do go for such a procedure when visual potential is poor, then you consider the ciliary ablation.
Okay.
But the only thing you have to remember is whenever the ciliary ablation is done in neovascular glaucomas, you have to have a very conservative approach. So what happens? Pressures may be high. At one stage, the vascularization gets settled down and the pathology settles down. Then there is a hyposecretion of the aqueous. These eyes will become hypotonous if you tend to treat them vigorously with the ciliary ablation during the NVG stage. So you have to have a very cautious approach. Even if you do the ciliary ablation, it has to be only for 180 degrees, not more than that.
Okay.
Yeah, Shaban has a point.
I'll ask a quick question. So,
Yes.
ma'am, since so much needs to be done to just control the neovascularization and inflammation preoperatively. Now, in a case like this, with wherein the patient without Dimox and on maximum AGMs has a pressure of 40, what do you do? How do you buy time to do all these procedures and then go on to the surgery?
No, let me tell you, the patient has 40 pressure because it's a secondary problem. The disc is supposed to be fairly healthy unless the CRVO is related to the glaucoma. If the CRVO is not related to the glaucoma, a pressure of 40 for few days is not going to kill the nerve. As long as you are able to bring it down to 20s or 30s, that is fine. You can allow, because the pathology is related to the posterior segment. Unless you take care of the posterior segment well, you cannot control the glaucoma. So taking care of the posterior segment is the first thing.
So 2 to 3 weeks of having an IOP of 40 is acceptable.
It's not 40. I think if you give the anti-glaucoma medication, the 40 will come down to 30.
Come down. Dimox or something like that.
Yeah.
See, also, when you give anti-VEGF, it's shown that it's 24 to 48 hours, you have iris neovascularization going down. So that will ease your things also.
No, but the angle is close to 70 degrees.
Yeah, because that's what I was going to say. Almost 3/4 angle is close, but then 3/4 angle is close. Do you think then it work here, but because glaucoma implant would have been a better, tube implant is better because 3/4 are already closed?
Yes, definitely a tube implant is a better option, but angle closure, in the past we used to do traps. They used to work. So it is a little more laborious than the tube. But you can. The fact that patient can't afford, that's the only option she had.
I think what Saiban was pointing out was that sometimes, these patients, even if you got them on maximal medical therapy, they don't really go down less than 40 millimeters of mercury. That's the nature of this condition. But I do want to tell you that you don't really need to wait for 3 weeks. Why would you wait for 3 weeks? If there is a patient,
48 hours is what we do.
Yes, I mean, just for a few days. So that means it gives you time to convince the patient, for the patient to make up his mind, for you to give that anti-VEGF before you go in and operate, 2 days later or 3 days later. So that would be the kind of time, and you've already explained to the patient that this is what is happening. So you're gently nudging the patient also to make a quick decision, actually.
Okay, thank you very much.
Thank you.
Thank you.
Yeah, Vijaya and Vinay Nangia for the wonderful discussion. And of course, Sweta and Saiban for the very nice glaucoma.
Yeah, very, very well.
Over to
Thank you, both of you.
We're running short of time. Over to Dr. Rajiv Raman for the retina session.
So we'll move to the next session, and I would like to welcome the panelists, Dr. Mahesh Shanmugam, Dr. GIRISH Rao, and Dr. Pramod Bende. And we have the first speaker, Dr. Abhishek Kothari. Dr. Pramod Bende, sir, can you introduce Dr. Abhishek?
Good evening, everybody, and it's a pleasure to introduce Abhishek. So I know him as a fellowship days, very, very active, energetic, and always up to date, whatever is here, knowledge and available at that time. Very, very enthusiastic, exceptionally good surgical hand, and really pleasure to see him again here. So he did his post-graduation from SMS Medical College, Jaipur. VR fellowship at SN between 2006 and 8. He worked as a small stint at a Arvind group of hospitals. He was in a Coimbatore group part there, and there he bring out a big book as far as VR surgery principle and practices along with Dr. Narendran. And it's a proud to be contributing for him, helping him to get that book out. He has many more awards to his credit, and ultimately decided to start on his own clinic, and he's now director and vitreoretinal surgeon at Pink City Eye and Retina Center, Jaipur. And Abhishek, so nice to see you. Over to you.
Thank you so much for your kind words. Let me just start sharing my screen.
As Abhishek is doing it, let me just butt in and say that he has a brilliant engineering mind as well. And he was one of the first few to talk about the mask, which mask is suitable in COVID and all that.
Yes, yes.
So this is the retina team that is going to present today. This was about 10 years back when I had more hair. Manoj Khatri had more black hair, and Darius had a lot less to care. It was
Don't talk about hair, man.
Pardon?
Don't talk about hair.
Yeah, you're
I
hurting
agree. I
somebody.
agree.
So this was just after our FRCS exam at Darius's place. So coming to the topic of the talk now. So PEDs are a place where retina surgeons, fear of venturing into cases that have large PEDs. And the main fear here is that PEDs, when you give them anti-VEGF injections, there is a RP rip. So I'm just presenting a few cases where we use a different approach to anti-VEGF treatment so that we did not have any rip and the PED rested in peace. I have no financial disclosures. So this is the first case where this gentleman, this is the left eye which had a large scar, and the right eye had a large PED, and the vision had come down to 6/18 and 12. This is the only seeing eye. And we gave the routine treatment, that is anti-VEGF injection. And this is what happened after the first injection. There was a large RP rip, and not much you can do. The fovea was also involved in the rip. And after the second injection, things started to settle down, but then the vision was permanently reduced to about 6/36. So after this, we decided that this is again another case. This guy had the left eye eviscerated, and the right eye, he was following up with us, had very good vision at this stage. You can see that the fovea is all right. And on the side, there is a large hemorrhagic PED creeping in. After a few days, this is how the progression went. The PED increased, and then you had a large dome-shaped PED, hemorrhagic PED, on top of which the fovea was resting. Now, and this was the ICG, just saying that there was a plaque, there's no PCV, no polypal choroidal vasculopathy. So here we give him systemic Avastin. By the way, this guy is a hypertensive, has had a stroke, and has had a has had a stenting also. So I sent him to the oncologist, got a fitness, and gave him systemic Avastin, 5 milligram per kg, 2 doses, 15 days apart, and look at what happened. This PED started settling down very nicely. This is at 15 days, 1.5 months, and at 3 months, the PED is much flatter, no rip, and the vision has also improved. The other thing about systemic Avastin is that the effect lasts for quite some time. So till 5 months, nothing happened. At the 6 months visit, some SRF started creeping in again, and the patient decided to wait for a month before he got the therapy. This is when we started giving him Lucentis injections. Now that the PED is not very tall, we don't have that big a fear of the RP ripping. We gave him Lucentis, and he got 3 injections of Lucentis, which led to the SRF resolution. Again, after about 3-4 months, the SRF started creeping back again. This is another case, this 80-year-old lady, hypertensive. She, in the left eye, she has a large area of geographic atrophy, which is involved the fovea, visible on the autofluorescence. In the other eye, there's a huge PED that I'm pointing to here. It's more clear in the autofluorescence map. The lady had a little bit of cataract, so the images are not that great. On the angiogram, this is what it looked like. An occult CNVM basically, no PCV on the ICG, and this is what the OCT looked like. Again, large PED. Now, what do we do? Again, we gave her systemic Avastin, and this is the sequence of event. This is at the presentation. Then on the next, this one, this is at about 5 days after the injection, about 1 month after the injection, 1.5, then 2 months, and this image is at about 2.5 to 3 months after the injection. So at 3.5 months, this was the picture. It had settled down quite a bit. At 4 months, we gave her an Eylea injection. And this is the bottom corner image is what happened at, what the image is at 6 months after treatment, initially with systemic Avastin and then with one intravitreal Eylea. This settled down very well. So PEDs are a treacherous, terrain. They are very stubborn. They don't resolve that easily as does a classic CNVM or other lesions. And there are certain features, especially these tall peak tense PEDs, that predispose them to the risk of RIP. RIP has been reported anywhere between 5 to 25%. That is almost up to 1/4 can actually RIP with therapy. So, when in our literature search, when we were thinking of ways to deal safely with these patients, we found that the first time that bevacizumab had been used in AMD was the systemic bevacizumab. And when I looked at these papers, if you look at the associated pics, a lot of them had PEDs and a lot of them had large PEDs. And when I kind of compiled the data in all these papers, you have approximately 100 cases of PEDs where systemic Avastin has been given and not a single RIP actually happened. So that is what prompted us to start using it. There are also some papers on the pathomechanism of RIP, which according to us, why it does not RIP when you give systemic Avastin is when you give intravitreal therapy, it's the superficial layers that contract before the deeper layers. So it creates a balloon-like tense effect. When you give it systemically, all the layers deterges almost at the same time in the same pace, and that leads to settling down of the PET without actually causing a RIP. As far as the main concern with this therapy is systemic safety, hypertension is the most common side effect. Gastrointestinal perforation is actually 1 in 10,000. This is the most common serious adverse effect. We have about 6 patients that we have given Avastin. None of them has had any problem except one patient who had a 8 mm rise of BP, which is not very, significant. So I'll conclude here by saying that systemic Avastin is an option for AMD with high or peak PEDs, tense PEDs, especially those patients that are one-eyed and you cannot take a risk of a RPE RIP. It's very safe and controlled. There's a lot of negative, rather information circulating around even with the intravitreal injection. It's not that bad. Our onco friends use it on a very routine basis. And the best part is that systemic Avastin is a prolonged action. Once you give it, the neovascular activity is almost silent for 3 to 4 months, and only after 4.5 months does the activity start coming back again. And you can always, once you have deterged or made the PD flatter or shallower, you can always shift to intravitreal therapy after the flattening and still continue safe therapy. Thank you.
Thank you, Abhishek. Very nicely illustrated cases, and I would like the panelists to give their opinion. Dr. MPS, sir.
Yeah, Rajiv, it was a very interesting presentation, Dr. Abhishek. Congratulations. I have heard this before as well earlier. It's a different approach. Only thing is, like, if you had a SDOCT or an SSOCT looking at the choroidal thickness and choroidal how it behaves, it would have given us some more information. Why do you think, Dr. Abhishek, is it the lesser dosage which you think is working in the form of making the PED go down slower, or is it the slowness with which it happens, Dr. Abhishek?
So when we give intravitreal injection and it goes across the retina and starts acting on the neovascular complex, it acts on the superficial neovascular complex first before it reaches the deeper vessels. So the superficial part of the CNVM will start contracting and fibrosing first before the deeper vessels would actually, or deeper part of the complex would. So that would create a balloon-like effect. The upper part is contracting and the inner contents are still at the, at a higher tension. Probably when we give systemic Avastin, it reaches all the components of the CNVM and all the areas of CNVM uniformly and at a far higher concentration, leading to a uniform fibrosis and flattening of the PED. That's probably the mechanism, sir.
But you really didn't have a notched PED with the CNVM in one side to cause a RIP, isn't it? Any of these? Because like you had large PEDs, but they were not notched PEDs with CNVM in one side where it can contract and cause a RIP. And even otherwise, like I agree, it's the incidence of RIP itself is probably around 6 to 13%, depending on what the agents are. So it's a very interesting approach. Another thing is like even oncologists give anti-VEGF every month or every 15 days. So how do you explain that the effect lasted for about 3 to 4 months actually in your case?
There, because it's the indication is the tumor, which is quite a fast growing and a very vascular complex. There is a lot of cellularity and anti-VEGF being produced. Whereas here it's much the anti-VEGF the VEGF levels and the kind of neovascularization will be much lesser. The VEGF drive would be probably much lesser than a tumor. That's
the dosage of anti-VEGF you give is also much lesser compared to an intravitreal dosage, isn't it? When you give a 4 milligram IV versus what you give intravitreally, intravitreal dose is much higher than what would reach the eye through a systemic circulation when you give 4 milligram.
Correct. but the dose is the same that the onco people use. They also use this.
No, I'm saying from the eye point of view.
Yeah,
from the eye point of view, what we give intravitreal is many times higher than what we would have given IV, and then what would have reached the eye.
But my guess, sir, is that what we give in the eye is quite higher. But I think what reaches the CNVM complex must be much lesser, because it has to go through intact retina, it has to go through RPE, and then reach the occult CNVM. So probably a very small amount of what is being introduced into the vitreous would probably reach the membrane complex.
Yeah, I agree. Like one thing I believe is something given through systemic circulation. What comes in through the choroid sometimes seems to work better, particularly in retinoblastoma for that matter. You give an intravitreal injection of anti-VEGF, chemotherapeutic agent, it works only on the seeds. It doesn't work on the solid tumor. But in contrast, if you give IV, it tends to work on the solid tumor. So what comes through the systemic circulation, through the choroidal circulation or the retinal circulation, seems to work better.
So that also sounds more logical, because when you part as a circulatory system and when you're flowing through blood, it's have a access is much better than having a diffusion through the from vitreous cavity to the retina and going reaching inside. Probably that's the thing. I do not have data firsthand as far as half-life, systemic half-life is concerned. When I'm talking about systemic introduction, that also adds on, and maybe also I feel like incidence is less. Probably the amount which enters the eye through systemic circulation, total dose may be less also, probably to have a gradual effect. Then really we have a exaggerated concentration with your immediate injection during that immediate first day or 2 or 3, but you have a sudden increase in the concentration as long as you have a systemic circulation going through systemic circulation. So, I mean, yes, it is a different, interesting concept. What Mahesh just mentioned, for a tumors, you do chemo reduction and then do local treatment, something like that. We are looking back again, and I think revisiting, and it's worth exploring. Suppose you have other issues and like when you particularly see really dome-shaped PEDs, it's worth trying, I would say.
Dr. Girish.
Good presentation, Abhishek. I just wanted to ask you, do you feel there is some role of the jet effect of the injection itself, the physical turbulence into the vitreous, whether that has any role in the RPE rip? Because have you really looked at the time frame when the rip occurs after the injection?
Probably very less, sir, because I think most of us who give injections, we do give it at a fairly slow pace. I mean, take care usually not to inject it. And I think another thing about this jet, what I always feel that if it's a non-vitrectomized eye, there is vitreous floating around, the jelly would actually cushion the impact. I mean, I really don't think there will be such a huge jet of the fluid, reaching directly at the PED, when enough to cause a rip probably.
Abhishek,
just one more question. In one of your cases, you showed a very good response to the systemic Avastin, but intravitreally you shifted to Eylea. Would it make sense to just stick to the Avastin intravitreally also, since the systemic effect is quite good?
Yeah, I mean, patient was affording. So between Eylea and Avastin or Lucentis for that matter, I always give the choice to the patient and I tell them the pros and the cons. I never pick the injection for the patient. So the patient chose Eylea because they were quite affording. So I let them take the Eylea. Had they told me that and by the way, they had an insurance cover, which was, they were getting everything free. So they opted for Eylea. But given that the activity was very less, if you see, when I gave the Eylea, there was hardly anything left. I think Avastin would have done an equally good job.
Thank you.
Yeah, Abhishek, nice approach. It is what you see. One thing which you really showed, that systemic Avastin, systemic anti-VEGF works. But I think telling that it reduces the rip, I don't think would be a right thing at this stage, because as we know, even with the intravitreal, it is less than 20%. So no, probably you may need to do more cases to come to that conclusion that it causes less rip as compared to the intravitreal. But yes, definitely this does suggest that anti-VEGF systemic works, and there are probable explanations which we thought probably may reduce the rip. But I would suggest a little more data would give us a real answer whether it really reduces the rip.
Quite correct, sir. I mean, the thing is that, we don't give it to all patients. We give it to very selected patients. So, and especially in a practice like mine, which is a private practice, these kind of numbers is a little more difficult to get. The probably, I would say, insinuation that I made that it is probably safer is because if you look at the papers that have given systemic, and if you look at their cases as to how many had occult, what is the percentage of classic, occult and all, they have approximately about 100 cases where they had PEDs, and not a single RIP has been reported in those papers. Even if we go by the lower figure, not 13%, but 6%, so at least, I mean, in 100, probably 1 or 2 probably should have had a RIP. I mean, if we were saying that, you know, there may not be a big difference. So that is, it's probably, yeah, it'll take time. And I mean, 6 cases is not really something that, you know, I can stake something, but yes, probably in an institute where you get a lot of such cases, I think it may be a very good idea to try this out. And one of the points that I wanted to make is that there is a lot of noise being made as to the systemic safety and the cardiovascular complications, stroke, heart attack. If you allow me 30 seconds, I'll share with you what happened to the patient, the first patient case, RKG.
Later.
This gentleman, I'll just finish it in 30 seconds, sir. So this gentleman received the Avastin, he was perfectly all right. Then he received 3 Lucentis. And then he was again all right. Then the fluid came back. We gave another Lucentis. And about 1.5 years after the systemic Avastin, and about 2 months after the last Lucentis, he developed a stroke. Now, that is probably because of the underlying conditions, not because of either the, I don't even blame Lucentis for that. It's not the Lucentis, it's not the Avastin. I mean, it couldn't have, you know, it's like birbal ki khichdi, can't have an effect after 1.5 years. But then, yeah, these patients, we know that they are at a little risk. We can always send them to an oncologist for a systemic workup and give it safely.
Thanks, Abhishek. And we'll go to the next speaker, Dr. Darash Shroff. And I would request Dr. Girish to just introduce him. Dr. Girish.
Girish, yeah.
So Darash comes from a very elite ophthalmologist family from Delhi. He's done his schooling and then post-graduation from Delhi University Guru Nanak Center, and did his VR fellowship between 2006 and 8 at SN. He's also done his FRCS Glasgow in 10, and he's been a very prolific surgeon, and also won the prestigious Reed Buckley Award from the ASRS for his video in 2016. So here I present Darash. Can you have your presentation?
Thank you, sir. Thank you for your kind words. I'll be presenting a very challenging retinal detachment in a patient with a corneal opacity. So it's in the form of a video. So I'll just share my screen. We, as retina surgeons, face constant challenges. Some of these may be so taxing that they make us feel like we're trying to roll an immense boulder up a hill, only to fail. One of the most daunting tasks is managing a retinal detachment in an only-eyed person with a corneal opacity. A 40-year-old uniocular man presented to us with sudden loss of vision in the left eye. He gave a history of loss of vision in the right eye 30 years ago due to post-chickenpox Stevens-Johnson syndrome. This eye showed a total leukomatous corneal opacity. The left eye with recent vision loss showed a vascularized corneal scar involving the nasal two-thirds of the cornea, along with a slightly decentered IOL. Due to the corneal opacity, it was difficult to visualize the macula involving temporal retinal detachment on indirect ophthalmoscopy. The presence and extent of RD was confirmed on ultrasound B-scan. Intraoperative visualization of the retina posed a major challenge. We were worried about the risk of causing iatrogenic retinal tears if we performed vitrectomy in this eye. The patient was comfortable with the level of vision in his only seeing eye prior to the recent RD, and so we decided in favor of scleral buckling. The challenge we faced in doing indirect ophthalmoscopy made us go back to the basics of optics. During indirect ophthalmoscopy, the illumination beam and the line of vision need to coincide in order to view the fundus. In this case, that proved to be a challenge as the nasal corneal opacity prevented illumination of the temporal retina, caused scattering of light and glare, and interfered with adequate visualization of the temporal retinal detachment. We realized that a conventional scleral buckling procedure would not be possible in this situation. This led us to think out of the box for a solution. We planned a modified scleral buckling procedure using chandelier endo-illumination with a wide-angle viewing system. This led to a separation of the illumination from the viewing system, less scattering of light, and a wide field of view through the available clear cornea. A 25-gauge pars plana cannula was placed superiorly at 3.5 millimeters from the limbus, and the chandelier light was inserted and secured. Under its illumination, the retinal detachment could be visualized through the operating microscope on the wide-angle viewing system. A small retinal hole was localized and cryotherapy was applied. 3 anchor sutures were placed. A 280 silicone explant was placed, covering the superotemporal quadrant. Good buccal indentation effect was noted. 2 months post-operatively, the patient had restoration of vision to pre-detachment values of 20 by 200 N12, and the retina had settled well on the buccal. Scleral buckling using 25-gauge chandelier endo-illumination is a recent modification of classical scleral buckling. We present the first instance to our knowledge of it being successfully used to tackle a retinal detachment in an eye with a significant corneal opacity. Thinking out of the box and going back to the principles of optics help us get a good surgical result in this extremely challenging case, as well as a ray of hope and new lease of life for our patient.
Fantastic.
Fantastic. Very well presented case and really well managed.
Yeah, I think a very good surgery, Darius, and out of the box, but something which is very innovative, and it's almost like a minimally invasive surgery, but trying to get the maximum out of thing. Because the only other option, conventionally thinking, if we go, would have been to either do a PK combined vitrectomy, and as you said, it would be fraught with its own complications, or an alternative could have been doing a endoscopic surgery. I mean, very few centers have that facility. So I think in that term, this chandelier approach has been very well for this patient. Though I'm sure in due course, if the corneal progression does increase, he might need a PK, but at least from the VR, the retina point of view, you're safe because you have a well-placed buccal. So excellent surgery. I'll open it up to Dr. Mahesh and PV for comments.
Yeah, Darius, congrats, very nicely done surgery. One other option in the earlier days when we used to do only buckles was what we call as end-to-end buckle. So if it was only temporal detachment, from one end of the detachment to the other end of the detachment, you can place a 276 or a 279. And it was a kind of blind buckle with blind cryo, which we sometimes used to do when we were not able to localize the break or even the media was compromised. But of course, now with the wide angle system, it's pretty easy to go inside, separating the illumination from the visualization and find out the breaks quite easily.
Yeah, excellent surgery, Darius. And basically, what we need to think is what you're shown. Just sit back, think what are the practical issues, and find your way out. I think that just shows, and with the available resources, still we can work out. Yes, you have a endoscopic vitrectomy, if that's a different issue. And You can think of like a lot of other high-tech instrument, combine PK, all those stuff. And what happened, what you need to know is this is what I have my resources and I need to handle, and how I can get best out of it without compromising outcome. And that is what I think you have shown here. I think excellent surgery.
I'd like to thank you and all my teachers, because at SN we are taught about the basics of buckles so well. I mean, I don't think anywhere else in the country or world nowadays people are exposed. So I'm blessed to have all of you as my teachers, and so that we can do minimal because this patient was very clear that he didn't want his cornea changed because he had lost the other eye. He was very happy with the kind of vision he had. The corneal opacity looks very horrific to us, but his level of ambulatory vision was fine for whatever work he was doing. So we offered him PK. We said we'll put a TPK, etc. But he was not willing to take a chance. So we thought first, let us do a minimum. Less is more. Let's do less, and then of course later we would do it, or may refer to SN also for that later. But now he's quite happy for last 3 years. I think touchwood is fine.
Very nice. Very nice.
Yeah. So we'll go to the next presentation by Dr. Manoj, and I'll just share the screen. Can you just 1 minute, Manoj?
Yes, sir, I'm there.
Yeah, I would just request Dr. MPS sir to introduce Manoj.
I know Manoj since the time he was a postgraduate, and it's hard to believe that it's been very short time, but like the way his career has taken off, it's really, when you say meteor, this is his career. So you can see pretty well the whole page is filled with his accomplishments. And from the time to PG, from the time of him being a postgraduate to where he is now, has been one meteoric rise, and something which the youngsters should probably emulate and follow. Congrats, Manoj, and let's go on to your presentation.
Thank you very much, sir, for the kind words. Is my presentation visible?
Yes.
Yes, Manoj.
Thank you so much, sir. So coming to some of the common problems seen in routine day-to-day OPDs nowadays with all of us, not only by retina specialists, but these kind of cases we see commonly with all of us. One such case, though I have no financial interest, was chasing how far you want to chase presence or absence of subretinal fluid, as a couple of things have been shown by Abhishek as well. So we look at this 83-year-old lady referred my very dear colleague here. She had been already diagnosed as having wet age-related macular degeneration in both eyes, right eye more than the left eye. And also the doubt of PCV considering the age and the female gender and so on. However, the vision was fairly okay. Patient was asymptomatic. In fact, when patient was sitting right across on my table, she said, "Can I not have any treatment, doctor?" I said, okay, but somehow I convinced her for further investigations, and you can see angiogram of both the eyes showing lacy pattern of choroidal neovascular membrane, and this is OCT of the left eye, although we have treated both eyes, but we'll just ignore left eye as of now. In right eye, when we looked into the OCT in further details, classical features of any classic occult choroidal neovascular membrane, you have intraretinal component, hyperreflective ecos. There is some hyperreflectivity on the bump of PED, suggesting this might be a PCV. And we gave her, treatment options. Though this stage itself, patient refused because the visual acuity, mind you, was quite good. She said, "Let me leave me alone." Somehow I convinced her for treatment, and she opted for bevacizumab. Fine, we gave bevacizumab. This was a monthly injection, 2 injections. Not much of a change apart from some intraretinal components which settled down over a period. But this fluid, which I was not very convinced, right lying below the subfoveal region, was not budging. And what you can see here, there is a presence of some RP fluid as well, which was increasing with treatment. However, we persuaded with treatment, and after 3 more monthly bevacizumab injections, there was a drop in vision from 6.9, she became 6.12. There was thickening of the outer retinal component, also worsening of the CNM complex, and you can see the notch speed is quite well now. So in and all, it tells us that the CNM complex is not responding to the treatment what you are offering. And also you are looking something called as a pachychoroid spectrum as well, which is, thickened choroid here, which is also contributing to the increased vascularity component. So where do we land in 5 monthly injections, which at this age, such a cooperative patient listening to you for every visit, and you land up in a less visit. Now the challenge to myself, I was asking whether I'm treating her correctly, whether my diagnosis is correct. I was not able to do the ICG at first go, and then subsequently when I asked her for a FA-ICG repeat, she said, I don't want to do it further. Then I said, okay, maybe there is a tachyphylaxis component which is well documented, and there is also switchover therapy between anti-VEGFs to one group to the other group, rather than anti-VEGF component to the other anti-VEGF component. So I did the same. However, there was not much of change in the CNVM complex after shifting from bevacizumab to ranibizumab. And this was, mind you, after 4 more monthly injections. So in total, we are at 9 injection stage, and still we are looking at something on a similar kind of a pathology. Though there was a marginal improvement in visual acuity from 612 to 69, but I was still not very happy with the way I'm approaching with the treatment protocol for this particular patient. Though it was a straightforward case. So my doubts were what next? Though right eye has persistent subretinal fluid and active CNVM despite 8 to 9 monthly anti-VEGF injections with 2 different classes of drugs. We have certain data available from 2018 onwards on fluid study, and we all know that fluid in a way can be protective, or in a way it's not protective. However, as far as neovascular AMD goes, we need to treat all the fluid, especially the subretinal fluid, till the time it died out. So that's what we decided, but with various treatment options available, patient opted for wait, and we said, okay, let's give a gap of at least 1 month. And I always said, like, I had my own doubts whether I'm dealing with something else, not only a neovascular AMD, maybe IPCV or some kind of a dystrophy, which is also along with it. And though fluid study concluded small subretinal fluid can be tolerated, but in the real world scenario, it's not the case, as most of these patients need treatment. And but most of the clinical data also said that we need to chase all fluid to have good clinical outcomes. So what happens in this particular patient? I land up in more problem rather than solving the problem. The vision drastically dropped from 6.9 to 6.60. And you can see here, after 1 month gap of anti-VEGF, say after 9 injections, the CNVM complex per se increased. There were a lot of intraretinal changes. And the question here is, what next? 1 month prior, you had a beautifully looking retina. At least the CNVM was stabilizing. You could have just left it like that. So we didn't give hope, and convinced her something, a next level. So we had only one choice as aflibercept now. Given her options of aflibercept, somehow convinced her that, take frequent aflibercepts. There's a good chance of recovery, and all the more second eye was also under treatment. So this eye did regain a good amount of visual acuity after 4 monthly aflibercept injection in 636. At final outcome, say about after 7 aflibercepts, we did achieve the baseline 6.9 vision. But again, the CNVM complex per se is not flattening. So again, it tells us that, we need to address either a pachychoroid spectrum or the IPCB type of activity, maybe in form of a laser, which can be added, or just continue with the treat and extend type of a phenomena. So the thought process here is, tachyphylaxis is one thing. Sometimes we have to keep it in mind, though I'm not 100% sure whether I'm dealing with tachyphylaxis. Sometimes the CNVM per se is non-refractory to any kind of treatment. So that is also a possibility. Observation at 1 month, has got CNVM worsening at such a rapid pace, which has to be kept in mind. That counseling to the patients is very, very important. However, we had a lot of data available now. Look for biomarkers activity for any kind of choroidal neovascular membrane, and long-lasting effect, how we are going to achieve for one particular patient has to be kept in mind. Fluid study, though it gives us a lot of insight, due to paucity of time, we'll just skip this slide. So I just kept this for a theoretical discussion. But ultimately, what we need to know is that, does maintaining a dry retina matter? Yes, it does matter. It gives you a good visual acuity as well as the anatomical outcome. So try to dry retina as much as possible, and achieving and maintaining a dry macula in the ongoing long-term management of patients, especially with vascular AMD, should be priority for us. This includes intraretinal, subretinal, and sub-RP as well sometimes. So again, the question, treat or tolerate, this judgment is very critical. How are you going to make it? And everything has to be individualized for that particular patient. Though I always think in my mind, seeing a couple of real-time examples, that it should not be the only criteria. You should look at all the CNVM parameters as a whole, and documenting each and every finding, and especially if you have an access to anti-OCT changes, it gives you a lot of perspective and also helps us to prognosticate and the role of treatment. So treatment has to be at regular intervals, and persistence of vascular network as well as clinicians' persistence for treatment, is equally important. And we need to keep a broad horizon. Don't only stick to one class of anti-VEGF, and sometimes a mix and match also helps, vice versa, or treat and extend as a personalized therapy to the patient to be taken into the consideration, and ultimately giving the best outcomes available for our patients. Thank you very much for a patient hearing.
Thank you, Manoj. Any comments from the panelists? Manoj, can you
yeah, can I?
Yes, sir, please.
Yes, sir.
Manoj, very nicely presented case. One thing is currently, even without an ICG based on the OCT, we should be able to come to a decent conclusion of whether it's PCV or AMD. One is this patient did not have much of drusen in either of the eyes and had more of a pigment epithelial detachment. And what you're seeing is a classic flat irregular pigment epithelial detachment, what we call as FIPED. So you have those thumb-like PED on one side, and there is that flat irregular PED. Once again, suggesting that's possibly what you're looking at is a PCV. So if you had started off with aflibercept from the beginning, the patient may have responded better. That is one. Second is, if you see the OCTs carefully, you do see a lot of intraretinal hyperreflective dots,
yes,
right? Intraretinal as well as subretinal.
Yes.
So that is a sign of inflammation to me. So whenever the patient doesn't respond adequately to anti-VEGF and I find that intraretinal hyperreflective dots, what I do is add a steroid. So either an intravitreal Ozurdex, dexamethasone implant, or sometimes I have given triamcinolone. Sometimes you can give even subtenon triamcinolone. All these things somehow seem to work. Actually, these PCV patients who don't respond to anti-VEGF agents, you can add a bit of steroid. And actually, people are given even oral steroids, but I have not given oral steroids, either intravitreal or subtenon steroids. And these two things may have probably improved the outcomes in this patient.
I totally agree with you, sir. Yeah, the PCV diagnosis doubt I always had from the first go itself. So the rest of the things, as you rightly mentioned, sometimes we think these cases are just straightforward cases, will respond to either of the anti-VEGF, but you should be careful in selecting and counseling these patients.
Can I just add a point? Sorry.
Sorry. If you had had an octa, once again, that will also add to the diagnosis of PCV.
Correct, sir. Totally agree with you.
Can I just point out that in your first slide that you showed, there was, on the OCT, you could see as if there was pre-retinal inflammation in the vitreous. And in the next slide, after you'd given the first anti-VEGF injection, the vitreous was absolutely clear. So this is just alluding to what Dr. Mahesh just told us, that sometimes there may be an element of inflammation, and you may also see it when you are doing an OCT scan, actually.
Totally agree, sir. Yes.
It's a very good point what Mahesh has told. Yes. Steroids. Yeah.
Any other points, Dr. Girish, Dr. Pramod Bendeji?
I think, this drying fluid always we talk about as a double-edged sword, because if you have a consistently injecting and absolute dry retina, we know underlying RP atrophy, and we still also land up having a poor vision at the end with a dry retina. So it's always debatable, intraretinal, subretinal fluid, and I don't think we really have a proper answer for that as of now. When with the brolucizumab coming in and everybody's talking about now, again going back to same and multiple seminars only on a fluid under the retina or intraretinal fluid, and I think all of us, everybody must have talked about that. That just indicates we still have a lot to learn with that, actually.
Yeah, if I can just make another comment, that's more for the AMD, not for the PCV. PCV, I would rather have the PED flattened out and the subretinal fluid going away. Yeah. Because there is no evidence to say that in PCV we do get a geographic atrophy at the end of it. If there is a re-bleed, it happens. But in AMD, of course, it can give rise to atrophy.
I think one message which goes out, that if your fluid is not responding initially, think of alternative diagnosis.
That's what I had my own doubts for.
What you did was correct. Like, definitely no need to wait for long, but 1 or 2 injections you can switch over. What you did is absolutely right. Probably, as Dr. MPS sir rightly said, in this case where we are know that it's a PCV, probably you will. I would prefer to go to Eylea initially.
I just have one comment. After 6 monthly injections of aflibercept, I think it's time to look at a treat and extend strategy now.
Treat and extend, and probably combination I would have preferred in this case because initial monotherapy and you are seeing that it's coming.
Now he can also try Abhishek's option probably.
Systemic. Good idea.
But she is 83, so we need to be a little bit careful with that.
Oh yeah, I agree with that.
Yes. Thank you, Manoj. And we move to the next section.
One other option would be to try Ziv aflibercept.
Any experience for what the panelists say about Ziv? Dr. MP, sir, what about Ziv?
Because I've been using it on my patients and it gives kind of similar results to what Eylea gives,
Okay.
I haven't used it because with Avastin itself, we are a little bit on the thin ice. So I'm not sure with the Ziv aflibercept. That's the reason I have not used it. But anyway, the aflibercept people have brought down the prices, so it makes it a little bit easier to use.
Yes. Thank you. So we'll move to the next session on uvea. And I would request Dr. JB sir to introduce Hitesh. Dr. JB sir?
Yes.
Yes,
it's
sir.
my pleasure to introduce my UVA fellow, Dr. Hitesh Sharma. And he was a very hardworking, very sincere fellow. And we did work together on Swift Society in VKH. And this resulted in a paper. The Rajiv Brahman was there also with the paper. So I learned a lot of things from Hitesh regarding that Swift Society. He is now in charge, director of Sharma's Eye and General Health Clinic and Aditya Jyot Eye Hospital. He did it MSc in ophthalmology from Banaras Hindu University. And he is a very bright and upcoming uvea expert. With this small few words, I would ask Hitesh to present his case.
Thank you, sir. Thank you for those kind words, sir.
Shall I share your slides?
Yes,
or you...
sir. Sir, I'll try once.
Yeah. I will share it, Hitesh.
So one second. Sir, is it visible?
No.
Sir, again, the error is coming, sir.
No problem. I'll share it.
Okay, sir.
Yeah.
Thank you, sir.
No problem. Can you see the slides?
Yes. Thank you, sir. So I'll start off with my case. It's an interesting case which I had during the lockdown at Aditya Jyot Eye Hospital. Sir, next slide. So basically, a 35-year-old male came to me with complaints of pain, redness, blurred vision since a week from OD, and which was gradually increasing in intensity, and there was no history of trauma. So best corrected visual acuity in OD was hand movements, and OS was 6.9 with an intraocular pressure of 10 and 18 mm of Hg respectively. So this was the OD which showed severe circumciliary congestion, corneal haze, severe anterior chamber reaction with fibrin, dispersed heme and hyphema, and the lens details could not be appreciated. And this was OS, which was quiet with a broad-based posterior synechiae. So as fundus, there was no view from OD, and OS, it was quiet and very well normal. And so basically just seeing at the presentation, the differential diagnosis which I could thought of is like maybe endogenous endophthalmitis, looking at the severity of the inflammation, or maybe some uveitic entity looking at the other eye, and last but not the least, some masquerade. So the next logical step was the B scan, which I did for the for OD, and B scan showed absolutely no verticos, absolutely clear, and but slightly increase in choroidal thickness. So coming back to history again, the patient told that he had similar episode in the left eye 4 years back, and he was diagnosed to have endogenous endophthalmitis and was treated by with multiple intravitreal antibiotic injections and intravenous antibiotics also. So at that time, he was diagnosed with ankylosing spondylitis by the rheumatologist when he was tested positive for HLA-B27 by the PCR method. So again, he gave a history of similar episodes of alternating between both the eyes since last 4 years and lower backache since last 8 to 10 years. So now looking at the B scan and looking at the history, I started him on topical steroids 1 hourly and cycloplegics. And considering the severity of inflammation, I added oral corticosteroids 40 mg per day, and I reviewed him on the next day. So day 1 of follow-up, there was no improvement in his BCVA. IOP was normal with 10 mm of Hg. So OD looked like this. Cornea was slightly clearer, but the inflammation more or less was the same. And fundus, there was no view. So we did the B scan again, which showed absolutely clear verticose. So the patient had brought his old reports, and the MRI showed chronic bilateral inflammatory sacroiliitis as shown by the red arrows. And so continued the treatment on day 4th of follow-up. Again, there was no improvement in his vision, and IOP was 9 mm of Hg in OD. So right eye looked like this, but there was a fresh heme in anterior chamber as seen by the bright red color of the hyphema. But this time I could see the fundus view was little bit clearer, and disc was hazily seen. So investigations done were routine investigations, including the various uveitic workup was normal or non-reactive. Peripheral blood smear was normal. Blood coagulation profile was normal. Urine and blood culture, there was no growth. So continued the treatment on day 8. The BCVA improved to 618 with a normal IOP, and OD looked like this. So there was still trace hyphema, as you can see, and the photograph in the mid dilated pupil, you can appreciate the normal pattern of the iris, which was comparable with the other eye. And at this stage, I did the gonioscopy, and just to rule out any NVA or any NVI, which maybe I could have missed, and then dilated the fundus and looked for periphery and everything. So right eye fundus was absolutely normal and quiet. So continued treatment after 2 weeks, the BCVA improved to 6.9 with a normal IOP, and OD was absolutely quiet. So basically, it's a case of spontaneous non-traumatic hyphema in a uveitic eye. Spontaneous non-traumatic hyphema can be because of various ocular and systemic causes. So next slide. So spontaneous hyphema in HLA-B27 associated uveitis is extremely rare, and it corresponds and is secondary to breakdown of blood aqueous barrier and corresponds to the severity of inflammation. So basic take-home message is intense reaction and spontaneous hyphema can be seen with the HLA-B27 associated uveitis, can be easily confused with other differentials, especially endophthalmitis. So this case highlights the importance of history taking and serial photographic documentation, and favorable response with conventional therapy may help in creating an awareness of this extremely rare presentation of the most common known cause of acute anterior uveitis. So these are the photographic serial photographic photographs. This A was on the first day, and this was on the second day for the first day of follow-up B, and C was on the 4th day, and D was after 2 weeks. So I would like to thank the UVA department and all my seniors and gurus at Shankar Nethralaya. Thank you, sir.
Congratulations, Nitesh. I would like Kalpana to give some comments first.
Very interesting case, Dr. Hitesh.
Thank you, ma'am.
Can you hear me now? Can you hear me?
Yes.
Yeah. So very interesting case, Dr. Hitesh, and very well documented as well. Now, again, the approach is very nicely put. So whenever we see fibrin with a bit of hyphema, normally the first thing is you rule out, look at the posterior segment, and that's what you've rightly done. to rule out any other vitritis or end off. That's the important thing which we need to take. But considering his age, I mean, we are seeing more and more cases of bleed along with the fibrin. But what is interesting in your case is, I think the subsequent pictures which were there, initially it was like, blood mixed with fibrin.
Yes,
but then eventually it looked like a fresh heme, which was there.
Yes,
Yeah, that is something which is a little puzzling. So I'm just wondering if there was any new blood vessels which are there, very small, fine vessels, probably because of the ischemia, which could be there, especially because of intense inflammation related to the B27. So I think that is something which we need to keep in mind, because whenever we see hemorrhage in a patient with uveitis with so much of fibrin, there are three important causes. One is whether there are any new vessels which we are missing. The second one is, especially viral, it's more related to an occlusive vasculitis, what you have. So that is something which we need to keep in mind. And the third one is, as you rightly said, because of intense congestion, you can have a lot of leakage and diapedesis, which can cause that bleed. But what was interesting for me was that fresh bleed, which was there subsequently. That is something which I'm unable to explain properly. I mean, that can be explained only with the presence of new vessels or something like that. So that is something interesting in your case. But the age group, and I would also want to do a CRP in this particular patient.
Yeah, okay. Yes.
And that's very, very important, because that will guide your management hereafter in terms of systemic medications which he needs to be on.
Okay.
I just like to add that HLA-B27 mainly causes anterior uveitis. Fibrinous anterior uveitis, often with hypopia in about 10-20% cases. But there are HLA-B27 positive pan-uveitis also is described. Hitesh has done the correct thing to do an ultrasonography. And this could not be in endophthalmitis, because that other eye had previous history of uveitis and responded to that one. So endophthalmitis, once it come in one eye and then coming back to the other eye, is very unusual. After Hitesh told about this case, and I was whole morning, I was reading about that hyphema due to the uveitis. Virus is one of the causes, Kalpana told about it. But the HLA-B27 producing hyphema is extremely rare. I have not seen any case like this. Virus I have seen. So I read that book, I review article about 10 pages, and found only one corner it's written that the dilated vessels in the iris can cause hyphema in some cases. There's one single sentence was there. But you are very rightly, you have treated the patients with a frequent topical steroid. I sometimes give some patients oral steroid for a short course to get out of the fibrin for 40 milligram per day for 3 to 4 days or a week. So challenging case, and you well presented, and most of on the top of it is very well documented. Thank you.
Thank you. Thank you, Hitesh. And we'll go to the next presenter, Dr. Nitin. And I would request Dr. Kalpana to introduce him. I'll just go out of this 1 minute.
Dr. Nitin is one of the young, enthusiastic uveitis specialists.
Dr. Nitin.
Yeah. So Dr. Nitin is one of the young, enthusiastic minds in uveitis who we are increasingly seeing him more often presenting such interesting cases. He did his residency and post-graduation from PGI Chandigarh and a fellowship from Shankar Netralaya. And he has received Best Poster Awards in Uveitis Society and AIOS meetings in 2019. More so, I know him well because he comes up with such very good, interesting cases, gives a lot of thinking. And I'm looking forward to hearing this one as well. So over to Dr. Nitin.
Dr. Nitin, are you able to share, or shall I try to share, because you had shared the presentation? I have downloaded it. We cannot hear you.
Can you hear Nitin?
No, we cannot hear you. Are you muted? Can you just unmute?
It's called Nitin. What is the number?
Sai, can you unmute him? Because I don't see. Yeah, he's unmuted. No, we can just remove your, I think your
He's already
audio.
muted, doctor.
Yeah.
Rajiv, ask him to remove his earphones.
Yeah, earphone just remove and directly tell Dr. Nitin, probably that will work. Just remove the earphone and the attachment from your laptop connection. I think we will go to the next presentation and again come back to you. You can again rejoin probably, come out of the thing and again rejoin it. In the interest of time, next talk we can have your talk, and we'll go to the next cornea first talk, and then we'll again come back to Dr. Nitin.
Yeah.
Okay. Yeah. So we have Dr. Vardhaman, and I would request Dr. Rajesh Fogla to introduce Vardhaman. Dr. Arif?
Yeah, hi.
Yeah.
Yeah, Vardhaman is a very dynamic young ophthalmologist, and he has established his practice in Pune, and both as a corneal as a refractive surgeon. He has trained at Shankar Nethralaya and then gone on to further training under Dr. Palikaris, and he has several publications and continues to innovate and come out with new techniques in refractive surgery every year. So I think he has a very bright future, and we continue to see much more from him in the near future.
Thank you, sir. Dr. Vardhaman, please.
Thank you, Dr. Fogla, sir, for the kind words. And always, it is a matter of great honor to come back to Nethralaya family and meet all the friends and all the teachers. Just meet all the friends and all the teachers who have actually made a big contribution in all of our lives in ophthalmology and beyond. So thank you again. What I'm going to talk, I'm going to just present a small case of some small novelty innovation that we have done. Friends, we all know that SMILE is one of the relatively newer alternative in refractive surgery. One of the most common intraoperative complications of SMILE has been attributed as suction loss. If we look at the whole process of SMILE itself, the suction loss can occur at various stages of SMILE, including your posterior refractive cut, the side cut of the lenticule, the anterior cut, which is also known as the cap cut, and the least common has been the small incision creation because it is at the end of the procedure. I'm going to just show a preemptive small case in which this is the SMILE which is being done, and this is the refractive cut which is being done. You can see that there is a bit of tear meniscus being formed and possibly impending suction loss. So basically now we have the anterior cut, and this is the side cut. So basically the side cut was performed, and fortunately we were happy that okay, everything has gone in well. But when I gone in and I tried to open up the side cut, because I could still see the line of the incision, but I could not open it. And then I realized that if we go to the science of the femtosecond lasers, the femtosecond lasers typically start posteriorly and then they cut anteriorly. So in this case, possibly about 50% of the posterior cut was done, but was not really attacked, was not proceeded to its completion to the anterior epithelial side. So in that case, of course, I went back to the laser to see, and I could see that there was suction loss and there was a remnant laser ablation which was still remaining. So I went ahead again. I redocked the patient, as we know from the precision of femtosecond laser. In such situations, you can redock and recreate from the past uncut zone. So you can see that there is a small incision which just got created. So this was just last few pulses which were remaining still to be done. And now in this case, I could go in very nicely and I could open up the incision, and again the same scenario of separating the anterior lamella and the posterior one, going inside, dissecting very well, and then removing the a full lenticule to give good outcome to the patient. So this is what happened in that case. However, this was about 4 years ago, and recently we had this case in which it was a straightforward refractive procedure otherwise, and we had planned for the smile for this young lady who with 6.5 millimeters of lenticule, 7.5 millimeters of cap diameter, 120 micron of cap thickness. Again, in this case, I could see that possibly just during the second step, there was a bit of conjunctival tissue which started to intrude, and you can see some peripheral opaque bubble there. And I was still, actually, I still went ahead, because in certain scenarios like this in the past, I could create a small incision. Even 1 millimeter was enough to do the dissection and remove the lenticule. But again, in this case, because the suction was unstable and there was an intrusion of this conjunctival tissue in the contact interface, the small incision could not be created. However, in this case, the big difference compared to the last case was, in this case, all the laser had already been fired, basically because there was this conjunctival intrusion, which causes what is called as a pseudo suction loss. So I very well knew that the cap cut was complete, the lenticule was completed. The only concern was to gain access to the already formed lenticule. And that was a big question mark, how to achieve it. So there have been publications in which people have actually gone ahead and created with a 15 number blade incision, have gone inside and removed it, or created a small incision and opened with Vanna scissors and then went ahead manually and removed it. Of course, there have been publications which have looked at doing the surface ablation in this scenario, or the femtosecond LASIK flap about 20 micron superior to the primary cap. However, we looked at another option in which we all know that when there is a smile procedure and when we have to enhance, there is a circle software which is now FDA approved to convert the smile into a flap for enhancement for residual correction. So in this case, what it does essentially is that it will actually create like a junctional lamellar cut, like a donut kind of pattern periphery to the lenticule, and it will create a side cut for the flap. You have to just lift the flap, and then this is how you can do the ablation for enhancement. So this was one thing which came into my mind, but in this case, we wanted to use it to create a flap and then remove the lenticule in piece. So basically, which works like a flex. But again, the second thing was the patient had chosen smile. So we wanted to keep the small incision approach intact, and we also wanted to keep the flapless approach of the patient intact. So what we decided to do was that typically in circle software, as I discussed, this is the junctional lamellar cut, this is the side cut which happens, and this is about 270 degrees or 300 degrees of side cut for the flap to be lifted, about 50-60 degrees of hinge. So actually I decided to completely flip the parameters. So what we did was we actually decided to keep the hinge to almost 310 degrees. So instead of having this typical format of circle in which I create the side cut and this lamellar cut, we decided to actually have the hinge which was as big as 310 degrees, which left behind the side cut to be only 3 millimeters, which is very, very similar to what we have in smile. And these were the parameters I fed into the circle software. We redocked the patient, and this is how is the lamellar junction cut is done, and this was followed by the small incision creation. So this was an artificial small creation with the use of circle software. So I could go inside very well in the same plane very nicely. I could dissect the lenticule out. I'm going below now. and just making sure that the lenticle is nicely dissected also from the posterior side. Once that is done, it is very important in these situations that we actually take out the lenticule, put it on to the cornea to look at the totality of it, so that there are no tags which are remaining behind. So the lenticule was good, everything went on well. This was actually the photograph I have taken on the first day. You can still see this epithelial small, let's say irregular margins which happened because I tried to open up the small incision, which was not possible, of course, that time. And this is the lenticule which was removed in one piece. My small incision actually now, which was done with the circle, was somewhere here. And this is the OCD, which shows a very nice single plane of this. Patient fortunately achieved excellent outcome. And we have recently, this case has been accepted in JCRS as a case report this year. So again, thank you, Shankar Nethralaya, for creating our foundation and everything that we are today. And it was great to see all the friends and all the teachers back in SM. Thank you. Dr. Fogler, sir, I think you are muted.
Any comment from the other panelists regarding the case?
Yeah, can I make a quick comment, Rajesh?
Yeah, I think it's a very nice way to manage it. Just that you have to be sure that your dissection of the anterior and the posterior cuts are complete, because otherwise you make a side cut, and then if you cannot access the anterior and the posterior plane, you may have difficulty in dissecting out the lenticule.
That is the prerequisite. Absolutely.
Yes, you have to recognize at which point you have. So Vardhaman, from his experience, he could make out that yes, these two cuts are complete, and then you could venture out. Otherwise, I think to make the flap would seem to be a much more easier way out if you are not very sure.
Yeah, Rajesh, I think Vardhaman showed off a very ingenious approach in which he innovated the Circle software. So the Circle software is actually a wonderful software which gives you the ability to overcome these circumstances, this difficult circumstance. But he used it and made a smile of the Circle software. I really congratulate you, Vardhaman. Excellent.
Thank you.
Yeah, very interesting case, Vardhaman.
Thank you, Rishi. Thank you so much.
So we'll go to the next presenter, Dr. Rishi.
We can move to the next case. Yeah.
Yeah. Dr. Sujata, can you introduce him? Hello. Hello.
Yes. Hello.
Oh, I think Dr. Partha has to introduce. Dr. Partha.
Dr. Partha can do it, yeah.
I think he's muted now.
Yeah, no, for you, I will unmute myself definitely, and I'll be loud and clear for introducing you. Rishi Swarup, a great surgeon, first and foremost, as big as his smile. Rishi is the medical director and chief surgeon of Swarup Eye Center, Hyderabad, and with an MBBS from Kasturba Medical College, Manipal, diploma in ophthalmology from CMC Vellore, and a long-term fellowship in cornea from Shankar Nethralaya, FRCS in ophthalmology, and he's the honorary secretary of HOA and editor publications of Telangana Ophthalmological Society, section editor, Cornea, Indian Journal of Ophthalmology. Huge number of awards Rishi has, and he's a gold medalist, the Achievement Award from the American Academy, C.S. Rashmi Endowment Lecture, Hyderabad, IRSI Gold Medal, New Delhi, M.M. Joshi Oration in Goa, and orations in Hyderabad. Special academic interest is lamellar corneal surgery, and non-academic interest, nature lover, fitness enthusiast, and amateur photographer. I don't think he's an amateur photographer, excellent pro photographer. So Rishi Swarup.
Thank you so much. At the outset, I'd like to thank Dr. Mohan Rajan and the SN alumni for having me here. And thank you, Dr. Partha, for that generous introduction. It's really a privilege to participate in the alumni webinar. It's always good to come back to the alma mater in one form or the other. So I'll just get started with my case. Are my slides visible?
Yeah, they are visible.
Yeah. Okay, so this case, I've called it the masquerading dendrites, and I'll just show you why. So this was a 23-year-old male who came to my clinic with complaints of redness, pain, photophobia, and foreign body sensation in his right eye since 10 weeks. He was already being treated elsewhere on topical ganciclovir after being diagnosed as herpetic keratitis. And his vision in the right eye was 20/40, the left eye was normal. So this was his presentation. You can see that the eye had a dendritic kind of a lesion. And since the patient was already on ganciclovir, I at that time shifted him to topical acyclovir, hoping that that would be a little more effective. And 1 week later, after starting acyclovir 3%, this is the clinical picture. The dendrites seemed to have worsened, and the patient was quite uncomfortable, and I was also inflamed. I'm sorry. So we thought maybe this is a case of acyclovir resistance, and even decided to add an oral acyclovir and see. 1 week later, the nature of the dendrite and the clinical presentation of the dendrite changed again, and that's how it was looking. And another week later, again the dendrite changed its morphology. So this was a dendrite that was over 1 month had changed its morphology from one to the other to the other. So why was this viral keratitis not responding? That was the question. So we decided that we'll do an epithelial debridement and see if that helps. And after a few days, this is what the patient came back with. He came back with these subepithelial infiltrates, and you can see superiorly at that area, there's an area of a whitish linear infiltrate extending from the limbus centripetally. Basically, this was a perineural infiltrate indicating a radial keratoneuritis. So at this time, of course, the diagnosis as presented to us, and this was a case of acanthamoeba keratitis. We scraped the patient, and the diagnosis was confirmed as acanthamoebasis. Of course, we gave him anti-acanthamoeba treatment, and he quickly resolved, and he became very, very good in a very short time. He was left behind the small scar, which was paracentral, but with time that scar became quite light, and he eventually regained full vision. So what I wanted to share in this case was always suspect acanthamoeba in an atypical dendrite or a pseudodendrite, because acanthamoeba can masquerade as anything, especially viral keratitis. If it's atypical, acanthamoeba should always be at the back of your mind. And especially if you see a changing pattern of dendrites with time, be suspicious. And when in doubt, scrape. I should have probably scraped him earlier, especially because the dendrites were not typical. I didn't really see classical terminal bulb, but there was something like a terminal bulb also at some point. So I was unsure. I thought maybe because the patient was already on treatment, the presentation was atypical, and my thoughts were going more towards an acyclovir resistance. But I learned from this case that you can have a very dendritic presentation also with acanthamoeba, and of course when I went back and searched the literature, it had been reported. So I thought this would be an interesting case to share. Yeah, that's
it. that's yeah, Rishi, I've seen this case earlier that
yes,
you presented.
I know,
it's a really nice case to present, and it's quite common to see that sometimes when you just look at a pattern that resembles a dendritic pattern, you immediately think of viral infection and you quickly switch over to antivirals. And a lot of conditions can present with a similar dendritic appearance, sometimes even medication toxicity, or if you have some limbal deficiency, also you have stressed epithelium, they can often form these kind of patterns on the cornea. if you discontinue the medications for some time, just put them on lubricants and maybe a bland ointment at night. That can also sometimes help you understand,
the true clinical picture.
Yeah, the true clinical picture. And you did the right thing. You debrided it, because even if it's because of stress epithelium, sometimes when you debride and the new epithelium comes, the dendritic pattern usually goes away. Whereas if it's a viral infection, that may still persist. Yeah. Acanthamoeba is definitely a mimicker, and often the conditions are. I myself have had cases where I've thought cases to be atypical corneal infections, because patients often are on antivirals and steroids, and the clinical pattern keeps changing. So it was great that you could pick up the acanthamoeba diagnosis in this case and treat appropriately. Otherwise, I think if the acanthamoeba infection would have gone more deeper, it would have been more difficult to manage and would have definitely led to visual disturbance because of the scar.
Any history pointing towards acanthamoeba? Like
No history of trauma or contact lens use or anything like that. So that is why also this guy was a mechanic by occupation. So nothing really took my suspicion in that direction, and I actually missed the diagnosis initially.
What was the pain factor like? There was not much pain.
There was pain, but not excessive pain. He was not uncomfortable or.
I think the initial case, that the picture you showed didn't have that perineural inflammation.
No. It came much late. After I scraped the epithelium, then he came once the epithelium healed with that kind of a presentation.
Even in the initial pictures, the dendrites are not very typical.
No, they're atypical. So my thought was that he was already on treatment.
Resistant, yeah.
Yeah, so the dendrites are known to be atypical.
Toxicity also it can
exactly.
be. Yeah. But anyway, very interesting. So the only thing I've learned over the years is that if you see a patient who has been on antivirals for a long time and you see these kind of patterns, now I automatically keep acanthamoeba infection. I definitely actively try to look for it and rule it out when I come across such cases.
Yeah.
Thank you, Dr. Rishi.
Thank you.
I think, is any other comments, or shall we move to the next case?
We can move to the next case, yeah.
So our next speaker is Dr. Vinay, and I would request Dr. Sujata to just introduce Dr. Vinay.
Vinay actually looks very young to have such outstanding CV. And he has been a consultant at Shankar Nethralaya, LV Prasad, and now he's presently consultant at Giridhar Eye Institute. A fantastic surgeon, very good speaker, and very accomplished person. So looking forward to his talk.
Well, thank you, madam. Thank you for that wonderful introduction. I hope my screen is visible now.
Yes.
Am I audible?
Yeah, you're audible.
Thank you. So some of the cases, take us by real surprise. So this is one of those cases which I had to face. So 54-year-old female presented with pain on the left eye 1 week, uncontrolled diabetic. And this was the picture when she presented. There was a small corneal infiltrate in the infratemporal cornea. As with all corneal ulcer, we did a corneal scraping. Smears, nothing was shown in the grams or KOH. So we started her on combination antibiotics, and she was on follow-up. Culture again was sterile. Nothing grew. There was no response to topical medication. There was progressive worsening, and in about 2 weeks, it progressed so much that we had to do a cyanoacrylic glue to maintain the tectonic stability of the globe. Again, it worsened and it presented like this in within 3 weeks' time. A total corneal ulcer, near total melt, severe inflammation, bogginess of the conjunctiva all around, severe discharge. So at this stage, we had the therapeutic issue and we took her for a graft. B-scan was reasonably okay. This was the picture. I mean, surgical video. Now, what took me by surprise was after peritomy, this area, the supra, temporal area of the sclera was necrotic, severely necrotic. I had to debride that sclera and then this was just to mark what size of the graft should be taken, on the rest of the area. So after dissecting out everything, the lens could be preserved. The graft was marked, and then a freehand dissection along the 3/4 of the graft to fit to the area, and the rest was like the whole scleral frill was left to cover the area of the necrotic sclera, and it was sutured. So surgery was reasonably okay. Post-operatively, the patient did well. No recurrence, and he was started on steroids in about 2 weeks' time. Again, the graft did not, the microbiology of the button did not show any organisms and didn't grow also. So 2 weeks started steroids, and she did well initially, but then in about 3 weeks' time, the graft was severely edematous. There was a near total epithelial defect, and the globe was very soft. And B scan showed, as you can see in this one, choroidal detachment and all. So we started on Viceron 40 milligram, and eventually it settled. The choroidal settled, but the graft, the eye remained quite hypotonous with a normal B scan. At this stage, we counsel, I told her, probably this is a stage where we leave the eye as it is. Chances of visual prognosis practically not there, and your eye is probably going for phthisis. So the patient was lost to follow-up after this. And to my surprise, she presented after 6 months, and she had brisk PL, very accurate, pressures was around 10, and this was a picture. Failed graft, of course, but then reasonably okay anterior chamber, deep chamber, total cataract. I was very hesitant to do anything, but because the patient kind of persisted at something to do, we went ahead with a penetrating keratoplasty with a cataract surgery. This is how she was in a month's time. The graft was clear, and this is the ASOCT. You can see 2 graftose junctions in this case. This is the second graft, clear optical graft, and this is the scleral edge. She did well, and for the last 5 years, she has been doing well. And when I saw her in March, this is her eye, maintaining clear graft, with the 618 vision. Patient is, okay in terms of happiness, saying that, oh, vision is not all that right. But I'm really surprised at this outcome. I don't know, sometimes these cases do well, and very difficult to predict which one of them do well. So the take-home message is never to say, to the patient, never again, till you're sure that there is nothing else is possible. Thank you.
Thank you, Dr. Vinay. Any comments from the panelists?
Rajiv, Nitin is
yeah, after this
ready now. After this, you can put
yes,
Nitin.
Yes.
Okay, so go ahead with the...
Yeah, it's a very nice case. The only thing that I wanted to ask Vinay was, you did such a large graph. Do you expect some sort of limbal stem cell deficiency in the long run? Because it looked almost like a allograft. Yeah.
Yeah, it was around 12.5 millimeter graph. Yes, we do expect, but then surprisingly, in this case, everything is doing well for the last 5 years.
How is the fellow eye?
Fellow is absolutely normal. Early diabetic retinopathy, but otherwise normal.
So you can always take limbus from the fellow eye in case if you do have some evidence of limbal stem cell deficiency, you can do a autograft from the fellow eye.
2 things even now, what I don't have an explanation is, one is the limbal stem cell. Second is, even despite the fact that she has had a 12.5 millimeter graft, there is no secondary
rejection.
No rejection, no secondary.
Maybe she had some sort of ciliary shutdown, so that's why maybe the aqueous production itself is low. That's why you have not had a secondary glaucoma. So you got away with that. Other thing I wanted to quite surprise is that despite having so much of material, that you could not get anything on microbiology, neither on culture.
Yes.
So that is again very surprising.
The issue is very limited option for microbiology here. Okay, especially if people who are handling ocular specimens are very limited. So
Clinically, sometimes it looks like what has been seen with Pythium keratitis, kind of pretty extensive, large, but luckily for you, no recurrence in this case.
And it was kind of coagulative necrosis. Okay. So I'm not sure whether we can label it as a fungal Pythium.
Sure. PCR done. Try to do the PCR for the PCR.
No, sir. No. PCR was not done.
Vinay, could it be that it could have been leaking around the graft because you had a fairly large graft, and it could have been just leaking under the conjunctiva, and then maybe over time that got fibrosed?
Probably yes, but systemic steroids in a week's to 2 weeks time, it kind of settled. So
I would think of ciliary shutdown.
Ciliary shutdown is more likely
because of extensive inflammation.
Yeah.
Great.
Vinay, any reason why you didn't remove the sutures for 5 years?
Patient is happy. There are two grafts, clear, stable. I didn't want to touch it. That's the only reason.
What about the astigmatism?
3.5, I believe.
That's good in
But it's important you should remove the suture, because
it
if
will
she
reject.
gets again lost to follow up and she has a broken suture, you might again end up with more complications.
Yeah. Double-edged sword. But then yes.
Yeah.
Only other
Anyway,
thing,
nice
Vinay,
case.
in this case, I would have done a pupilloplasty also to keep the pupil a little small.
Smaller, yeah.
Yeah.
Stretch the pupil a little bit. Now the question is, Rajesh, just wanted to ask you, how was it possible to have a ciliary shutdown for such a long time? It's not, once the first graft, yes, possibility, but when you do an optical graft, usually the pressure starts building up. So
no, there was some scleral necrosis as well. So it's possible that not 360 degrees, but partially some part of the ciliary body must have lost the blood supply and it's not functioning very well. So the eye is maintained from the remaining production that's still happening. So the rest of the ciliary body may not have recovered from whatever ischemia it would have suffered.
And what was the last recorded pressure in IOP?
I think 12 millimeters.
That's quite okay, no? I mean,
Yeah.
I wouldn't really label it as a ciliary shock then, because it has recovered. Even if it has occurred, it has recovered.
With such large graft, you get peripheral synechiae, so the outflow is virtually blocked. And most of the time, we end up with secondary glaucoma in such cases. So here, the pressures are very well maintained. So one of the explanations that we could think about is the amount of aqueous production is slightly less compared to in a normal eye.
Can I just make a quick comment, Vijaya here?
Yeah, ma'am.
Yes, madam.
Yeah, no, you said that after the first surgery, you saw the choroidals.
Yes.
And are you sure that the entire choroidals resolved with the treatment over a period of time?
Yes, ma'am. Within a month's time, the whole choroidal settled.
What was the documentation at that point of time?
In terms of B-scan?
No, B-scan.
Yes.
Sometimes the peripheral choroidals cannot be picked up by the B-scan. And that was the reason that you had that picture of inflammation and hazy cornea.
Yes.
And she was lost to follow. When she came back, those peripheral choroidals also have disappeared. And the eye came back to what kind of the normal contour and the pressure. So that's the only thing that can explain, rather than the ciliary shock or other things. So, but like Rajesh said, I think there is some amount of damage to happen. The pressure is not going high in spite of extensive synechiae. That's working to your advantage. So the graft is remaining clear.
Yeah.
Thank you.
Thank you, ma'am. I think Dr. Nitin, if your audio is now on, yes. Can you again try to put your presentation?
Yes. Good evening. Can you hear me, sir?
Yes.
Am I audible, sir, now?
Yeah, you are audible. You can share your slide.
Am I audible?
Yes, you are
Yeah,
audible.
I can share screen also, sir.
Yes,
Yeah,
please
yeah.
do.
Are my slides visible, sir?
No.
No. Yeah.
Are they visible, sir?
No, it's
Just started.
starting.
I can't see them.
Yeah, it's coming.
Rajiv, you can share.
Let me. Oh, it has started. It has started.
It has started.
So good evening, everyone. So I'll be presenting this case. This is a. I hope it are visible.
Yes, visible.
It's moving very slow, sir, on my screen.
Rajiv, you can, I think, present.
Yeah.
Rajiv, we can.
Yes, sir. It will be better if you can, sir, share.
Sure.
Yeah.
Can you just unshare it?
Yes, sir.
Stop sharing.
I will share it now.
Yes, thank you.
Yeah, you can start.
Thank you so much, sir. Sorry for this technical glitch.
No problem.
So, next slide.
No problem.
So, my case is a 47-year-old male who presented to us with diminution of vision for last 1 year. The diminution of vision was gradually in onset, painless and progressive in nature, and it was associated with metamorphopsias. Patient had been complaining of episodes of foreign body sensation and redness for this past 1 year and was managed elsewhere with topical and oral steroids. This time he was advised immunosuppression due to recurrent episodes of inflammation and came to us for a second opinion. So this is the ultrawide fundus photograph of the right eye. His best corrected visual acuity in the right eye was 6.6 and the eye was quiet. So this was the involved eye, the left eye. At presentation to us, his visual acuity was 6/60. There were presence of some cells in the anterior chamber with flare, presence of a posterior subcapsular cataract, and we can see as comparison to the previous photograph, there was presence of vitreous cells, vitritis, and vitreous membranes. So yes, we can. So we were also thinking on the lines of intermediate uveitis and planned the patient for ancillary investigations on the same day. So we got a FFA done for the patient. Next slide, sir. So right eye was absolutely normal. However, the left eye, in the earlier frames, we can show that there is some vascular staining and leakage, which is more evident during the late phases. And the later phases, we can see that there was very much involvement of all the vessels with disc leakage and significant peripheral leakage with massive cystoid macular edema at the posterior pole. The OCT, the next picture, OCT of the left eye also showed massive cystoid spaces with subfoveal serous RD and subfoveal serous RD. So at this point of time, a diagnosis of intermediate uveitis was kept in the mind. Patient was already carrying these investigations. He was roaming from one hospital to another with the recurrent episodes of uveitis, and these were the investigations which he was already carrying. MAN2 was negative, VDRL, TPHA, whatever investigations could have been done, all the investigations were already available with the patient. So he was having this MRI also. So what were the previous uveitis specialist missing and what we could have also easily missed is seen in this slide. So yes sir, you can move. So when we had a look at the nasal quadrant of the fundus, we could see that there was presence of some active vasculitis, which is not clearly seen. And then these three hair-like things were floating in the vitreous. So we went back into the history and asked the patient about any specific episodes in the past. So he had already been complaining of these foreign body sensation and redness for last 1 year, which was not paid attention to. So he revealed to us that he had history of trauma to left eye with a caterpillar hair riding motorcycle about 2 years back, and there was the local doctor at that place had removed some of these hairs which were present on cornea and conjunctiva of the left eye. And following that, he was having this persistent foreign body sensation, and some records have also mentioned presence of that inflammation on the sclera. So keeping in this history revealed that the patient was having left eye caterpillar hair induced intermediate uveitis. So we went on with the UBM to look for any other hair in the eye, and there was no hair. Specifically, we looked for the ciliary body region. There were no hair. And after a short course of oral steroids, we took the patient, because now the diagnosis was very much clear that the patient had this inflammation due to the retained these caterpillar hair. So when we went ahead with the vitrectomy for the removal of hair after a short course of steroids. So we can see some areas of vasculitis in the nasal quadrant, and later on, after completing the core vitrectomy and peripheral dissection, we can see this hair. This was the one which was lying freely in the vitreous cavity, and it was easy to remove it with some form of scleral depression. Now we can see the second hair. This was somewhat embedded in the retina, and here we can see the hair being removed with the cutter, and we can see the third one. The third one is just lying on the surface of the retina, slightly lodged on the retinal surface. So with the help of the ILM forceps, this was just teased off the retinal surface, brought somewhat into the vitreous cavity, and then with the help of the cutter, this third hair was also removed. This was followed by a 360-degree peripheral scleral depression assisted peripheral vitreous dissection, and we specifically looked for any other hair in the eye. So we could not find any other hair in the eye, and all those 3 hairs were removed. So this is the post of 1 month. We could see that the eye was white, and there was resolution of the macular edema with regain of a good visual acuity of 6/18. So the basic thing which has to be kept in mind is to do a good clinical examination and listen to the patient and ask for specific histories in the past which the patient might find irrelevant. Thank you so much. I will acknowledge the team which I am working with currently at PGI. Thank you so much.
Thank you. Dr. JB sir, any comment?
I would like Kalpana to comment first.
Sure.
Kalpana?
It's such a very interesting case, Dr. Nitin, and with such an excellent recovery. And I should really congratulate you on your clinical acumen, because that's very important. And as you rightly said, we need to get the records, the prior records, very, very, very important in all patients with uveitis. One thing which I would like to just add for these caterpillar hairs are, though they are scleral or episcleral or in the cornea, they tend to migrate, and you need to keep a very close observation over at least a year even. And many of these cases which you would have seen in the cornea, suddenly you would be seeing it in the anterior chamber, and it is much more common in our country, at least in our part of where we are right now also, that these are so underestimated, and many of these patients are unnecessarily treated with steroids and immunosuppressants. So your clinical acumen is very, very crucial in dealing with these cases. Yeah.
Thank you.
Dr. JB,
Rajiv, I just wanted to show a slide.
Please,
the
please,
similar
sir.
case. I hope I can do that. Am I visible?
Yes, sir.
Slide. Okay. This is Dr. Mona Bhinde and myself and Dr. Tarun Sharma and Dr. Lingam Gopal saw this case. This is the ultrasound biomicroscopy was done in the management of pars planitis caused by the caterpillar hair. That time the intermediate uveitis was not told that pars planitis was the term, and this is the case. I just want to show you. This is the patient presented. He's a doctor actually from UP, and he had a recurrent uveitis, as Dr. Nitin has said, and it was persistent and not going off. Then when he did the UBM, we suspected something wrong with that one. The patient gave history of wiping the head with a wet towel underneath the tree, and there was a caterpillar. And Dr. Mona Bhinde elegantly detected the caterpillar, which is shown in the red arrow. The patient brought that caterpillar with him, and this is the photograph I took it, and this was published in American Journal of Ophthalmology 2000. So caterpillar here, that as this Kalpana has told, they can migrate and they can cause exudations in the pars plana region, inferior vitreous, and chronic intermediate uveitis is produced. So intermediate uveitis is not only produce autoimmune etiology, it can be TB, sarcoid, and can be parasitic or like this caterpillar here. Thank you. Stop sharing.
Thank you, Dr. JB, sir. Any other comments?
Anybody is that promote these?
I think one of the thing is those cases, I remember many of them had severe inflammation, membrane there, but this case didn't had only those vitreous cells and minimum vitreous inflammation. I think that was one difference.
See this, you see this here, slowly migrating, extremely difficult to peel out, pick up, because you have to, sometimes they are on a pars plana, sometimes going little bit posterior, and each one you have to just meticulously, you have to hold and pull out, otherwise they are known to come back with recurrence inflammation actually. This Dr. JB sir was talking about the patient. Actually what happened, his towel was like hanging, put for drying outside on the rope, and without he just pulled that towel and without realizing just rub his face with that and rub the things. We have another patient we saw in Calcutta. The boy was going on a bike and something just hit on his face and they didn't realize, and he was wearing helmet but no visor, and landed up having problem. Is almost 6 months. First 6 months intermittently, once in a while something redness, never realized till we pick up him after almost 6 months. So history is very, very important in this type of situation, and I mean, I would say very well manage the case. Otherwise, when you have to be extremely meticulous to each hair to pick up, keep on looking, you will have multiple subconjunctival, intrastromal, on a pars plana. Slowly they keep on migrating.
This is another hairy story. Put his photograph with Abhishek along with the three of them.
Great presentation, great case. We'll now move to the last oculoplasty, and I would request Bipasha to introduce our next speaker, Dr. Pratibha Devi. Bipasha.
Yeah. So Dr. Pratibha takes care of the oculoplasty division in MNI Hospital, Chennai, after completing her fellowship with us. She is one of the simplest, nicest, and kindest human being I have met in my life. Over to Dr. Pratibha.
Thank you, ma'am, for the kind words. Yeah. Can you see my slides?
Yes, Pratibha.
Yeah. At this outset, I would like to thank the organizing committee and my teachers for giving me an opportunity to present today in this wonderful webinar. So my topic is the enigma of a popping eye. So what to do next when we see a patient like this on a regular OPD? My eyes were actually popping out and didn't know what to do next. So SN was always there for a rescue. I called up my colleague and friend from SN and she guided me what to do next. So this was the patient who came to us with complaints of spontaneous subluxation of globe. She gave history of 2 episodes prior. She was a known case of thyroid. She had severe pain and blurred vision. There was no RAPD. So the next thing what we had to do was to do a reduction technique. I'm sorry, I don't have the video of that. So what we did was I held the upper lid of the patient firmly with my left hand. I pinched the upper lid upwards and then gave gentle traction backwards and downwards with my index finger of the right hand on the upper sclera. While doing so, I was giving firm pressure on the upper eyelid so that I was moving the upper lid firmly anterior to, so that the lid comes anterior to the equator of the globe. So, and then I gave a conservative treatment. This was post-reduction 1 week. The patient was completely normal. She had the extraocular motility was full. Her fundus examination was normal. Her field examination was normal. As she was a thyroid patient, we did a visa scoring and it showed an inactive eye disease. The severity was mild to moderate. MRI did not show any activity of thyroid eye disease. However, we could see a very shallow orbit of both the eyes with the globes almost popping out in both the eyes. So to summarize, our case was an obese, inactive moderate thyroid eye disease patient who was hypothyroid on treatment. She had 2 spinal surgeries prior and she had recurrent spontaneous subluxation of globe. To prevent further subluxation, I decided to do a simple lateral tarsography. And the tarsography is the procedure wherein we fuse the upper and lower eyelid. So the amount of fusion was determined preoperatively. I made an incision in the gray line and then dissected the posterior lamina. And then I fused both the upper and lower eyelid with non-absorbable suture. I used a bolster so that the suture doesn't cheese wire. So this is the immediate postoperative picture of the patient. This was 1 week postoperative picture after removal of 10 days postoperative picture after removal of the bolster. So to discuss, ocular subluxation occurs when the equator of the globe protrudes anterior to the eyelid aperture. The main risk factors are obesity, thyroid eye disease, floppy eyelid, and shallow orbits. The main problem here is the lax orbital septum and the canthal tendons, along with a shallow orbit, causes the globe to protrude out with mild manipulations. So what happens is there is exposure, corneal exposure, and which causes severe pain. And because of the stretching of the nerve, there can be traumatic optic neuropathy, there can be retinal venous congestion, and even vision loss. So how to prevent it? We have to avoid eyelid manipulations, avoid contact lens, reduce weight, monitor systemic thyroid levels. However, permanent measurements can, preventive measure can only be obtained by a surgery. The surgery can either be a lateral tarsography or can be a lateral wall decompression. Lateral tarsography has the advantage when there is an lax lid and when there is a lateral or a medial canthal tendon disinsertion. It is very simple and effective. It has an easy learning curve. It can be done by general ophthalmologist. It doesn't have any complications. The cons are sometimes there can be further subluxation even after the procedure, and then the reduction becomes very difficult. And it can be cosmetic blemish. And in my case, I did bilaterally. As we saw in the MRI, both the orbits were very shallow, and so the cosmesis was also not affected. Lateral wall decompression, it offers more space for the orbital contents. It gives more physiological retroplacement of the globe. Thereby, it's excellent for shallow orbits. However, it's a major surgery. It needs a general anesthesia and it takes longer duration and it involves risk. So to conclude, spontaneous globe subluxation is an alarming event. Immediate management is reduction with conservative treatment. Risk and benefit of both temporary and permanent procedures should be explained to the patient, and management should be titrated based on individual patient. I thank my teachers and seniors for giving me the opportunity once again. Thank you.
It's a nice case, Dr. Pratibha.
Thank you, ma'am.
Dr. Lakshmi, do you have any comments?
Thank you, Bipasha. Thank you, Dr. Mohan Rajan and SN Alumni for this opportunity. I think Pratibha has managed it very well. I just need to know if there was any form of subtle craniofacial anomaly. Was a three-dimensional CT scan done to see the orbital dimensions, whether that needed any kind of a correction? Because I'm not very sure whether a lateral wall decompression alone will help, because it will just add to further laxity. Would you agree about that, Bipasha?
Yeah, usually we do a great deep lateral wall decompression. We do not remove the lateral wall, and it gives a fairly good cosmetic as well as a permanent result. But as Pratibha said, this is a simple procedure, and if patient does not want a major procedure, then lateral tarsorrhaphy is a good temporizing measure in these cases.
In the circumstance, she has managed it very well. But are there any other anomalies or any other congenital issues?
Yeah, shallow orbit can be there congenitally. We have congenital cases in Apert syndrome, Crouzon syndrome. Those cases, they need a whole facial distraction surgery. It's completely different ballgame altogether.
I have a question. I had a patient who's known to me very well, and she's a family friend. And every time she had this, by the time she came to me after coming home, by the time she sat in the OPD, she herself got it put back the eyeball. And I didn't do any investigation looking at Pratibha's presentation.
Some patients present with excruciating pain. Probably your patient, the laxity is too much. She didn't have much pain. Or
it went automatically in. She herself put it back. Second time she said, she called me. By the time she came, she said at home itself she was all right. After that, we didn't do any investigation. Should we do anything? That's my question.
It's better to treat these patients because when the optic nerve gets compressed, they can go for permanent visual damage. So it's better to treat.
I had a similar patient. She had got so used to pushing the eyeballs back herself that the first time she came. Hello? Can you hear me?
Yeah. We can hear you, ma'am.
We can hear you.
You can hear me?
Yes.
I had a similar patient who used to come, who she came for the first time to the OPD, and we pushed it back inside, and then subsequently she got so used to pushing it back herself that she didn't want anything done, you know.
Those are the dangerous cases when they come to the emergency with visual loss.
Dr. Natarajan, my consulting room is next to yours. Next time, just send them across. And Karobi madam, I am also in Bombay. What is this?
Probably you've seen her, I think, once. I don't remember whether you've seen because she has come.
No, I know her name. I have seen her. Yeah.
Yeah. But what do you do? Nothing to be done?
Nati.
Yeah.
Yeah, welcome Achi to the SN Alumni webinar. Very nice to see her. Say hello to her.
Thank you, Pratibha.
Yes, sir. Yes, ma'am.
We will move to the next case. And Dr. Akshay Nair, I will request Dr. LM to please introduce Akshay.
Thank you, Rajiv. If I have to introduce Akshay, it's just one word. He's a superstar. He's really he's coming up very well in our OPI association. He's at his fingertips. He has beautiful videos. He's a good surgeon. He has a number of publications. He's in charge of our OPI webpage. Anytime and every time there's a discussion in our site, which is very active, he always, even here, he beautifully, when Rajesh was telling about Gimbal's article, he immediately flashed it for everyone there, the PDF file. So he's a real superstar. He has become a member of the APSOPers, and he has still a long way to go. At a very young stage, he has come up very well, and he has many more laurels to get.
Thank you.
Lakshmi, I wanted to add one thing. He just finished MBBS and came and worked with me before he came to Shankarnethalaya. He had 3 international publications in cornea and international ophthalmology and one more journal. I forgot what is it. But he's a great. Even today, I learned from him. And
article in Indian Express also.
Pardon?
article in Indian Express also.
Yeah. And he helped me as an editor in Indian Journal of Ophthalmology. And Rashmin, you have not done the help what you promised, man. Okay. Akshay is I told Akshay looks like Aditya Lakshmi. So immediately he's telling me, you give me the property.
No, he was saying, oh, you look like my son.
I thought you promised the property
that
for
in
me.
the will in writing. You put it in writing, then we'll talk about whether I look like your son or not.
Nati, you promised the property for me, no?
Yes.
Sir, you come in the line. After that, we'll see.
See how many claimants, Nati.
All right. So my topic is a little bit, not completely oculoplasty, but ocular oncology, which is an offshoot of, because oculoplastic surgeons tend to manage intraocular tumors, it is very, very closely related to oculoplasty. Retinoblastoma, I have a couple of cases. The first one is a 2-year-old male child who presented to us with a history of redness in the eye since 2 weeks. There was no history of leukocoria, strabismus, or any such thing. He was being treated locally by an ophthalmologist for uveitis. The anterior segment picture was this. Here we can see discrete, fluffy, white particulate matter settling at the bottom of the anterior chamber. There is some material also stuck to the endothelium. There we can see at 8 o'clock and 4 o'clock. The cornea is a little hazy, suggestive of raised IOP. The fundus, as you can see, there's a reddish hue and there was vitreous hemorrhage. So the B scan we did, again, it showed only vitreous hemorrhage, nothing else, no discrete mass, no calcification, no nothing. Retrospectively, when we saw the scan, we could appreciate some focal areas of retinal thickening. Now, in this case, I had a strong suspicion of retinoblastoma, so we advised the patient's parents about EUA and the possibility that later on we may need an enucleation. The parents, on hearing that, were lost to follow-up. They presented 9 months later. And this is how it looked like. The leukocoria now was a little better appreciable. But again, the IOP was 40 at this time. When we did an MRI as per protocol, you could see that there was a large intraocular mass. The optic nerve was thickened right up to the apex, including the cavernous sinus. And our protocol for diagnosing these patients, at baseline, we do a bone marrow and a CSF. Unfortunately for the child, CSF was positive for retinoblastoma cells. So the child was offered palliative chemotherapy and he succumbed within 3 months of treatment. But what do you do in a case like this when he presented at first? There's a pseudo hypopyon, the fundus has no view, there's no discernible mass on imaging, and the child has been treated as uveitis previously with no response. So all of these are strongly suspicious of what is a rare manifestation of retinoblastoma called diffuse infiltrating retinoblastoma. From SN, Dr. Vikas and Dr. LG sir have published a couple of cases and they have beautiful documentations of it. Here the tumor, instead of forming a discrete mass, grows in a horizontal manner along the retinal tissue, causing retinal thickening. And in these cases, you may see seeding of the anterior chamber or the vitreous cavity. How do you differentiate it from uveitis? There is no congestion, no pain, no synechiae, no cataract, and there could be associated hyphema. Iris may be studied with tumors, cells which look like iris nodules, but in these cases, you must also rule out other hematological malignancies. So there could be a presentation which looks like uveitis, but you need to have a strong index of suspicion to rule these cases out. My second case is a 5-year-old male who was coming for a routine checkup to a pediatric ophthalmologist. The parents had noted some slight squinting a couple of days before presentation. The pediatric ophthalmologist saw and called up and said, I'm sending a 5-year-old male child with unilateral retinoblastoma. Now, 5 years old for a unilateral retinoblastoma is slightly on the older side. And this was what the fundus picture looked like. And this typically looks like what a retinoblastoma looks after you have given chemotherapy for it. So let's have a closer look at it. What are the features that we can identify? Here, we can see clear, distinct margins with retinal pigment epithelium changes at the edges. We can see intratumoral calcification that is clearly visible with those bright white spots. We can see a large translucent intratumoral cystic space within. There is no feeder vessels, no prominent dilated tortuous vessels over the mass, which normally we would expect in a retinoblastoma. And finally, this appearance is called a fish flesh appearance, which is suggestive of a type 1 regression that we see in retinoblastoma after chemotherapy. We did a OCT passing through the cystic space, and we could appreciate that it was actually a clear cavitary lesion in the retinoblastoma, in the tumor, in the mass. On the B scan also, we could appreciate not only the calcification, but also the cystic lesion. So then my question to the parents was, when was the last chemotherapy? What treatment you've given? And they said, for what? There is absolutely no history of chemotherapy, laser, or any sort of treatment. The other eye was normal. At that same time, I dilated the parents were normal, the sibling was normal. And the reason why we did that, because this lesion is something known as a retinocytoma or a retinoma. A retinoma, the term was introduced by Brenda Galli late in the early 80s. And basically, it's a rare benign tumor. What you see, 4 characteristic features are presence of a translucent retinal mass, like we can see here. There is calcification, which we saw here. There are retinal pigment epithelial changes and atrophy at the edges. All the features, this tumor ticked all the boxes. So in what condition do we see this lesion? It is occurring only in 4 cases. A, sporadic. B, when the patient is apparently normal, and with apparently normal parents who have multiple children with retinocytoma. It can also be in association with a retinoblastoma in the same or a fellow eye. So you may have a large retinoblastoma that you've been treating with chemo, with laser, and in the periphery, you will have a small lesion that doesn't respond. Those non-responding lesions are retinomas or retinocytomas, or in the setting of a low penetrance retinoblastoma. So what do you do for these patients? Typically, literature tells us that you need to do an MRI to rule out a rare possibility of a trilateral retinoblastoma. You should screen them for RB1 gene. A lot of authors say that you treat them with laser and see at 2 weeks or 4 weeks whether there is any sort of increase in size, or you follow them up closely, because no growth is an indication that it's a benign tumor. Screen the siblings, and the last possibility is that there is a less than 4% chance that in the 2nd or the 5th decade, they could turn malignant and form a retinoblastoma. So these are key points. Retinoblastoma, or a benign version of it, can present in absolutely mind-numbingly different ways. We need to have a high degree of suspicion to make sure we catch them early and treat them in time. That's all from my side.
Beautiful.
Can I make some comment?
Akshay,
please. Can I make some comments?
Please,
Yes,
sir.
Sure, sir. Sure, sir.
The 2 cases has been presented. The first case is diffuse infiltrating type of the retinoblastoma, and UBM is one of the tests which could have been done, and that could pick up the tumors at the periphery in the iris, ciliate body, and peripheral retina. And then if that doesn't take out, then one can do an anterior chamber aspiration, anterior chamber tap, and do a cytopathology. And the diagnosis is very important for the treatment of the patient. Second case, I still think that it could be retinoblastoma. And because there's a 1% of the retinoblastoma undergo regression, in this spontaneous regression, and this could be the regressing type, spontaneous regressing process of the retinoblastoma. I don't think the retinocytoma is so big. Mahesh?
Yes, sir.
Can I make a comment over here?
Please.
It could be the other way around. These retinocytomas are generally purely benign, and sometimes because they originate from the neural crest cells, they start proliferating at later ages. That is why the presentation comes 5 years or later. So this could be a benign retinocytoma or a retinoma which has got activated at a later age. So this has to be treated, because otherwise it is active now.
And
PS sir, any comment?
A quick follow-up on that case was that we've now seen that child for 3 years, and at the end of 3 years, the child is absolutely stable. The size of the tumor, OCT, and we've actually recently done OCT angio also. The dimensions of the mass and the thickness are absolutely the same. So that mass has not increased. So it probably is, retinoma, retinocytoma. And literature says that, these are different terms for the same kind of tumor.
Why did you offer
Let us have the panelists, Lakshmi and Vipakra and Mahesh also.
Why did
Mahesh,
you
please.
calculation offered Akshay as a first for the first case? Before
No,
the
ma'am.
patient.
Enucleation was not offered. We had
sir,
discussed
good
that
night, sir,
this could
and
be
thank you very much,
retinoblastoma,
sir, once again, sir.
and the
Okay.
treatment options for retinoblastoma are chemotherapy, enucleation, and etc. etc. And that's when they latched on to the enucleation part, and I think that's what scared them.
And Akshay, I don't know whether you remember seeing the patient Rupali Ingle. Vishwas and Mahesh Shanmugam should remember. I think that's one mistake I think I done. It came as referred as an endophthalmitis. I did a vitrectomy, and during the vitrectomy I saw some snowy material, and I thought what it is, and I didn't realize. It was a Saturday. I remember I was practicing in '99 or something in Dadar, and I told send it for histopathology, and Saturday evening I forgot about it. Monday morning, JB luckily the courier reached, and I think he did the immediate histopathology, and he called me on an emergency, and he said, "What happened?" I said, "I don't even did you sweat a specimen? You know, how did you do a vitrectomy in a retinoblastoma?" I got a shock. I said, how did I do a vitrectomy in a retinoblastoma? And I think I sent the child, we started chemotherapy, and I think Mahesh enucleated it, I think. I hope you remember Mahesh. Mahesh, you have not published it.
Remember, yes.
And I think she's alive. We did a program with her 2 years back, and she was that time a sub-junior, what do you call that? Swimming.
Yeah, so she received radiation, and we've treated her for a contracted socket also. Yeah.
Yes, correct.
Thanks, Dr. Natarajan, for sharing with us. Next, we can move on to the last case of the day. Maybe?
No, we have two more cases.
Two more.
Okay.
Kirti.
So the next
Kirti
speaker,
and then Shreya.
Dr. Kirti Koka, and I am indeed fortunate to have her working with us in SM in my department, because she's a perfectionist and she is very hardworking. She's also in charge of our fellowship training program, and our fellows are very lucky to have her because, as someone said today, she leads by example. Over to Dr. Kirti.
Thank you so much, Dr. Bipasha, for the kind introduction. I'm just sharing my. Is my screen visible?
Yes.
Yes.
Okay. A very good evening to this large member of SN families here, and it's indeed a privilege for me to be part of this SN alumni meet. Today, I'm going to be presenting a topic of old wine in a new bottle. So this is a really interesting case of a 3-year-old male child who presented to us. So this child presented with a history of right eye proptosis for 3 months with sudden worsening for 5 days. So we were suspecting a malignancy and we did an imaging. But to our surprise in imaging, we didn't find malignancy, but what we found was a multicystic lesion with characteristic fluid levels, which helped us clinch the diagnosis of a lymphangioma. So then we started considering what are going to be our treatment options. So after considering all the options that we had, we decided to go with the current technique of bleomycin sclerotherapy. But we were really worried about the complications such as injury to the globe, optic nerve, or what if we inject the drug at an inaccurate site. To this, our retina colleagues came to our rescue, and they said that since they are really good at ultrasound B scan, they will help us not just localize the cyst cavity, but they will also help us by monitoring the position of the needle throughout the procedure. So now with some added confidence, we decided to proceed. We used bleomycin at a dosage of 0.5 milligram per kg body weight. We reconstituted it with saline, sterile water, as well as lignocaine 2%. The cyst cavity was first localized under ultrasound guidance. And once this was done, a 5 cc syringe was then mounted on a 22 gauge needle, which was introduced percutaneously into the cyst cavity, and we monitored the position of the needle on ultrasound. After this, the cyst was then aspirated. Post this, we retained the needle in the position, and we used another syringe with a loaded dose of bleomycin, and we made sure that we could see the injectate entering into the cyst cavity. The needle is very much inside the cyst cavity. So though bleomycin is known to induce inflammation, so we gave a short course of steroids to all our patients post-operatively to counter the inflammation. This is the same boy post 1 injection. And here you see him post 3 injections of 5 international units each. And you can see the excellent clinical as well as radiological response with complete resolution. We all know that lymphangiomas are hematomatous malformations which generally occur in the first decade of life. And as per the International Society of Vascular Malformations, they're called no-flow anomalies. The clinical presentations as such are very confusing, and the child can present with, say, a proptosis or a lid swelling, which can look like a neurofibroma sometimes, or a ptosis, diffuse mechanical ptosis. And sometimes it can be a cosmetic disfigurement or a retrobulbar hemorrhage, which can cause visual compromise. Bleomycin is a cancer chemotherapeutic agent which is widely used for treatment of cancer, but its use for the treatment of head and neck lymphangiomas has been proved of late. And this is a study from our center where we studied the effect of bleomycin in 13 patients, and we found an excellent response in all patients, but here ultrasound was not used. Most of the image guided studies that we see use fluoroscopic guidance, which uses CT arm, and this exposes young children to radiation, which is not ideally suitable. So if you see in our technique, we use ultrasound, which helps then avoid the use of exposure to radiation. Intervention radiologist is not required, thus reducing the cost for the patient, and has excellent results as can be seen in some of our patients. Thus, what I would like to conclude by saying is that though lymphangioma, ultrasound, and bleomycin are age-old clinical entities which are known to each and every one of us, this combination of old wine, which is put into a new bottle and presented, is a very safe and cost-effective technique which gives both functional as well as cosmetic improvement in all patients with lymphangioma. I would like to thank all my colleagues in Shankar Nethralaya and all my seniors present here for giving me this amazing opportunity. Thank you.
Very nice.
Thank you, Dr. Kirti. Anyone has any questions or comments?
Actually, Bipasha, I would like to say, Pratibha presented a similar one, lymphangioma, 2 weeks back in a TNOA symposium in a webinar. Is Pratibha there around there? So I was asking the question to her also at the same time. So what is the gauge of the needle, and how do you know exactly when you're aspirating whether you're inside the cyst wall?
Sir, so we usually we do it under ultrasound guidance for all our cases now. We have about 35 patients who we have done it under ultrasound guidance, and that we use a 22 gauge needle because the needle length that way is safer in 22 gauge, and it also has enough of a bore size to help in aspiration. And the ultrasound probe is placed on the globe, and we keep monitoring the passage of the needle starting from the eyelid all the way into the cyst cavity. And only when we know we're in the cyst cavity do we start aspirating. And sometimes when we're going close to the globe or closer to the orbital wall, our ultrasound, our retina colleagues inform us, and then we retract our needle direction to enter into the cyst cavity.
Good. Very nice.
Very good presentation. And how are you sure that every case is a lymphangioma? What if there is a hemangiomatous component? When you blindly stick the needle, you may blood coming. So
we
many a times lymphangioma as a AV malformation.
Yes, ma'am.
How are we sure that it's lymphangiomas unless there are those telltale signs?
Yes, ma'am. So we go by the radiological diagnosis one. Number two, all the aspirate fluid we send for cytological examination also. And so Dr. KK usually helps us in identifying that it is fluid of a lymphangioma cyst. And also yes, ma'am, we send. And then also with bleomycin, if we don't see a response after the first injection, then we rethink if the diagnosis is different. So in case of doubt, then we do not do the procedure. We have one patient who had a case of doubt, and so we did a biopsy first. But most of the other patients where the diagnosis is clear cut, we go ahead with bleomycin, and they generally respond very well with the first dose of injection itself.
Kirti, a small question.
Dr. Lakshmi ma'am.
How do you
these people in
1 minute, 1 minute.
One second, Akshay.
One of you can talk.
Dr. Parohi, yes.
I just had a small question. Is that when it is ultrasound guided, how do you place the ultrasound probe in the opposite quadrant at a slight angle?
Yes.
Okay.
And so we position ourselves such that because for person doing ultrasound, they need to be on the right hand side of the patient because that's when it's convenient for them. So they stand on that side with the probe lower on the eyelid, and we stand at the head end of the patient and we inject our needle from that side. So both our hands don't clash.
Okay, thank you.
Great case.
Yes, Akshay, you were saying something?
No, I was telling LM ma'am that the people in SN oculoplasty have one thing that both of us don't have. They have a radiologist who can give reports like as if it is histopathology.
Yes.
Dr. Veena Norona, she
Yeah.
is so good that she can see the the MRI scan and tell us what the histopathology is going to be.
I think
So that is something we don't have.
most of the time we know the diagnosis even before we can start, thanks to her.
So my only question is that a couple of times I've had cases that eventually responded to bleomycin, but after the first or the second injection, there has been a hemorrhage, and I've seen a like a worsening of the proptosis or the lid swelling.
We had it.
What do we do in those cases?
We had it for our initial few cases. So, and then we realized that bleomycin as such can induce a lot of inflammatory reaction. It was pretty frightening actually in the initial stages. I remember it was the first few cases when during my fellowship days, and child had such a increase in amount of proptosis. So that's why now routinely we apply a tight pressure patch, at least from if we do the procedure morning until evening, and we give all dexamethasone when the patient is in the hospital, and post-op we at least give a 2 weeks of short course steroid. So this helps control the inflammation quite a bit.
Oral steroids.
Yes, oral
I would say macrocystic lymphangioma is now going in for a microcystic. You have the macro, intermediate, and the microcystic. The morphology is changing, so that it is densely packed now. The tumor is growing again. You know that it's a very cranky tumor, cantankerous tumor. It tends to regrow and grow until the third decade or fourth decade. So now at this stage, if bleo is not working, you will have to go for debulking.
Yes, ma'am. And sometimes what we have noticed is even microcystic lymphangiomas, bleomycin works initially, and after a point it doesn't work. In fact, the lesion becomes very fibrous, and eyelid lesions as such, they become very hard, and then you have to go in for debulking. But that is easier to debulk than a fully cystic lesion which is not fibrous.
Kirti, would you consider injecting dexamethasone or some steroid along with your bleomycin?
Yes, Karobi. Before we had bleomycin in our hand, we were giving a lot of tricot, triamcinolone, dexamethasone. Yes.
It will have the same possibility of complications as any intralesional corticosteroids like CRAO. So if we knew that it really works, then we would. But bleomycin works just as well, so we don't.
Yes.
Go on to the final case, Rajiv.
We'll go to the final case, and that would be Dr. Shreya Shah. I would request Dr. LM, please, ma'am, if you can introduce Dr. Shreya.
Okay, Shreya is another very upcoming and well-known entity now in the west of India for orbit, oculoplasty, trauma. She is none other than Dr. Mehul Shah's wife. Mehul, as you know, they both head the Drashti Netralaya in Dahod, Gujarat. They offer fellowships. In fact, they are internationally known now for the work they're doing, and a lot of charity work they do. And Chief himself has gone there along with Madam, and they were all praised for their setup there. So Shreya is presenting cases consistently of late, and she has a lot of publications as well.
Thank you, ma'am.
Yes, Lakshmi. I think I also went to as a Ocular Trauma Society president 2 years back to Dahod. I think everybody should visit. I don't know whether you know that they have dedicated their life for this NGO, and they also decided not to have children, only to make sure they run ophthalmology. Correct, Shreya? Shreya?
Yeah, thank you, sir. Thank you so much. Correct, sir.
Very nice.
Can I share my screen, sir?
Please go ahead, Shreya. Sorry for the delay.
No, that's okay, sir. That's fine.
Gujarat and Mumbai, only meeting starts, man. Mohan. Gujarat and Mumbai, no? KROB is becoming fresh now.
I know. Her practice starts now.
Sir, Gujarat is dry state. Don't say anything like that.
I'm grateful to Dr. Mohan Rajan sir and SN Alumni just to be reconnect with the SN Alumni meet. And I'm grateful to LM ma'am also for introducing me. So I'm just going to show some of the innovation in canaliculostomy. And canaliculus can be ruptured by direct or indirect laceration, and can be a can have lots of consequences along with it. Primary repair is at most important. It should be done within 48 hours of the trauma, and you need so many things for that, like controlled OR. The first thing is we have to look for the location of cut severe and of the canaliculus lost end by inspection, but sometimes it's not possible. If you are able to see flaring gas ring reflex, it's better. And then if not, then we have many solutions like fluorescein dye. We can do that. Second step is confirmation by railroad. Third is stent placement, and fourth is suturing. We all know that. Mini monoca is very standard technique which is used since long days. It has got its good advantages, but it's quite costly. So the cheaper option was a Teflon sleeve, and we are just using the Teflon sleeve of IntraCare. We are just making it as a stent placement, and then after confirmation, if patient is adult, we can confirm on table, and then pericanaliculaar suturing can be done. But this technique also has some of the advantages, like it can be done in upper canaliculus also, but disadvantage like you have to fix the knot outside, and then it is very cheap also. It is very easily available in OR, but it creates local inflammation, and most of the Teflon sleeve gets extruded because it's not in inert material. The then thing comes is a pigtail probe, which is very, very thick. The thick metal of it sometimes injures the non-injured canaliculus too. So its design is such that it has got very thick metal probe. And the most important and difficult part in canalicular laceration repair is to find out the cut end of canaliculus which is lost from this mass. And here is the case. Very next day of cataract, patient got injured. Still the air bubble is there in the eye. So we can, if I'm not able to see flaring gas ring reflex, we cannot just do all the solutions fluorescein dye. So the idea came in my mind during that time only. I just took 4O proline needle. I just cut it by a mosquito forceps. We have amrystone, amrystone in our OT. And then I just made that cut tip of the needle blunt by rubbing on the amrystone. So I just made it blunt on table. And after that, I just assure that it is properly blunt and it is not now non-traumatic. So I just holded it with card needle holder, and that is become another pigtail probe. I just tried to pass. Initially, I had difficulty because I was pushing. But then I came to know that I need to have counter pressure and don't have to push. Let the needle guide us. And then to our surprise, the needle really came out. Once I applied the counter force and softly I passed, the needle came out of the cut end of the canaliculus. So here it served two purposes: finding out we can see flaring gas ring reflex how the needle is coming out. So here it served the two purposes: finding out the cut end, and as it is a proline suture, the stent material was ready. So you don't have to put another stent material along with that. And that same thing we passed through the distal cut end, and then we tied. This similar technique we used in children also, but I used 6-0 proline in this case, and same way we passed, and we could find out the cut end of canaliculus. So it is cost effective, easily available, easy technique, less learning curve, surety of finding the case, and done same procedure in 10 eyes, and it was published in German Medical Science also. But it also has the flaws, because the knot of the proline creates the initial epiflora corneal aberration. Sometimes the proline is very strong suture, so sometimes shaving off of the roof of canaliculus can happen if patient drops, and also infection. And it was difficult for post-traumatic strictures. So this newer technique developed, newer material developed. This is Drashti canaliculostomy silicone intubation set. It is already patented and it comes in 3 different sizes. So I just use the same technique, but there is a silicone tube along with that. So the same needle design we have used, and I've done in this around 20 cases after doing this. So this case I am using for a secondary stricture case. So first I dilated, made the canaliculus proper. After confirming with the railroad technique, the probe was in the canaliculus and in the sac. And then we use the same technique with silicone intubation. Initially it was little difficult, but then once you do properly, it can be done. So it comes with the tip, ready-made tip, which is blunt. The same way we passed and it came out from the upper punctum, and then we can pull, and then we can just suture the canaliculus and we just slide the knot in the canaliculus, so it's not now irritating. It has got all the advantages of all other techniques, plus cost effective and very easy to use, and it can be used in lead aversion too. The similar technique we used in children also, in child also, and that we use 27 days. Postoperatively, systemic antibiotics, steroids, and syringing also we can do along with the tube inside. So in adult, we can confirm the patency too. It has got little disadvantage that if not used skillfully, it can create the false passage, false anastomosis, cannot give confirmation of surety of the right passage when both the canaliculi are injured. But of course, it can be used secondary to create the new passage when both the canalicular strictures are there. So just to avoid, and it has got some complications like cheese wiring, ocular irritation, infection, which can happen with any other technique. Most important was false anastomosis because of little bit only blunt tip. So we came up with the design new, which is olive tip, blunt tip needle and silicone tube. Because of lockdown, we are not able to get this. We have already ordered for that and it is coming. Thanks to my patients. Have a happy patients. Thanks to my teachers. Thank you all.
Wonderful.
Wonderful, Shreya.
Very innovative and nice, Shreya. But I'm wondering, after Arvind brought out their monocanalicular stents, it's extremely cost effective and it is a really nice one. I've used the ones from FDC, I've used the imported ones, and about 30 years back, when I used to assist Dr. NS, we used to get those, like bugris, that is the tops which we play, that kind of a wooden plank we used to have, and we used to roll elastic tube in that and unfurl it, get it ETO sterilized and then use it. We were doing all kinds of gimmicks then, but after this has come, it's extremely affordable. Why do you say it's because what happens with this monocanalicular stent, especially from the Arvind eye group, is that it confines to the dimension of the canaliculus and stays there. Unlike you yourself mentioned, proline is extremely irritable. So your technique of finding the other end is extremely nice. But I think you should consider, and I'm sure for your hospital, please forget the COVID times, there'll be a lot of grants and all. I think you should use monocanalicular stent.
How much it is costing, ma'am? How much it is?
It's less than 3,000 rupees.
That's what, ma'am. The 3,000 in one patient in a rural area, it's too difficult. Here, this is the technique. With the same tube we can use in.
Shreya, can you just stop sharing the screen?
Yeah. So also, FCI last year has reduced their cost per unit. So if you buy a pack of 3 mini monocas, that comes to 5,100, which equivalent is about 1,700 per patient. And this is not
Yeah, it's not only.
Presenter should stop sharing the screen.
Yeah. It's not only cost effectiveness. Here, my idea is to present to find out the cut end of canaliculus, which is the most difficult part for everybody. Mini monoca comes when you are able to find out the cut end. This technique itself is finding out the cut end of the canaliculus, as well as it works as a stent. That was the purpose. It's not only cost. It's
Shreya, I have two
easy to
questions for
find
you.
out the end.
Shreya, I have two questions for you.
Yes,
Very
ma'am.
nice presentation, very innovative
Nice.
technique. But my questions are such that the cut end, can't you do it with injection of fluorescein or brilliant blue into that? That is question number one. And second is that would you do the same kind of surgery for dog bites, which generally children have when they have these cut canaliculus? Because generally they have to have these injections of immunoglobulins in and around the bitten site. So how would you handle those kind of cases?
Yeah, the question number one is using any liquid like BSS or methylene fluorescein blue. In my case, it was second day cataract post-op, so it was out of question. I could not use. That's why the idea came. It was possible, and sometime if you just color the area, it becomes more mass, and you are not able to find out the cut end easily. The second thing, what you said in dog bite, we had in last ocular trauma conference, Dr. Natarajan sir said that we had a debate for dog bite immediate repair and late repair, and I was presenting immediate repair. So I usually do the same technique with immediate repair in the dog bite.
And then you'll give the injections also over there.
Yes, yes, ma'am.
Very nice. Superb.
Thank you, sir. Thank you so much.
We got the best for the last.
Thank you, sir. Thank you so much.
Really,
Thanks
seriously.
a lot, sir.
Fantastic.
No, Dr. Mohan Rajan, sir. Now, automatically that means oculoplasty will be first in next alumni.
Done.
Because you are the best, no? You are the best.
No, we keep the best for the last.
Yeah. You are always the best.
Best for the last or worst for the last, I don't know.
No.
Akshay, you'll be
Best for the
second
last.
because trauma will be first.
Not only Shreya, but all the presentations of oculoplasty was simply amazing.
Amazing.
Thank you, sir.
Yeah,
Thank you so
your
much.
retinoblastoma and Pratibha's case and also Kirti's case were also fantastic.
Mohan, what about this audience?
That audience is the best.
Yes.
Mohan, she's telling she can do better surgery now.
Namaste, Mai.
No, Rajiv.
Yes.
Let's have a final word from Rajiv.
So before the final word, I thought that we can request Dr. Girish to give some updates about SN. I think it's a SN alumni meet, and we have all the alumni who are there. So I think Dr. Girish can give some updates about Shankaretralaya.
Hi, Rajiv. Thanks for the last minute edition. I won't keep people waiting from their dinner any longer. So it said that there are friends, there is family, and then there are friends who become family. So SN is proud to have such a wonderful alumni who are an integral part of the SN family. And it is also said that nobody is bothered about an institute more than its alumni. And I'm sure all our alumni would be eager to know how SN is coping with this pandemic disruptions. So in one word, if I can say that we are trying to scale up our teleconsultation in its true sense. And yesterday, we launched a joint initiative with Titan for teleconsultations at Titan outlets across the nation. So we have SN-trained optometrists who will be working up patients at these Titan stores. And the consultation would typically consist of a refraction, slit lamp photography, applanation tonometry, fundus photography. And then the teleconsultations will be provided by our consultants who will be using either their laptops or smartphones with access to all the patient records, which is being integrated with our SN TCS EMR platform. So it will be a seamless integration. And with this, we hope to reach out to our patients who are finding it difficult to come to our centers now. And now here, I see a role for our alumni, because we'll be only able to provide a consultation, but if they need any minor procedures or any investigations, we will be asking these patients to follow up with our local alumni there, so that part of the treatment can also be completed. So we complete a full loop there.
Yeah, correct.
So I appeal to all our members to continue to serve the alma mater in action and words. And let us take this vision of our beloved chief to provide quality eye care to every nook and corner of India. Already we are doing it through our MISU. We are taking surgeries to the doorsteps. With this, we'll actually be taking our consultations also right to their
Doorstep.
where they stay. So in the end, it is good to see you all. Stay safe and healthy and take care of your near and dear ones, especially the elders in the family. Good night.
Great, great. I think this is what I have addressed a month back to the optometry webinars, and I told them we should have a teleophthalmology, teleoptometry hybrid model, and I think you're doing it, and in Mumbai also we are doing. But I think, as you rightly said, all alumni all over can help this so that the patients are helped finally. And I think it's a great idea. We should promote that. And I keep telling that in all the webinars that how Chief started a Elite School of Optometry in '85, and All India Ophthalmic Society also was objecting, and it actually came to the general body, and then Chief stood up, and finally I think it's going well. Similar thing happened in between, and I think now again in India we are having a good rapport between optometrists and ophthalmologists. So thanks to again Chief and you and Netralaya for promoting that, and I think we promote that all the time.
Thank you. And I think we are coming to the end of the program, and this program would not have been possible without vision of Dr. Mohan Rajan and Dr. JB. I think both of them, they made this program possible. A really good mix. We had all the subspecialties, remembering again all our grand rounds, which we used to have, and definitely it was a great learning which we had in this evening. Also like to thank Mr. Sai Krishnan from Numerotech, who made possible all the audiovisual platforms, the Facebook, the YouTube, and most important, all the panelists and all the speakers who were the pearls of the day, and they could make the day a great learning experience for all of us. Very good night. And
just want to add one thing.
Yeah, please.
I want to add anything.
Please, please.
I like to thank Rajiv for anchoring such a nice meeting, and also Mohan to give enough time and such a good meeting. We have got good panel discussion. We are not in a hurry. So each case was discussed in very detail. It's really the academic height we have reached, and I'm really so happy.
Maybe just a quick comment from my side. I think what is so impressive about it is because you have chosen the cases, so that kept everybody's interest. Yeah. Otherwise, people will give lectures and you lose the interest.
Correct.
Second thing is, what is really, really appealing is just on WhatsApp group, Mohan was able to collect all the information and coordinated everything. Excellent, Mohan.
Thank you.
I never thought you can do that just on the WhatsApp without depending upon the mail. Thank you.
Not to forget the catchy titles. They were really good.
Yes. And also the anterior segment guys still who presented first are still around till we oculoplasty and retina guys presented. So that's
why we presented first actually. We were worried that people will present and run away.
Partha came a little late. Partha, I wanted you to say a few words.
No, but the anterior segment guys presented, went off to their other webinars and came back.
Akshay, that is the versatility of anterior segment guys, and special versatility because they were first VR surgeons and then they surfaced to anterior segment. That's what Mohan is
also. Posterior segment people also did that. Nati went for 2 webinars. I went for 1 meeting and came back.
I had my dinner.
Yeah, Dr. Natarajan in between was it one webinar. We could see that he was.
Let us not discuss what all we had on the Saturday night. We'll just say good night and end it.
But I think Rajiv, the best thing is that
thanks to each and everybody. I think it's been a marathon webinar with more than 37 faculty, which is, I think,
fantastic.
The highest number.
Yeah.
Number.
Fantastic.
So, like seamless, streamlined arrangements. Really, really good, Mohan.
Thank you.
Everyone can unmute and give a huge round of applause.
Rajiv, thanks a lot, Rajiv.
Thank you.
Mohan, I suggest we should do
Congratulations,
again,
Mohan.
again one more 3 months later.
I think every year we will have only webinar.
No, ma'am.
Months later,
Next year we have to strongly pray that we meet in Chennai.
Absolutely, we are meeting.
Yeah, but I think 3 months later webinar is
3 months later we'll have one more. Yeah.
Okay.
Congratulations, Mohan, Rajiv, and JB.
Yes.
Fantastic job.
So 3 cheers for SN. Hip hip hooray.
Hooray.
Hip hip hooray. Hip hip hooray.
Good night.
Good night.
Good night, everyone. Good night.
Good night, ma'am. Good night. Thank you.
Great.
Thank you so much.
Bye, Vijaya.
Good
Bye
night.
bye.
Gail, my sweetheart is sitting next to me.
Yeah, I know. She's a real
Say
sweetheart.
hello to Achi.
Huh?
Achi is also one of the SN alumni members.
I have photographed with the chief and Achi in the SN alumni meet, one of the meets.
Definitely a better student than you.
That is Mohan humor here.
Okay, good night.
Good night.
I invite all of you to come
Bye.
to Dahod whenever lockdown opens.
Shreya, we come to Dahod and we'll go to that temple.
Yeah, we can't forget it.
Thank you. And you remember the incidents also happened.
Yes.
Really, God said, give us a new birth.
We went to Kali temple and got stuck over there.
I invite all of you to come to Dahod whenever lockdown happens.
Thank you. Thank you.
Sai from Neuro, you can come on the screen, man. Sai,
Sir, it's me. It's Dr. Yes, sir.
not you. I
It's
told
my initial, which was given to me in SN. So I logged in with my initials only. With that Sai in the IT field.
but the other side is there, neurotechnology.
He's also there, sir.
Yeah. Good. Thank you all. Thank you.
Thank you. Bye-bye.
Thank you. Thank you, everyone. Bye-bye.
Bye-bye. Thank you.
நான் சாய் ஆச்சி உட்காந்துருக்காங்க பாத்தீங்களா?
பார்த்துட்டு இருக்கேன் டாக்டர்.
நம்ம சொல்றதெல்லாம் பண்ணுவாங்க. என்ன ரஷ்மின்?
அவங்க
இல்ல இன்னைக்கு நல்லா முடிச்சிட்டு இருக்காங்க காலையில இருந்து.
ஓகே.
ரஷ்மின் ஆச்சி அங்க பாரு அவரு மொட்டை பாஸ். Okay, Rashmin, we should do something like this for teaching here, which somehow I will talk later.
Sure, sir. Sure.
Right. Thank you. Thank you, Sai. Wonderful.
Thank you, Dr. Good night.
Right. Good night.